Okay.
You can record it to computer.
Yes.
Then you can upload the meeting at
Yeah. Yeah, I'll
in the
just do
Google
all
Drive
this.
and
Yeah. Okay, I'll do today. Okay, yeah.
Good.
Okay.
Thank you.
So now the lipid transport, we're going to study how these lipids travel inside your body, how they get absorbed. Okay. So you should know that there are two types of lipids or fats found in your body. One are the dietary fats, and second, and those that forms in your liver. Okay. So first of all, let's talk about how these dietary fat and cholesterol absorb in your body. So as soon as you ingest this fat in your body and the cholesterol, what happens is they found in some micelles, as you can see here. You remember the bile salts, they will break down into micelles, into smaller fat molecules, and they will absorb in your intestine, as you can see here. Now, what happens is in your intestinal cells, they're found this chylomicron thing, okay, which are the lipoproteins, the chylomicrons, okay. The chylomicron then uses its receptors, which are, you can see here. These are the receptors that are found in the chylomicrons. These are the apolipoprotein E, the apolipoprotein C2, and the apolipoprotein B48. Using this B48, the chylomicrons actually absorbed into the lymphatics. As you can see here, the intestinal cells, the chylomicrons uses the B48 to get absorbed in the lymphatics. And finally, after entering the lymphatics, they enter your subclavian vein into the venous system. In the venous system, when they enter the blood, they meet with these, with these HDL particles, which are the high density lipoproteins. Now, these high density lipoproteins will share their apolipoprotein C2 and apolipoprotein E to the chylomicrons. And now it contains the apolipoprotein B48, apolipoprotein C2, and apolipoprotein E. You should know these. The thing about this apolipoprotein C2 that it contains the activator of this lipoprotein lipase. Your lipoprotein lipase requires this apolipoprotein C2 to function. Now, as soon as it reaches a cells like your fat cells, the lipid cells, what happens is this lipoprotein lipase get activated, and you should know the location of this lipoprotein lipase, that it's found in your endothelium of the blood vessels. Very important part, it found in your endothelium of the blood vessels. So after activating, it will break down the fat in the triglycerides. These things, the triglyceride, it will break down, it will release the free fatty acids into the circulation. And finally, the free fatty acid can be absorbed into the adipocytes, as you can see. And now this chylomicron, after losing lots and lots of triglyceride, will become the chylomicron remnant. Okay, and you should know that this apolipoprotein C2 will stays here with the lipoprotein lipase. Very important part. So now the remnant will contain only this apolipoprotein B48 and apolipoprotein E. And you should know the fact about this apolipoprotein E, that it is actually a receptor that are found in your liver cells, and that helps in the uptake of this remnant, the chylomicron remnant. Finally, the chylomicron remnant enters your liver. It will release these cholesterol and the triglycerides. And finally, these things will be packed into the new molecules known as the very low density lipoproteins. Remember the reactions I told you about, the formation of this cholesterol, the HMG-CoA synthetase, and then the HMG-CoA reductase. That's how your liver forms this cholesterol. Okay. And I've already told you about the reaction of this formation of the free fatty acids and these PGs. Okay. Finally, they will be stored in something known as the very low density lipoproteins. Okay. And this very low density lipoprotein contains this ApoB100. And you should know that ApoB48 is actually made from this ApoB100. The stop codons found at 48th position here in the apolipoprotein B48 and in 100 in the apolipoprotein B100s. Okay. So this VLDL contains this apolipoprotein B100. Similar to the chylomicron, they will meet the HDL particles. They will transfer their apolipoprotein C2 and apolipoprotein E to the VLDL molecules. Apolipoprotein C2 activates the lipoprotein lipase, which is found in your blood vessels. It will release the free fatty acids, which will be stored in the adipocytes. Now, after losing the triglycerides, this VLDL will become the intermediate density lipoproteins, which is IDL, low in triglycerides but high in the cholesterol level. Finally, using the apolipoprotein E, it will be again uptaken by the hepatic cells. They uses their triglycerides, store them, and finally they will release some molecules known as the low density lipoproteins, which are made from these intermediate density lipoproteins, and they are rich in the cholesterol, so much in the cholesterol. And finally, the receptor, which is apolipoprotein B100, which are found in your peripheral cells. They have this LDL receptors for these LDLs, and they will get uptaken by these cells and finally destroy, releasing all their cholesterol inside the cell. Can you remember a fact about this LDL receptors? How this LDL get yeah?
Clathrin coated bits.
Yeah, exactly. The clathrin coated bits. Okay, please remember the fact about this LDL endocytosis. So this is about these intermediate density lipoproteins, the low density lipoproteins.
I have a question on cholesterol ester. In the entire diagram, the cholesterol ester is not being decreased in quantity.
Because ultimately it would be uptaken by these cells, the peripheral cells of your body. Okay.
Not
the cholesterol is being synthesized. Yeah.
The hepatocytes synthesize these cholesterol esters, and they are only to be taken up by the peripheral tissues.
Yeah, exactly.
Okay.
The peripheral cells as well as the hepatic sites also. Some amount the hepatocytes and some amount the peripheral cells. Everyone requires the cholesterol, right? Every cell requires the cholesterol. That's why it will be uptaken by the peripheral cells and the hepatocytes also, but in a very small amount in the hepatocytes. So not much going to decrease. But ultimately, all this LDL, which is very highly rich in the cholesterol, will be uptaken by these peripheral cells. Okay.
Okay, thank you.
So you should know about the receptors that are found on different lipoproteins. You should know the function of this HDL particles, which share their apolipoprotein C2 and apolipoprotein E with the chylomicrons and the VLDLs. And one more receptor that are found in the HDL particles is your apolipoprotein A1. Okay, which activates an enzyme known as the LCAT enzyme, which makes a cholesterol esters so that they can be easily cleared from the blood. And finally, this cholesterol will be transferred to your hepatocytes by these HDL particles. So the function of the HDL particles is to transfer the cholesterol from the blood to the hepatocytes. So as you can see, because they are removing the cholesterol from your blood, so they have a very protective role in your body. HDL particles. Please remember their function. Now you should know the different type of enzymes which are found in your lipid transport. First is a cholesterol ester transfer protein, okay, which makes a cholesterol into the esteric form so that it can be easily packed into the lipoproteins. Okay, cholesterol are very big molecules. They should be converted into the esters to form, to pack easily into these lipoproteins. So here requires this cholesterol ester transfer protein. Then comes the hepatic lipase. Again, the name lipase, which break down your lipids, the fats. They will degrade the remaining triglycerides in the IDL. Like I told you already here, the IDL with the help of this receptor apolipoprotein E will be uptaken by these hepatocytes, and they will take up all this triglyceride in it, and the remaining, it will become the low density lipoproteins. Okay. Then comes the hormone sensitive lipase, which actually found in your hepatocytes. Whenever you require the fat for the energy production, what happens is in the starving conditions, this hormone that activates, it will break down all of your TG store in the adipocytes and releases the free fatty acids. These free fatty acids will be uptaken by the liver to form the, beta oxidation for the TCA and the ketone synthesis, and the remaining and the glycerol part will be used for the gluconeogenesis, as you already know about it. Okay, and cortisol and epinephrine activate this hormone sensitive lipase. Glucagon has also some effect over it, but not as much as this epinephrine. Epinephrine has much effect over the hormone sensitive lipase. Then come the LCAT enzyme, which is lecithin cholesterol acyltransferase. As I told you, it get activated by the apolipoprotein A1, which is only found in the HDL. It will make the esters of the cholesterol in your blood so that it could be easily cleared from your blood. Okay, esterification reactions. Then comes the lipoprotein lipase, which I already told you that it could be activated by the apolipoprotein C2 and help clearing the help releasing the free fatty acids from the lipoprotein so that it can be easily uptaken by the adipocytes. Please don't confuse between the hormone sensitive lipase and the lipoprotein lipase. Both are different things. Then comes the pancreatic lipase, which destroy the fat in your digestion process. Dietary fats or the triglyceride will be destroyed by this pancreatic lipase. Then comes the enzyme PCSK9. It is found in your liver cells, and what happens is it will degrade the LDL receptors. So ultimately, it will increase the LDL level in your blood. Okay, and that's why you give the enzyme inhibitor therapies, the PCSK9 inhibitors, as a treatment for the hyperlipidemia. Okay. So now I've told you about all of these receptors, lipoprotein E, which basically help in the remnant uptake. And every lipoprotein has it except the LDLs. LDLs has only one receptor, which is your lipoprotein B100. Okay. Then comes lipoprotein A1, which is found only in the HDL. It will activate the LCAT enzyme. Then lipoprotein C2, which activates the lipoprotein lipase, the B48, which is found in your chylomicrons, and it is derived from this lipoprotein B100 only. Okay, then B100, which is found in your LDL as well as your, in the ideal, LDL, and as well as your VLDLs. Okay, and they will be uptaken ultimately by the LDL receptors. Any doubt? And yeah, one more fact that I forgot to tell you about this lipoprotein lipase, that it is bound to the heparin molecules. So one of the tests that you can use to detect the deficiency of this lipoprotein lipase is to give the patient heparin sulfate. And if the activity of this enzyme increased after giving the patient heparin sulfate, that means it is normal. But if the activity does not increase, that means the patient is having a deficiency of this lipoprotein lipase. Okay. Any doubt? No? Okay.
You
Now,
mentioned two enzymes,
yeah.
lecithin cholesterol. The first one
Acyl
is related
transferase.
to
I'll
the
get.
ApoA1, and the second is lecithin cholesterol acyltransferase. So
Yeah.
the role of lecithin cholesterol acyltransferase is related to ApoA1.
Is to clear the cholesterol from the blood actually, right? And it got activated by the A1 only. It will clear the cholesterol from your blood.
Okay.
Okay. Because esterification is required to easily pack these cholesterol into your lipoproteins. Okay. So that's why these two type of enzymes exist. First is the cholesterol this ester transfer protein, and second is your LCAT enzyme. So that esterification can be happen easily, and they could be packed easily in the lipoproteins. It is found in your blood and it is found in your GI section. Okay. Now comes the function of the lipoproteins. Like I told you already, the chylomicrons are required to absorb the dietary lipids and triglycerides. It get absorbed using the receptor apolipoprotein B48 and will transfer the triglyceride to the peripheral tissues as well as your liver. Okay. Then VLDLs, which get secreted inside your liver and will transfer the triglycerides and cholesterol to the peripheral tissues. The IDL, which takes up the triglycerides and it will transfer them to the liver. Okay, the triglyceride and cholesterol to the liver. It is formed by the degradation of this VLDL. Then comes the low density lipoproteins, which are formed from the liver from the modification of this LDL, and it will transfer the cholesterol to the peripheral tissues. Okay, and the LDL receptors are present in all of the peripheral tissues, especially your adipocytes and the mammary glands and the other areas. So it will help the transferring the cholesterol from the liver to your cells, the peripheral cells. And you should know that LDL is very lethal. As much as LDL, the more LDL you have, the more chances you have for the myocardial infarction. Okay, because it contains only the cholesterol, which is very lethal. Okay. Then comes the HDL, which has very protective role because it clears the cholesterol from your blood, by activating the enzyme LCAT using A1, and it will also transfers the cholesterol from the peripheral tissues to the liver. Okay, and it will transfer the apolipoprotein C and apolipoprotein E to the chylomicrons and the VLDL. Okay, any doubt? I think it's easy if you understand that diagram, the last page. Then comes a disorder known as the A beta lipoproteinemia. That means you do not have this apolipoprotein B48 and apolipoprotein B100 in your body. And as a result, the chylomicrons won't get absorbed in your lymphatics. Remember, you require this apolipoprotein B48 for the absorption of chylomicrons in your blood. So if you get loss, if you get deficient of these apolipoprotein B48, you will have very low content of chylomicrons. And if you become the deficient of this apolipoprotein B100, you will be absent of this VLDL, LDL, and other ideal thing. Okay, what happens is there's a mutation in the microsomal transfer protein. If you remember the name MTP, microsomal transfer protein, and will lead to a deficiency of this apolipoprotein B100 and apolipoprotein B48. Ultimately, you will get a deficiency of this chylomicrons, VLDLs, and LDL. So what happens now, as I told you, that chylomicrons are required for the absorption of fat from cells to the lymphatics, right? So what happens is all of this fat will get absorbed in the intestinal cells but cannot travel into the lymphatics. So all of the fat will be start accumulating inside your in these cells. So what you will see in the biopsy? Anyone tell me what you will see in the biopsy in these patients?
Formed macrophages?
Not the macrophages, enterocytes. You know, lipid-laden enterocytes, very clear cells you will see in the biopsy. Okay, intestinal cells are very high. The lipid-laden these enterocytes. Okay, and they will see as the enterocytes with a very foamy cytoplasm, clear and foamy cytoplasm. Okay, that you will see in the biopsy. Ewald has a very nice histology of these cells. You will encounter a question over it. Okay, so now because you have this fat malabsorption, what you will see is the loss of the vitamins. Which vitamins? Vitamin A, D, E, K, and especially you will get a deficiency of this vitamin E in these patients. So if you get a if you get a vitamin E deficiency, what you will get is a subacute combined degeneration. Remember, just like a vitamin B12, and plus you will get the anemia, and you will get the something known as the acanthocytosis, which is a RBC disorder. You will have some spikes over your RBCs that you can easily see in the peripheral blood smear. The acanthocytosis is very important. Other thing you will get is a retinitis pigmentosa. Your retina started losing the pigments. So blackish spots will be seen in the fundoscopy of the retina. It is a dysplastic disorder you will see. You will study that later into the ophthalmology section. Okay. So steatorrhea, failure to thrive because you're not absorbing any nutrient. You will have this very weight loss, malnutrition, fat malabsorption, steatorrhea. You will get this vitamin E deficiency, the retinitis pigmentosa, the progressive ataxia you will see because of this vitamin E deficiency again. Acanthocytosis you will see in the peripheral blood smear. You will study that later in the hematology section also. And on the histology, what you will see is the foamy clear cytoplasm of the enterocytes. So what are the treatment is to give the patient oral vitamin E, and of course the the dietary lipids, restriction from the dietary lipids. Okay. And you should know that the manifestation generally occurs within first year or five. So it must be a patient who is having an age less than 1 year. Okay. Any doubt in A beta lipoproteinemia? Any doubt, guys?
You have just said that beta lipoproteinemia leads to the deficiency of all fat soluble vitamins. But then why in the treatment we are only focusing on vitamin E?
Because there's a major deficiency of vitamin E only. But all A, D, E, K will be lost, but most importantly, E would be lost. Okay.
Okay.
You will have to give ADEK also, but most importantly, you will focus on the E, because it is said that E is much more important. You know, that's why.
Yes.
Okay, so then comes your familial dyslipidemia's case. There are 4 types of dyslipidemias present: the type 1, the type 2, type 3, and type 4. First आता है the hyperchylomicronemia. As the name suggests, you will have a very high chylomicron level, and because it contains your triglycerides and cholesterol, so you will have very high level of triglycerides and the cholesterol in your body. Why this hyperchylomicronemia? Because you will become the deficient of either the apolipoprotein C2 or the lipoprotein lipase. Remember, I told you the function of these enzymes and these receptors. They will require to absorb the triglyceride from the chylomicrons. So if you become deficient of these 2 enzymes, what you will have is a high level of chylomicrons in your blood. And because they carry this triglycerides and cholesterol, so you will have this high level of cholesterol and triglycerides. So it could be happen because of 2 things, like I told you, either the lipoprotein lipase deficiency or the apolipoprotein C2 deficiency. And I told you that this lipoprotein lipase is found in your blood vessels at, with these heparin molecules, remember? So if you give the patient heparin infusion test, if the activity of lipoprotein lipase is decreased or no activity would be seen, that this means the patient is having a deficiency of lipoprotein lipase. But if you give the patient heparin infusion and the activity of lipoprotein lipase is normal, that means it is a deficiency of apolipoprotein C2. Okay. So because of high triglycerides level, you should know that these high levels of these fatty acids will lead to the pancreatitis, a very important cause of acute pancreatitis. So you will get the pancreatitis, you will get the hepatosplenomegaly. And because of this high level of lipids in your body, you will get this eruptive or the pruritic xanthomas, which are xanthomas over your palms, and it is very pruritic, And there is no increased risk of atherosclerosis. You should remember, because atherosclerosis will be happen when you have the increase in cholesterol primarily. Okay, not due to the triglyceride. It will lead to the pancreatitis only. Okay, and what you will get in the lab test, a supernatant creamy layer. When you left their plasma for a second or 10, 20 seconds in a test tube, what you will see, the upper layers become very turbid or milky. Okay, and that's how you know that is a fat in your blood. So much fat triglycerides in your blood. So please remember the pancreatitis, hepatosplenomegaly, pruritic xanthomas over your palms. It will become your yellowish papules, okay, over your extensor surface or your palms, and which have very erythematous base. So it would be like that. Let me tell you. This is quite yellow area, okay, and surrounded by this reddish base. It is something like that. You can easily search search these xanthomas on the internet. Okay, so yellowish papules with the reddish base in the periphery. They will describe you that only. Okay, then comes the familial hypercholesterolemia. Okay, and which is due to the defect in the LDL receptors or in the apolipoprotein B100 receptors. Either the LDL receptors or the apolipoprotein B100 receptors. What gonna happen? You will ultimately get the high level of this LDL lipoproteins, the low density lipoproteins. Okay, and because they contain mainly the cholesterol, so what you will get ultimately high level of cholesterol in your blood. And you should remember that it could be of 2 types, either the LDL receptor deficiency or due to the apolipoprotein B100 deficiency. And if the deficiency of this apolipoprotein B100 occur, then you will get high level of both the VLDL as well as the LDL, because it is present in both, remember. But if you will get the deficiency of LDL only, LDL receptors only, then you will get the high level of LDL cholesterols only. So the 2 type of deficiencies, either the LDL receptors, which is a type 2A, lead to the LDL level very high. And in the type B, which is due to the apolipoprotein B100, you will get the high level of LDL as well as the VLDLs, okay? And the mutations can be heterozygous and can be the homozygous. If it is heterozygous, then the cholesterol level will be around 300 milligram per deciliter. And homozygous is quite rare, but the cholesterol level will be, more than 700 milligram per deciliter in these patients. And because I told you that high level of this cholesterol will be a risk factor for the myocardial infarction. So you will get the MI before age of 20 in these patients. Can you guys remember the case of myocardial infarction in very small children? What you will think if you get a case of myocardial infarction in very small children?
Kawasaki.
Not the Kawasaki. Okay, Kawasaki can be happen. But other than Kawasaki, I told you in the biochemistry section,
Was it vasculitis?
the
Yeah, yeah.
homocystinuria. You know, you will get the recurrent attacks of myocardial infarction and recurrent attacks of stroke. Please remember this also, because in the familial this disease, you will get the MI before age of 20. And you will get the tendinous Achilles xanthomas, which are, xanthomas over your Achilles tendon on your fingers or in your ankle areas. The yellowish papules or bulging areas would be seen, and you will get the corneal arcus, which is kind of this white, let us suppose this is your eye. Draw it. This is your eye. This is your area. You will get this corneal arcus at the periphery. You will see. FA has a diagram of it. I will tell you about this in the cardio section. Okay. This is a corneal arcus. This is eye, and the periphery of the eye, you will see this whitish layer. This is a corneal arcus, and that is especially seen in the familial hypercholesterolemia. Okay, then comes a this beta lipoproteinemia. That means you're going to have a high level of lipoproteins, which are chylomicrons as well as the VLDLs, and it is due to a defect in the apolipoprotein E. As I told you, it is required for the uptake of the VLDL and the chylomicron remnants. So what you will get high level of VLDLs as well as the chylomicrons. And because they contain mainly the cholesterol in them, so that's why you will get the atherosclerosis and the myocardial infarction. And you will get the palmar xanthomas, which are xanthomas over your palms. These are not pruritic, but these are pruritic in case of hyperchylomicronemia. Okay. Then comes your hypertriglyceridemia. That means high level of triglycerides, which are mainly because of this VLDL, increased production of the VLDLs. Okay. So, and as I told you that high level of triglycerides is responsible for the pancreatitis. And as well as these triglycerides are responsible to increase the resistance of insulin in your body. So you will get the diabetes mellitus in these patients, as well as the acute pancreatitis. So what you will find in the patient: obesity, diabetes, and acute pancreatitis. And the case is your hypertriglyceridemia. And then you should remember about this metabolic syndrome, in which you have all these defects only. Like you will have this high level of LDL, you will have high level of triglycerides, you will have very low level of HDLs, you will have this central obesity, hypertension, high blood glucose, that means diabetes. So whenever I encounter such kind of patients who is very obese, high level of LDL, triglyceride, low level of HDL, means only defects, this is a metabolic syndrome. They will ask you if a patient is very obese and having hypertension, what are the level of lipoproteins would be there. So they will give you some options, and the right option would be this: high ITGs, low HDL, and high LDLs. And you should know that triglycerides are responsible for the resistance against the insulin. Any doubt in this page? No? Any doubt, guys? We're finished with the biochemistry section. Any doubt?
No. No.
Okay. Okay, so we are done with the biochemistry and we will start with the immunology today. Let me start the screen for immunology. Okay, so first of all, you should know about the immune system organs, which are of two types, either the primary organs or the secondary organs. The primary organs where the formation of your lymphocytes or the maturation of the lymphocytes occur, and secondary organs are the organs where they store and fight the infections. So the primary organs includes only the bone marrow and the thymus. Bone marrow, where the maturation of B cells occur, the formation of B and T both cells occur in the bone marrow, but the maturation of only B cells occur here. The T cells leaves the bone marrow and enters the thymus where they will get mature and become the T cells. Okay. Then comes the secondary organs where they fight the infection. These are the spleen, the lymph nodes, the tonsils, the paired patches in your intestines. Okay. And that is where they allow the immune cells to interact with the antigens. Okay. Then comes the structure of this lymph nodes. First of all, you should know a fact that it has many afferents, as you can see, 1, 2, 3. Many afferents, but only single efferent. Okay, the lymph nodes. Second thing you should know about the fact that it is encapsulated structure. It has capsule over it. And after the capsule, it has this cortex and the medulla. This is the cortex and this is the medullary part. And between the cortex and the medulla, there is this paracortex. So 3 zones, the cortex, the paracortex, and the medulla, and everything is covered in the capsule. It has many afferents, but only one efferents. In the cortical region, there are present these follicles, and the follicles are of two types, either the primary follicles or the secondary follicles. The primary follicles will appear very darker, as you can see. These primary follicles appear very darker on the biopsy, and the secondary follicles has these lightish areas in the middle, and these are the activated follicles. Whenever you have an ongoing infection in your body, the primary follicles will become the secondary follicles, and in this secondary follicle, in this lightish area, you have this germinal centers where the the class switching of the antibodies is occurring, and something known as the affinity maturation process is also happening in these centers, and they will appear very light in the biopsy. Then you have these medullary cords, okay, where they get in the paracortical region, and in the cortical part you have only these B lymphocytes. A very important thing, in the cortical part you have only these B lymphocytes mainly, and the germinal centers and the primary follicles. In the paracortex region, which is this region, you will have mainly the T cells. So the T lymphocytes present in the paracortex and the B lymphocytes in the follicles of the cortex. Okay. And you should know there are also present the endothelial venules or the post-capillary venules. Okay. And this is the area where these B and T lymphocytes can enter these lymph nodes. A very important thing, in the paracortical region, they are present the endothelial venules where the B and the T lymphocytes enters from the blood. And you should know in the DiGeorge syndrome, because you will lose all your T lymphocytes. So DiGeorge syndrome, you won't have the paracortex region. Okay, you will get the atrophy of your lymph nodes because you do not have the paracortex region in the DiGeorge syndrome. And if you get a B cell deficiency, then what you will have is the loss of this cortical region. Okay, you will see that in the later pages also, the proton tyrosine kinase X deficiency. What you will have is the loss of these cortical regions. Okay, and whenever you encounter a bacterial infection, what you will have is the hypertrophy of this cortex region and the formation of the germinal centers. Okay, a very important thing, whenever you have a bacterial infection, you will get the hypertrophy of these cortical regions and the formation of these germinal centers. And if you have a viral infection, because to fight the virus, you require mainly your T cells. So what you will have is the hypertrophy of this paracortex region. A very important thing, where you will get the hypertrophy of paracortex and when you will get the hypertrophy of your cortex. Then comes the medulla, where you have these lymphocytes, the plasma cells, medullary sinuses, which can be connected with these lymphatics. Okay, these are the medullary sinuses and medullary cords are present also. Okay, so this is about your structure of the lymph node. It has two parts, the cortex and the medulla. And in between these two parts, you have this paracortex. Paracortex, you will have these T cells. In the cortex, you will have these B cells. In the bacterial infection, you will get the hypertrophy of this cortical region. In the viral infection, you will get the hypertrophy of this paracortical region. So any doubt? No? Okay. Then you should know the location of different lymph nodes in your body and where does they collect the lymph, which structures they supply, which structures they drain. You should know every location. So we'll start from the lower and go to the top. Okay. And you should know all the arteries and the lymph nodes have very similar name. The arteries that supply this structure are the, will be the name of the lymph nodes which drain these structures. So first of all comes our popliteal lymph nodes, which actually carries or drains the lymph from the anterior part of the, from the posterior and the lateral part of your foot. Okay, the dorsolateral foot and the posterior area of your calf. And you should know it bypasses, just a second. Yeah. It bypasses the external inguinal lymph node and directly enters into the interior inguinal lymph nodes. You should know the location of this lymph node. This is the superficial or the exterior inguinal lymph nodes, and there is also a deep inguinal lymph nodes. Finally, these superficial inguinal lymph nodes will drain the lymph into the deep inguinal lymph nodes. And these popliteal lymph nodes, bypassing these superficial inguinal lymph nodes, drain the lymph directly into the deep inguinal lymph nodes. Okay, I know it is very confusing thing, but you should remember this table mainly. It contains every name you should remember. So whenever you get a posterior leg cellulitis or the lateral foot cellulitis, where you will get the infection, the drainage of the infection, that would be through the popliteal lymph node. So you will get the hypertrophy of the popliteal lymph nodes. You can easily palpate them when they get the hypertrophied. Okay, and in the medial side of the leg, okay, and the anterior part of leg, there is this superficial inguinal lymph node which drains the lymph. Okay, in your anterior part, the lymph gets drained by this superficial inguinal lymph node. So whenever an infection happens in the anterior part of leg, the infection will be travels through these lymphatics only, and you will get the hypertrophy of these superficial inguinal lymph nodes. Okay, the lymphadenopathy that you call. And other areas where the superficial inguinal lymph nodes drain the lymph from, these are your anal canal, and it is below the pectinate line, which means everything that you can see below your umbilicus would be drained by the superficial inguinal lymph nodes. That is your, the anal canal, the scrotum, the vulva, the skin below the umbilicus. Okay, everything is drained from by that superficial inguinal lymph node, and ultimately this superficial inguinal lymph node will drain the lymph into the deep inguinal lymph nodes. And popliteal lymph nodes draining the lymph directly into the deep inguinal lymph nodes. Then comes the external and the internal inguinal lymph nodes. This is it, the external and the internal iliac lymph nodes. For the internal iliac lymph nodes, this is a lower part of your anal canal above the pectinate line, but the lower part. Okay. Then this vagina, the cervix, the prostate, and up to the bladder. The lower part of the bladder, I must say, because upper part of the bladder is drained by this external iliac lymph nodes. Okay, and above the vagina you have this cervix. So cervix is drained by this external iliac lymph nodes. Okay, above the cervix you have some lower part of the uterus or the body of the uterus. It is drained by the external iliac lymph nodes. Okay, then comes the para-aortic lymph nodes. Okay, above the uterus, the lower part of the uterus, you have the upper part of the uterus, right? And they are drained by the para-aortic lymph nodes. The testes directly drain into the para-aortic lymph nodes. The kidneys, because these para-aortic lymph nodes are near the kidneys, you drain the lymph from the kidneys. So kidneys, uterus, ovaries, and the testes, they are drained by the para-aortic lymph nodes. Then comes the inferior mesenteric lymph nodes. As the name, the inferior mesenteric artery, which supplies the lower 1/3 of your intestine from the splenic flexure to the upper rectum. Similarly, these lymph nodes drain the lymph from the splenic flexure to the upper rectum. Okay, then the superior mesenteric, will drain up to the splenic flexure. From the duodenum to the splenic flexure. Then the celiac, the areas where the celiac artery supply these lymph nodes will drain the lymph from these areas, which is your from the the esophagus, lower esophagus, the liver, the stomach, the spleen, the pancreas up to the upper duodenum. Okay. Then axillary, which drains your lymph from the breast, which is more important. And of course, the skin above the umbilicus, everything above the umbilicus will be drained into these axillary lymph nodes. Okay. And then the hilar and the mediastinal. This is very confusing thing. Hilar and the mediastinal. Hilar will drain blood only from the lungs. We have this hilar which drain only, not the blood, but the lymph, only from the lungs. But the mediastinal lymph nodes will drain the lymph from the trachea and the esophagus. Outside the lungs, the lymph will be drained in the mediastinal part. And within the lungs, the lymph will be drained in the hilar lymph node. So whenever you get an infection of the lungs, pneumonia, you will have the lymphadenopathy of this hilar regions, okay? And whenever infection affects your trachea or the esophagus, you will have the lymphadenopathy in the mediastinal lymph nodes. For example, the sarcoidosis, the TB, pneumonia, lung cancers. In the lung cancers, you have this hilar lymphadenopathy bilateral, remember? In the sarcoidosis, you have this bilateral hilar lymphadenopathy because they affect mainly your lungs. Then come the supraclavicular and the clavicular lymph node, which drains the lymph from your head and neck structures. And whenever you have this supraclavicular lymphadenopathy, you can be damn sure this must be a case of your cancers, because no infection can gain access to the supraclavicular lymph nodes. So this is an exam question. Whenever you have a supraclavicular lymphadenopathy, you can be damn well sure this must be a case of cancers, not an infection. And these supraclavicular lymph nodes are also known as the Burkitt lymph nodes, if you guys remember. Where you heard this term, Burkitt lymph node?
Stomach.
Anyone? Stomach cancer, yes.
Can you please repeat the supraclavicular point again?
Yeah, whenever you have a supraclavicular lymphadenopathy, you can be damn well sure that this must be a case of your cancer, not an infection. They will ask you this, how will you, what lymphadenopathy will tell you that this must be a case of your cancer. So you will check the box that contain this supraclavicular lymphadenopathy, because all of these lymphadenopathies can be happen due to infection also, not just by the cancer, but the supraclavicular lymphadenopathy can only happen in case of cancers. Okay. So this is about it. And then you should also remember that ultimately all of these lymph nodes gonna drain their lymph into the veins, which are a jugular vein and the subclavian veins, right? And as you can see in the diagram, this is the right part of your body. Okay, and from the head and neck structures of your right part, from the chest or the lungs of your right part, and the hand of your right part, they all will drain their lymph into the internal jugular vein, right internal jugular vein, the right subclavian vein, and finally the right interjugular vein. Okay, the right part. And the left part of your body, all the head and neck area, the thorax part, the limbs, and all the body after the thorax will be drained into the subclavian vein, left subclavian vein, and then to the internal jugular vein, and that is by the thoracic duct. There runs a thoracic duct in the left side of your body. It will drain the lymph from all of these lymph nodes, and finally will drain the lymph in your left subclavian vein or the interjugular, and then to the interjugular vein. Okay, I hope you remember this fact. Very important. The right side of the body and the left side of the body is very important, where they drain their lymph ultimately. And then you should remember what happens if you block the lymph drainage. So what you will get is a lymphedema. Okay, so they can ask you the causes of this lymphedema, which could be due to the infection. Remember the parasite that causes the lymphedema? Remember the name? The parasite that causes what?
Wuchereria?
Yeah, exactly. Wuchereria bancrofti and Wuchereria malai. Elephantiasis. Okay. Then it could be due to congenital syndrome also, which are your Turner's. Remember the cystic hygromas I told you about? Where you heard this term, cystic hygroma? In the Down syndrome. Yeah, remember on the neck, over the neck, you will get this very bulging structure. This is a cystic hygroma, and it is also a lymphedema. Okay, it happened due to the blockage of your limbs. Okay, then the chronic cellulitis and the malignant obstructions can also causes the chronic lymphedema. Okay, and you should know that these lymphedema can also causes the cancer, the skin cancer that you will study later in that the Dhamma section also. You will see that chronic lymphedema is a cause of cancer. Okay, so how will the patient with this chronic lymphedema present you with? It would be a non-pitting edema. You will get the swelling of one side of the limb. They will complain about this heaviness or the increase in size in one side of the limb and other side is normal. Okay, the skin over that area will be very dry, very hard. You know, there will be non-pitting edema. And they will ask you what is the treatment of this lymphedema. Very important part. They will ask you the treatment of this lymphedema, and that is the bandage, the compression bandage, and the physiotherapy. Please write it down. The treatment of the chronic lymphedema, which is a compression bandage and the physiotherapy. You should remember. And please remember that diuretics are contraindicated because the lymphedema is due to the blockage of the lymph. You know, you have this increased lymph, not the increased blood or the water. And if you give the patient diuretics, what will happen? It will decrease your blood volume. You will get a dehydration, but they do not have any effect on the lymphedema. So diuretics won't be used in the lymphedema. Very important part. Okay, so any doubt? And the easy way to remember all of these lymph nodes is I have included this in my points to remember note that I have shared with you guys. There is a part, let me show it to you. Just a second. Share. If you want to remember, you can look at that part, the lymph nodes part, the inguinal lymph nodes, the iliac lymph nodes, the para-aortic, mediastinal, and hilar. Inguinal lymph nodes are of two types, the superficial and the deep. The superficial will drain the lymph from the anterior medial of the leg, the scrotum, the anal canal below the pectinate line that you can see, and the vulva part, which is easily be seen. So all of the structures that you can easily see below your umbilicus would be drained by the superficial inguinal lymph nodes. But the deep inguinal lymph nodes, the penis, the posterior medial of your leg, so the posterior later it is, and the superficial inguinal lymph nodes ultimately drain the lymph into the deep inguinal lymph nodes, as well as the popliteal lymph nodes will also drain the lymph into the deep inguinal lymph nodes. Then comes the iliac, which is the internal iliac and the external iliac. Above the anal canal, what you will have is above the pectinate line, you will have the lower part of the anal canal, which is, which drains the blood into the internal iliac lymph nodes. Okay, then the prostate, okay, then the vagina, because vagina is above the vulva, so it will drain the lymph into the internal iliac lymph nodes. Above the vagina, you will have this lower part of the cervix, and the lower part of cervix will drain the lymph into the internal iliac lymph nodes. Then above the cervix, you have this upper part of the cervix, which drains the lymph into the external iliac. Above the cervix, you will have also this lower part of the uterus, which drains the lymph into the external iliac lymph nodes. And then the upper part of urinary bladder, lower part drain into the internal iliac and upper part drain into the external iliac. Then above the uterus, you have this complete upper part of the uterus, which drains the lymph into the para-aortic. The testes and the ovaries drain into the para-aortic, and kidneys, which are near the para-aortic, will drain into the para-aortic. Do not confuse between the mediastinal and the hilar lymph nodes. Mediastinal lymph nodes drains the lymph from the trachea and the esophagus, and the hilar drains the lymph from the lungs. So this is an easy way to remember, the very simple way. If you want to remember like that, goes above and above and above structures, you will reach the different lymph nodes. Okay. Any doubt?
No, we're good.
Okay, so Then comes the structure of the spleen. First of all, you should know where the spleen is located. It is located in the left side of your body, in the left upper quadrant. Okay, and it is protected by the 9th and the 11th rib. So whenever you have a fracture that involves your 9th and the 11th rib, the first thing you're going to damage is your spleen. And you should remember, in the blunt abdominal trauma, the first damaged organ would be your spleen. Okay, and after the 11th rib, in the 12th rib, which is guarding your left kidney. So whenever you have a fracture of your 12th rib, what you will damage is your left kidney. Okay, and if you have a trauma that is involving your 9th and the 11th rib, it will be damaging your spleen. Okay, please remember this fact. So as soon as you enters the spleen, there will be two regions, the red pulp and the white pulp. Every area in your spleen is a red pulp, and in between the red pulp, there would be some white pulpy area. So all of this area is your red pulp, as you can see. And in between the red pulp, there are some areas that are your white pulp. The white pulp area actually contains your lymphocytes and the macrophages. And this red pulp area is filled with RBCs only. Okay. And in between the red pulp and the white pulp, there is a periarterial lymphoid sheet, okay, which contains your T cells. And in these follicles, which is a white pulp, you have these B cells. So white pulp has two parts, the follicles, and just like your lymph node, the follicle contains the B cells. And around these follicles, in between the red pulp and the white pulp, you have this periarterial lymphoid sheet, which contains the T cell. They will ask you the location of T cells and B cells in the spleen. Please remember this fact. Okay, and in between these part, in between the T cells and these RBCs, there presents some macrophages. Or you can say in between the white pulp and the red pulp, there is a marginal zone, okay, which contains the macrophages. And macrophages and B cells, specialized type of B cells, are basically your antigen presenting cells. They will take up the antigen, take them to your T cells, and then they will activate the B cells. Their formation of the germinal centers will occur, and they will fight the infection. Okay. And you should know that the splenic macrophages are very important in clearing the encapsulated bacteria. And that's why whenever you have a loss of spleen, like in case of any accident, or there might be a surgery, or it might be a case of sickle cell anemia, you always want to give the patient vaccines for these encapsulated bacteria. And the main bacteria are your Streptococcus pneumoniae, Haemophilus influenza, and your Neisseria meningitidis, or the meningococci. Okay, please remember these three bacteria: the pneumococcus, meningococcus, and the Haemophilus influenza. And the most important among them is your Streptococcus pneumoniae. You always need to give the vaccine to the asplenic patient against these bacteria. So whenever you encounter a patient who is having some kind of a fever only, just the fever and chills, and he's have a history of some kind of a abdominal trauma like years ago, or might be a history of sickle cell anemia, or might be a history of splenic removal, you want to immediately give them the antibiotics against these three bacteria. Okay, because there's a very high chance, or the 90% chance, that the infection is caused by one of these three bacteria. Okay. Okay, so paradigm sheet, everything I've covered here. Then spleen dysfunction, I've told you. I've told you that the most commonly damaged organ in your blunt abdominal trauma is your spleen. Okay, or you can also get the splenic surgery in the sickle cell anemic state, or other reasons also you can lose your spleen. So whenever you lost your spleen, because you know that the complement activation, actually the complement formation is occur in your liver, but the fixation of the complements that you will study later in the chapter, you will see that the fixation of the complements is actually happening in your spleen, which is very important to fight these encapsulated bacteria. So if you do not have the spleen, there won't be any fixation of the complements occur. You will get the decreased activation of the complement, so you will get the increased susceptibility to the encapsulated organisms. You will see that later that these complements are very important to fight the encapsulated bacteria infection. Okay, And some RBC conditioning is also occurring in the spleen, like removal of the Howell-Jolly bodies, which are the remnant of your DNA or the nuclear remnants. So if you remove the spleen, you would not get the splenic conditioning. So what you will see in the peripheral blood smear is your Howell-Jolly bodies, but it is seen only in the acute circumstances. After some time, the liver will take up that function, so you will never see the Howell-Jolly bodies in a very chronic patient. Okay, in the acute patient only. Then the targetoid cells, because I told you that splenic conditioning of the RBCs is occurring in the spleen, they will remove some of the membrane of the RBCs so that they can get their shape, the concave shape. So if you remove the spleen, you will get the targetoid cells. Where you can get the targetoid cells again, other than the spleen? Anyone from hematology section? Yeah?
Thalassemia.
Yeah, thalassemia as well as a sickle cell anemia also.
Liver disease.
Yeah, exactly. And liver disease can lead to targetoid cells, yes. Then there will be a loss of sequestrations of different cells, like your lymphocytes. As I told you, the lymphocytes stays here, right? And there would be a loss of your platelets or the thrombocytes. So you will get a thrombocytosis shortly after the removal of your spleen because of this loss of sequestration. And because of this loss of sequestration, you will get the lymphocytosis also. And whenever a patient is undergoing a splenectomy, you will always want to vaccinate the patient against these three bacteria, the pneumococci, the meningococci, and the Haemophilus influenza. Then you guys should know some causes of the splenomegaly. Okay, if the infection occurs, then the hypertrophy of your PALP will occur. Okay, or sometimes due to the damage of your RBCs, there could be the splenomegaly, and it is due to the expansion of this red pulp. If the blockage of the veins occur, okay, you will get the splenomegaly also in that case. Okay, in the lymphoid tissue proliferation, like due to the infection, you will get the splenomegaly. In the leukemia or the lymphoma, you will get the increased size of this white pulp. You will get the splenomegaly in that case also. In the Niemann Pick disease or the Gaucher's disease, remember, you will get the hepatosplenomegaly. Please remember these cases of the splenomegaly. Okay. Any doubt in spleen structure?
So why do we have target cells?
What do we have?
Target cells.
Not following, please.
Target
repeat it again.
cells. Target cells.
Target.
Why do we
Yeah,
have
okay.
those?
Okay, because I told you that splenic conditioning of RBCs is occurring in the spleen. What happens is actually spleen removes these nuclear remnants from the RBCs, and as well as some membrane of the RBCs is removed by the spleen, so that there's something known as the volume and the surface area ratio. Okay, and as you know that RBCs is a biconvex shape because of this loss of surface area and a very the loss of surface area and very high volume. Okay, but because the splenic condition is not occurring, you won't get to remove the membrane of the RBC, so you will have a very increased surface area and less volume. So this increased surface area, the increase in the membrane, will lead to the targetoid cells. Okay,
There is an
if you have
increased surface area.
let me show you. Well, normally you have the RBCs of this shape, remember, if you're looking from the side of the RBCs. Yeah, but in case if you have too much of the membrane, what will happen is this thing. Okay, and this, if you have increase in the membrane, so what will happen? This is the increase in the membrane. So what you will see in the from the above is the targetoid cells. So you need to remove this membrane. Okay, and this is done by the splenic conditioning. The macrophages that are present in the spleen will remove this membrane, this extra membrane, so that the RBC can achieve the size or the shape of this biconvex shape. Okay, if you do not have the splenic macrophages, if you do not have the spleen, you won't get to remove this membrane, and you will get what? The targetoid cells. Okay.
Okay. Thank you.
Okay, now the structure of the thymus. The thymus again has this cortex and the medulla. The immature cells are reside in the cortex, and the mature cells after this negative selections will come into the medulla. Okay, you guys already know this fact. And in the medulla, there are also present some cells known as the Hassel corpuscles, very important cells. These are present in the concentric layers. Okay, you will see them as like that. This is one layer. This is two layer. This is three layer. This is a Hassel corpuscles. You will see in form of concentric layers, and these are these cells which forms your T regulatory cells. Can anyone tell me what is the T regulatory cells are? Anyone? T regulatory cells?
TH17.
No, not the TH17, but these are actually CD4 cells. Okay, they are become from that CD4 cells. Actually, what happens with the negative selections? Those CD4 cells which cannot pass a negative selection will become the T regulatory cells, and these cells actually inhibits your immune response in order to control the damage. Okay, they releases that interleukin 10, which inhibits our immune response. Okay, so that's why these T regulatory cells are important. So, and they are formed from these Hassel corpuscles, formed by these Hassel corpuscles. Okay. And you should know that the thymus is derived from the third pharyngeal pouch. There is this pharyngeal arch, the pharyngeal pouch, and the pharyngeal cleft. Outside is a cleft, then comes the arch, then comes the pouch. So thymus is formed from the third pharyngeal pouch. And you should know that in the Digeorge syndrome, because you're losing your third and fourth pharyngeal pouch, what's going to happen? You will lose your thymus. And if you lose your thymus, what's going to happen? You will lose your T lymphocytes. There won't be any T lymphocytes, just the B lymphocytes. So what you will see in the lymph nodes, if you lose your T lymphocytes, anyone?
Absent T cell.
Paracortex.
Absence of,
Paracortex.
exactly,
Paracortex.
absence of paracortex, yes. Absence of paracortex, you will see the atrophy of the lymph nodes. And again, in the subacute combined immunodeficiency syndrome, SCID, what you will see is the loss of B lymphocytes as well as the T lymphocytes. What is the reason? I've told you already in the biochemistry section. I think it was third or fourth.
ADA deficiency.
ADA deficiency. Why the ADA leads to the SCID?
ATP cannot be broken into adenosine.
No, that is not the main reason. The adenosine is actually very toxic to your lymphocytes, remember? Adenosine is very toxic to your lymphocyte. It leads to the death of your B cells as well as the T cells. And that's why in the ADA deficiency, you're having this SCID, the loss of B as well as the T lymphocytes. And because there is loss of B and T cells, what you will see is the atrophy of the lymph nodes. There won't be any lymph nodes present in your body. There won't be any thymus present in your body. And if they show you an X-ray and asking you where's the thymus, this is the shadow of the thymus. The triangular region in the right side of your X-ray is your thymus. And in the Digeorge syndrome as well as the SCID, you will lose that thymic shadow. A very important thing, okay? And when you get the thymoma is a cause of myasthenia gravis, you guys should remember, okay? Thymoma is the cause of this myasthenia gravis, and as well as a Goodpasture syndrome, you will study in the renal section. The thymoma is a cause of Goodpasture syndrome, okay? And again, the superior vena cava syndrome, you will study that later again. The pure red cell aplasia, in which you will lose only your RBCs. Your WBCs, your platelets will be absolutely normal. You will have just aplasia of these RBCs, and that is due to one of the cause is thymoma. You will also get the pure red cell aplasia in one of the infections. Can anyone tell me?
Parvovirus B19.
Exactly, pyrovirus B19 infection. So please remember the causes of this pure red cell aplasia, the thymoma and the parvovirus B19 infection. And they can ask you by giving you a scenario of this myasthenia gravis patient, and they can ask you what other disease had the same pathology. So they will give you some options and you have to choose one of these 3-4 options, okay? So that's why you need to remember the examples of this thymoma. The superior vena cava syndrome, the pure red cell aplasia, and the Goodpasture syndrome. Can anyone tell me what is superior vena cava syndrome?
lung tumor which compresses the superior vena cava.
Yeah, not just a lung cancer, but any structure in your mediastinum that compresses your superior vena cava can cause the superior vena cava syndrome. Okay, and one of them is the thymoma, because if you have increased size of your thymus gland, it can easily compress the vena cava. Remember? So remember all of these examples. Any doubt in thymus?
No.
No.
Then comes your two types of immunities, the adaptive immunity and the innate immunity. Innate immunity, which presents since your birth, and adaptive immunity is immunity which you acquire during your lifetime. And you should note that the B cells and the T cells and the antibodies which are secreted from the B cells are the part of this adaptive immunity. And the remaining cells like your macrophages, the neutrophils, the NK cells, the dendritic cells, the complements, the skin, your fever thing, and your enzymes, different type of, all of them are the part of your innate immunity. And like I told you, it presents in the birth, so it is germ line encoded. Okay. And the adaptive immunity, you acquired this during your lifetime. It is a very specific response. And there is a VDJ recombination, which leads to the formation of these T cell receptors and your antibodies. You will study that later about this VDJ recombination, how you form your antibodies actually. Okay, so this is the mechanism of the formation of this adaptive immunity. So VDJ recombination will lead to the formation of the receptors on your B cell, T cell, and as well as your antibodies. Then the resistance, you need to know that if the resistance occur, it will persist through the generations. Okay, it do not changes when any organism's lifetime. Okay, but you should know that if the resistance in the microbes occur against these B or T cells, it will not be inheritable. Okay. Response in the innate immunity is very kind of non-specific for every organism. They do the same thing. They will use the respiratory burst to kill the microbes. Doesn't matter what type of microbe it is, they will use the same thing, and they won't have any memory of the response. Means the next time when the pathogen came in your body, they will do the same thing. No difference. But in the adaptivity, it is highly specific for every organism, for every type of bacteria, for every type of virus. They have a very specific type of immune response. Okay. And they have this memory of the response. They know what bacteria should be killed in which way. So next time when the bacteria came, they will, kill it in very seconds, in very faster, more burst from now. Okay. There are secretory proteins in case of immunity. In the case of innate immunity are your lysozymes, your C-reactive proteins, as you know, the cytokines that the complements, and in case of adaptive immunity, the immunoglobulins are secreted. Can anyone tell me the name of cell that secretes immunoglobulins?
Plasma cells.
Plasma.
Plasma cells, yes. Then comes the how the innate immunity cells or your macrophages or your neutrophils actually recognize the pathogens. So every pathogen has a a pattern of the work, how they move, what structures they have, like cilia or the flagella. Every pathogen has it, right? And these are known as a pathogen associated molecular patterns. Okay, these pathogen associated molecular patterns like your cilia, flagella, they will be recognized by these toll-like receptors present on these macrophages or the neutrophil cells. Okay, and once the toll-like receptors activated, they activates the NF-kappa B protein. And you should note that this NF-kappa B protein is actually found in an inactivated state in your cells, bonded to something known as the inhibitor of kappa B, which is I-kappa B. When the toll-like receptors become activated, they activate this, they remove this I-kappa B from the NF-kappa B so that this NF-kappa B could be activated. And this is done by the process of phosphorylation. You will add a phosphate group. You will add a phosphate group into the I-kappa B, which is the inhibitor of the kappa B, and you remove it from the NF-kappa B. So that NF-kappa B could be activated and it will lead to the release of these cytokinins and these other things, okay, which are required to destruction of the bacteria or the viruses. Okay, so that's how it is done. And you should also know, as soon as the transcription of this NF-kappa B starts, there's also the production of I-kappa B happening at the same time. And again, when the immune response is not necessary, this I-kappa B again binds to this NF-kappa B, deactivating it. Okay. Any doubt? This is very important, the toll-like receptors. And the toll-like receptors are actually the CD14 in your macrophages, okay? CD14 receptors are the toll-like receptors. Any doubt?
Yeah, can you explain that VDJ recombination thing properly?
VDJ
Oh,
recombination
समझ
part,
में नहीं आया,
you will,
sir. Repeat again,
yeah,
please.
VDJ recombination actually leads to the formation of your T cell receptors. Okay, you know that on the T cells, there are found some receptors which recognizes the CD cells. Remember? On the T cells, you found these T cell receptors which recognize your MHC, sorry, not the CD cells, but the MHC, MHC1 or the MHC2, right? So these T cell receptors are formed from this VDJ recombination. These are a set of genes. You will choose one gene from the V for the V chain, you know. You will choose one set of gene from this D part. You will choose one set of genes from this J part. There are millions of genes in the V part, millions of genes in the D part, and millions of genes in the J part. So choose one of them, and one of them from here, and you form a receptor combining them. Okay, there is a T cell receptor. And similarly, the antibodies are formed through this way. You will choose one gene from the V part, one gene from the D part, and one gene from the J part. Combining them, you will get one antibody. You will see that later in the antibody section also. I will describe this process again. Don't worry. For a clear view, you will see that later, okay? Just to have this V1, V2, V3, V100 up to. Then similarly D1, D2, D3, D100 up to. Then J1, J2, J3, J100 up to. You will choose one of the V, one of the D, one of the J, combine them and form a receptor. That's how the T cell receptors and the antibodies are formed. If you want more information, you can refer to the Kaplan also. They have a very nice diagram explaining this process in very detail. In the Kaplan immunology section, if you want to know. Okay. Any doubt?
No.
You want me to repeat this thing again?
No. It's clear.
Okay, now comes the major histocompatibility complex 1 and 2, which are your MHC, also known as the HLA genes. These MHCs are encoded by the HLA genes, which is human leukocytic antigens, which are present in every cell of your body. You know, the MHC1 especially is present in every cell of your body, all the nucleated cells except the RBCs. RBCs do not have the MHC1. Okay. And wahi the MHC2s are present on those cells of your body which are antigen presenting cells. For example, your CD4 cells, your B cells, your dendritic cells. Okay. So MHC2 present on the antigen presenting cells and MHC1 present in every cell of our body. And this MHC1 and MHC2 helps in identifying the type of organism or the organism if they're inside your body. Then they will be shown on this MHC1 and MHC2 so that your cells, your CD cells, your lymphocytes can easily recognize these antigens if they are foreign. Okay. So you need to know about the type of MHC1. This is coded by the HLA-A, HLA-B, and HLA-C. So MHC1 is coded by the HLA-A, HLA-B, and HLA-C. And the MHC2 is coded by the HLA-DP, HLA-DQ, and HLA-DR. The easy way to remember is in MHC1, you have only one letter ABC, and in MHC2, you have two letters, the DP, the DQ, and the DR. So where this MHC1 actually shows shows the receptor, yeah. Where does this MHC1 shows the receptor? They shows the receptor to the T cell receptors of the CD8 cells. Okay, T cell receptors of the CD8 cell. They present their antigen to the CD8 cells. Okay, and you can easily remember it by the fact that 1 into 8 equals to 8. And when the MHC2 cells present their receptor to the CD4 cells, the T cell receptors of the CD4 cells. Okay, you can remember it by the 4 into 2 equals to 8. So ultimately, you need it to be 8. Okay. Then in the structure of the MHC1, you have this one single alpha chain, which consists of again 3 chains, the alpha 1, the alpha 2, and the alpha 3. And there is a short beta chain, which is a beta 2 microglobulin, which is a regulatory type of chain. Okay. So the alpha chain and the beta chain, a short beta chain, which is a beta 2 microglobulin, and the alpha chain. Okay. And in the structure of this MHC2, you will have this equal alpha chain and as well as the equal beta chain. Okay. And expressions are, I've already told you that MHC1 is present in every single cell of your body. Okay. And in MHC2, they are present only on the antigen presenting cells. These are the specialized cells that present the antigen to the CD4 cells. And whenever any bacteria or any virus affects your any cell of your body, they will show its antigen of the MHC1 to the CD8 cell, so that CD8 cell can kill the virally infected or the bacterially infected cells. Okay. Then comes the function. Like I told you, whenever a virus or a bacteria affects any cell of your body, infects any cell of your body, what will happen? They will present its antigen to the MHC1, to the CD8 cell, and finally CD8 cell will kill the virally infected cell. And you should know that it must be a cytosolic protein. So any protein which is dividing in the cytosol of the cell, for example, any viral or the bacteria that can gain access easily inside the cell, they will replicate in the cytoplasm of the cell. So after replicating, what happens is, like I told you already about this proteasome thing. Remember, in the biochemistry section, I told you about this protein. What will happen when the virus or the bacteria actually dividing inside the cytoplasm of these cells? They will destroy its DNA or the protein, not the DNA, sorry, or the proteins of this virus into the smaller fragments. Now there is a protein known as the TAP protein, which is a transporter associated protein. The transporter associated with the antigen processing, the TAP protein, which does what? It will transfer the shorter peptides of the antigen into the rough endoplasmic reticulum. And in the rough endoplasmic reticulum, there present the MHC1. Okay. Within the rough endoplasmic reticulum, the MHC1, this antigen is loaded on this MHC1 and finally packed to the Golgi body. The Golgi body will pack this MHC1 and ultimately it will be presented on the surface of this infected cell. Okay, this is an infected cell and it is showing this MHC1 loaded with the antigen. Now this antigen is presented to this CD8 cell. The CD8 cell recognize it as foreign and finally kill this cell completely so that the infection could not be spread to other parts. Okay, so now you guys remember the function of this proteasome in the MHC1 processing. Someone was asking me the question, how it is involved, right? This is answer. So any antigen, any foreign antigen that is replicating inside the cytoplasm will be degraded by this proteasome into smaller parts, then loaded on the loaded on the MHC2 by the TAP proteins. Please remember the function of these TAP proteins. These are the transporters that transfer your peptides into the rough endoplasmic reticulum, and finally they will be displayed on the cells, recognized by the CD8 cells, killed by the CD8 cells. And the associated proteins, beta 2 microglobulin. Okay, so this is about the MHC1. Any doubt in MHC1? No? And then we will study the MHC2 part after a short break. Okay.
Okay.
We'll take a short break of 5 to 10 minutes. Yeah, 10 minutes. Of some bacteria which are intracellular. Can anyone tell me the name of bacteria which are intracellular?
Neisseria,
Yeah,
Syphilis.
rickettsia, listeria,
Neisseria,
syphilis, yes, tuberculosis. Remember? Yeah. So these bacteria which replicate within the cytosol of the proteins, actually really what gonna happen ultimately is that they will meet this proteasome enzyme, and what it does, it will destroy their antigen into smaller peptide fragments, and finally these peptide fragments will be will be located on this MHC1, will be loaded on this MHC1, and this MHC1 is presented outside this cell. And this is kind of a distress signal. The CD8 will recognize the signal and it will kill the cell. Okay. So that's how you fight your intracellular organisms which are replicating inside your cytosol. If the intracellular organism is replicating inside this lysosome, for example, your TB sometimes, what's going to happen is it will be loaded on the MHC2, not the MHC1. And finally, it will be represented to the CD4 cell. Okay. So for the lysosomes, for the endosomes, what's going to happen? It's a CD4 or the MHC2. For the cytoplasm, it would be MHC1. Okay. Then let's talk about how this MHC2 thing work. What happens is when the when the antigen presenting cell encounters a bacteria or a virus, they will do what? They will endocytose it. They will degrade it into the lysosomes, and finally inside the lysosome, they will load them onto the MHC2. Okay, and the MHC2 finally is presented on the cell surface to the CD4 cells. CD4 cells recognize it and they will tell the antigen presenting cell what to do next, because they are the managers of the inflammation response or the immune response. CD4 cells, they will decide if it is a T cell immunity or a antibody immunity, what kind of immunity will be active against this infection. So these are kind of a manager of the immune response. Okay, they will decide what cell to be activated, what cell to be inhibited during the immune response. Okay, any doubt in MHC2? And you should know that the MHC2 is existing in an inactivated form in the cell, and there is this invariant chain which should be removed so that this antigen could be loaded on the MHC2. Okay, and it is in the acidified endosome. Okay, and you should know that all of these antigen presenting cell will also have this MHC1 inside them. So whenever a virus is infected these cells, what's going to happen ultimately is they will represent the antigen on the MHC1 so that these antigen presenting cell can be destroyed too by the CD8 cell. For example, let's take an example of this HIV virus. Okay, so what happens is HIV infected the CD4 cells, and CD4 cells will display the HIV fragments on the MHC1. These MHC1 will be recognized by the CD8 cells, and these are the CD8 cells which are killing the CD4 cells. And that's why in the HIV you are having a very low CD4 count. You guys understand it? Why the CD4 count reduces in the HIV?
Yeah.
Okay, so all of these antigen presenting cells will also have the MHC1 inside them. If the bacteria, someone is saying something.
The last thing about this HIV thing.
Please come closer to the microphone. I cannot hear it. Please come closer to your microphone.
This last point of HIV.
I'm not understanding. Please repeat it again. A bit loudly, please.
Can you please repeat the last point about HIV?
Okay, that's everything. See, I told you that all of these cells, all of the nucleated cells have this MHC1, including these antigen presenting cells, the CD8 cells, and the CD4 cells. Now you already know that this HIV actually infects your CD4 cells, right? And when the HIV infects the CD4 cells, it will replicate in the cytoplasm of the CD4 cells. And the CD4 cells with this pathway, the proteasome and this TAP pathway, they will load the HIV fragments on the MHC1. And I told you that MHC1 is like a distress signal to the cell. So what happens is now this CD4 cell will display the MHC1 to the CD8 cells, and CD8 cells, after recognizing this distress signal, they will kill the CD4 cells. Because I told you that CD8 cells, whenever they encounter MHC1 on any cell, they will kill the cells. Okay, so CD4 cells are actually responsible to killing the CD4 cells, and that's why in the HIV you are having this low CD4 count. Okay, this is a very important concept, that it is a CD8 cells which are responsible for killing the CD4 cells in the HIV. Okay. Then you should remember what diseases has which HLA subtype. If you are a guy who is having this HLA-A3 type, you are likely to have this hemochromatosis. If you're a guy having a HLA-B8 subtype, you're likely to have this Addison's disease or the myasthenia gravis or the Graves' disease. If you're having this HLA-B27 inside you, you can develop this psoriatic arthritis, the ankylosing spondylitis, reactive arthritis, inflammatory bowel disease. The most important to remember among this is your HLA-B27, because it is responsible for the seronegative spondyloarthropathies, which are these 4 diseases: the psoriatic arthritis, the ankylosing spondylitis, the inflammatory bowel disease related arthritis, and the reactive arthritis. You will study them later in the musculoskeletal pathway chapter. The most important one is the B27. You must remember this. You should remember all of them also, but this is the most important one to remember among these. Okay, this is a table that you should remember by yourself. No easy way to learn it. You need to write them down again and again and again till you remember everything in your disease. Okay, I'm moving forward now. Then you need to know how this actually inherits. Okay, so you have a chromosome here. These are the homologous chromosomes. Okay, and this is the homologous chromosome of the father, and this is the homologous chromosome of the mother. Let us suppose that one set of this HLA genes in one homologous chromosome of the father, and this is the another set of homologous chromosome on the father. This is one set of homologous chromosome on the mother, and this is the one set of homologous chromosomes on the mother again. Okay, the HLA-A, the HLA-B, the HLA-C, the HLA-D, HLA-DQ, HLA-DR. So now you see, father either can transfer this set or this set, and mother can transfer either this set or this set. I can denote it as A, this is as B, this is as C, and this is as D. So either it could be a case of this one with this one, this one with this one, right? In this case, this blue one, let me zoom it. Okay, this is blue, this is black, this is red, and this is green. Either this blue one could be gone with the red one, or this blue one can be gone with this green one, or this black one could be gone with the red one, or this black one could be gone with the green one. So if the question is time ask you, let us suppose you have a sibling. Okay, so what are the chances that the sibling has an exact match? Let us suppose a sibling has this set of HLA genes. So what are the chances that the siblings must have this exact HLA gene match? This is 25%, right? Only one chance will be there having the same set of genes. Okay. If they ask you what are the chance that 50% of the set is identical in the sibling, this would be 50% chances. As you can see, one of the 2 sets are having this red and one of the 2 sets is having this green. Similarly, one of the 2 sets are having this, 2 of the 4 sets are having this blue, 2 of the 4 sets are having this black. So there are 50% chance that they have at least 50% of the identical HLA thing in the siblings. And what are the chances that they have exactly different set of HLA genes within the sibling? This is the 1/4 of the chance, or the 25% chances are there. Okay. So please remember the inheritance pattern of this HLA subtypes. They can ask you
From
giving
this Punnett square, these half chances are not seen. It's like, sorry, 1/4 is not seen. It's always half, no?
yeah, it's always the case that 50% times it would be one of the 2 set will be identical.
So where is that
1/4
Punnett square?
Yeah, it is like a Punnett square, not the exactly Punnett square. I'm taking as gene 1, this is gene 2, this is gene 3, and this is gene 4. Okay. So this is kind of a Punnett square you can see in this HLA subtype. This is gene 1, gene 2, gene 3, and gene 4. So you can get the combination of gene 1 with gene 3 and gene 1 with gene 4. Or you can get a combination of this gene 2 with gene 3 or gene 2 with gene 4. Okay. So 25% chance that you can have one of the 2 genes similar, 25% chance neither of the genes would be similar, and 25% chance for an exact match. So they will ask you this question. You can either remember this thing or you can remember these 1/4, 1/2, and 1/4 thing. Okay. A direct question could be made on it. I got a question on this HLA inheritance in my exam, and they were, I think they've asked about the similar case, exact match of the SLA genes, and it would be answer your this 25% is the answer. Okay, exact match. Okay, any doubt?
No.
Then comes the function of your natural killer cells. You guys should know that these natural killer cells are actually derived from the lymphoid lineage, but these are not the part of your acquired immune system. They are the part of your innate immune system. Okay, there are two type of lineages, the lymphoid lineage and the myeloid lineage. Myeloid lineage cells forms the macrophages, the neutrophils, the RBCs, the platelets, and other cells. And the lymphoid cells forms the B lymphocyte, the T lymphocytes, and the natural killer cells. Although the natural killer cells are the part of your lymphoid lineage, but they are not the part of your acquired immune system. They are the part of your innate immune system. And those cells which are not recognized by the CD8 cells, the viral infected cells or the cancerous cells which are not identified by the CD8 cells, natural killer cells identify them. What happens is sometimes cancerous cells lower down their MHC1 so that the CD8 cells cannot recognize them. But if that the case happened, if the cancerous cells lower down their MHC1, then ultimately it is recognized by the natural killer cells, and similar to the CD8 cells, they will kill these cells, by secreting the perforins and the granizymes. These are the two type of proteins which are released by the natural killer cells and as well as the CD8 cells. The granizymes makes the membrane very porous, so that the perforins make the membrane very porous so that the granizymes can be easily enter into the cell, and after entering these granizymes activates the apoptotic pathway. Okay, and as a result that virally infected cells or the tumor cells could be easily killed. Okay, so those cells which could not be identified by the CD8 cells, which means the cell which lower down their MHC1, they could be easily identified by the natural killer cells, and similar to the CD8 cell, they would release the perforins and the granizymes. Two set of proteins, perforin make the membrane very porous or permeable. Granizymes enter in it and activates your apoptotic pathway. And you should know the markers on the natural killer cells, and these are the CD16 marker and the CD56 marker. And you should know that the CD16 marker is actually for the bounding of these IgG antibodies. Remember you will see that later in the part here. Yeah, you will study that later here. That the IgG actually fix the complement and as well as opsonizes the bacteria. And they opsonizes the bacteria by, this attachment on the cell, on the B lymphocyte or the T lymphocyte or the macrophages. And this is done by the CD16 receptors. This is the Fc portion of the antibody. And this Fc portion has a receptor on the cell, which is a CD16 receptor. So the bacteria bound here and the cell bound on the, and the antibody bound on the cell using this Fc portion through the CD16 receptors. And this is done to opsonize the bacteria. You will study that opsonization part later. So you see the NK cells take part in the opsonization because they have this CD16 receptor on them. Okay, and similarly the macrophages takes part also in the opsonization because they also have this CD16 receptor. So CD16 receptor is kind of non-specific type. Okay, it is found on many cells, but this CD56 is very specific for the natural killer cells, that you should remember. Okay, and if the patient is athymic, for example, if the patient is of a DiGeorge syndrome, so they do not have these T cells, they do not have the CD4 cells or the CD8 cells, but they do have this natural killer cells to perform the same functions as that of the CD8 cells. Okay, please remember the fact that athymic patient who do not have the CD8 cells, they have these natural killer cells only. Any doubt? Any doubt regarding the CD16 or CD56 or any perforin enzymes or the function of these NK cells? And you should know the interleukin that enhances the activity of these natural killer cells. These are the interleukin 12 and the interferon gamma. Interleukin 12 actually are released from the macrophages to activate the natural killer cells. And in response, these natural killer cells also release the interferon gamma to further activate the macrophages. This is kind of a cycle. Interleukin 12 released by the macrophages activate the NK cells, and in response, NK cell releases the interferon gamma to activate the macrophages. Okay, so guys, any doubt? Please respond.
No.
No.
Okay, now the major functions of the B and T cell, like I told you, sorry, I didn't tell you now, but see, the B cells are actually a part of our humoral immunity. Your acquired immunity could be of two types, either the cell-mediated immunity or the humoral immunity. And B cells are the part of your humoral immunity, which is related to your antibodies. Okay, what happens is when the B cell recognize any antigen, because B cells are a part of your antigen presenting cells. Okay, so whenever a B cell recognizes the antigen, they will present the antigen to the CD4 cells, and in response, the CD4 cell activates the B cell to become the plasma cells. They will release many antibodies. Okay, and the antibodies will undergo the somatic hypermutations. Okay, and the class switching, which is happening in the germinal centers. Remember the germinal centers, which are some lightish parts in the follicles. This somatic hypermutations is occurring there. And the affinity maturation and the class, this somatic hypermutation lead to the affinity maturation, okay, which increase the affinity of the antigen to the antibodies, okay, and the class switching then occur, and all of these three things are going inside the germinal centers, okay. Should remember this process: the somatic hypermutation, the affinity maturation, and the class switching. All of the three things happening when antibodies are secreted and they go into the germinal centers. Then comes the T cell. There are two types of T cells, you know, the CD4 cells and the CD8 cells. CD4 cells actually the manager of the immune response after, B cells present their antigen to the CD4 cells. They activate the B cell. They decide whether it should be a cell-mediated immunity or a humoral immunity. Okay. Then the CD8 cells, which actually recognize the tumor cells or the virally infected cells. They kill those infected cells by releasing the perforin and the granizymes, similar to that of NK cells. I already told you the function of perforin and the granizymes. And you should know that this cell-mediated immunity, the CD4 cell and the CD8 cell, along with the macrophages, they are involved in the delayed hypersensitivity reaction, which is a type 4 hypersensitivity reaction, and as well as the chronic graft rejection. Okay, and some part of acute also, mainly the acute and some part of chronic, because in chronic, it is mainly the humoral immunity which is responsible. And in acute graft rejection, it is the cell-mediated immunity which is responsible. Okay, and you should know that cortisol actually causes the apoptosis of these T cells. A very important fact, cortisol, which is your steroid, actually causes the apoptosis of lymphocytes, and it increases the neutrophils in the blood, because it, actually the neutrophils are found attaching with your blood vessels. So what does cortisol does? It basically deattaches your neutrophils from the blood vessels so that they can enter the bloodstream. And this increases the neutrophil count in the blood, but actually it is disrupting the function of neutrophils, because now they cannot cross a blood walls now. Okay. So the cortisol, which increases the neutrophils, and it causes the apoptosis of your lymphocytes. Any doubt or anything you want me to repeat? No? Okay. So now the process of maturation or the differentiation of the T cells. Like I told you that T cells are actually formed in your bone marrow, and then they leave the bone marrow, enters the thymus, where the maturation of these T cells happening. Okay. So when the T cells are formed in the bone marrow, they do not have any kind of receptor over them. They're double negative cells. Okay. They do not have any T cell receptor. They do not have any CD4 receptor. They do not have any CD8 receptor. When they enters the thymus, in the cortex of the thymus, they acquire the CD4, CD8, and as well as the T cell receptor, which could bound to the MHC1 as well as the MHC2. Now, whether the cell is CD8 or the CD4, it will determine, which MHC this T cell receptor should bind. So in the cortex, it is a double positive cell which has both the CD8 as well as the CD4. And you should know that every T cell has this CD3 also. Okay. Now they undergo something known as a positive selection. They will expose to certain antigens, having this MHC1 or MHC2. Now the T cell receptor bound to which antigen, whether the MHC1 or the MHC2. According to this, they will acquire either the CD4 receptor or the CD8 receptor. Let us suppose there are some cells which bound to MHC1 only. They become the CD8 cell. And there are some cells which bound to the MHC2 very strongly. They become the CD4 cells. This is known as a positive selection. And the cells which could not bind either to MHC1 or to MHC2, they will go into the apoptosis process. They will destroyed within the cortex. Okay. Then in the medulla of the thymus, there happens known as the negative selection. Now those cells which bind too tightly or with so much affinity to the MHC, they become destroyed. They will go into the apoptosis, and this is known as a negative selection. This is to control the autoimmunity, because if the cell is binding to the self antigen very strongly, it must be destroyed within the thymus before it leaves the thymus and enters the blood vessels, right? You do not want any autoimmune cell in your blood, and that's why this negative selection happens. Whenever any cell which is going in the selection binds too much with too much of the affinity to the cell, it will get destroyed within the thymus. This is the negative selection.
Positive and negative selection.
Yeah. Repeat it again, please.
Can you please repeat positive and negative selection?
You're not very clear. Please respond it again.
Can you please repeat positive and negative selection?
Okay. Now what happens is when the when the T cells enters the thymus, they do not have any kind of receptor over them. They're double negative. Okay. As soon as they enters the cortex of the thymus, they become the double positive cell. They have both the CD8 receptors as well as the CD4 receptors, and plus the T cell receptors. Okay. Now there comes a positive selection. They would be exposed with the MHC1 or the MHC2, and depending upon how much affinity they bind with the MHC1 or the MHC2, they become either the CD8 cell or the CD4 cell. If they bind with the MHC1 with the affinity, with high affinity, they become the CD8 cell. If they bind with the MHC2 with high affinity, they become the CD4 cell. Okay. Now comes a negative selection where they're again exposed to the MHC receptors. And if they bind with too much affinity to these receptors, they will be destroyed by the apoptosis, because you do not want the self-reacting cells in your blood. If one of these cells are binding with your self receptor with too much of the affinity, then they will be destroyed within the medulla. Okay, this is a negative selection, and it is required to stop the cells becoming the autoimmune cells. And you should know that those cells, those CD4 cells which could not pass through this negative selection, they become the T regulatory cells. Okay, so T regulatory cells are actually the CD4 cells which could not pass through the negative selection. And if they pass through the negative selection, they become the T helper cells. Okay. Is it clear now?
Yes, thank you.
Okay, now in the lymph nodes, they get exposed to the antigen, and depending upon the type of antigen, like I told you, these are the managers of the immune response. Depending upon the type of antigen, they releases some interferons and the interleukins, so that they could become either Th1 cell or the Th2 cell or the Th17 cell or the Th regulatory cells. Here, as you can see, the T regulatory cells are actually the CD4 cells. Okay. Now, if they become the Th1 cell, they will activate the macrophages and the cytotoxic T cells. If they become the Th2 cells, they will activate the eosinophils or the IgEs or the humoral response, I must say. If they become the Th17 cells, they will induce the inflammation using the neutrophils. If they become the T regulatory cells, they will inhibit the immunity. Okay, they will inhibit the immune response, and this is to prevent the autoimmunity actually. Okay. And now, yeah, this is it. And like I told you, when the cells arrive at the thymus, they will turn negative. In the cortex, they undergo the rearrangement and in the beta chain of the T cell receptor, so that they can become either the CD8 cell or the CD4 cells. Then, okay. And you should know that these T cell receptors can recognize only the protein antigen. No lipid antigen can be recognized by the T cell receptors. And that's why the capsulated bacteria will have only humoral response, direct humoral response, no cell-mediated immunity. And you will study that concept later into the vaccination part when we talk about the conjugated vaccine and the capsulated vaccines. Okay. So this is a positive selection, thymus cortex. Thymic cortex, the T cell expressing the T cell receptor capable of binding the self MHC antigen will become either the CD8 cell or the CD4 cells. And if they bind with too much affinity to these MHC receptors, they will be destroyed. Okay. And the gene which is required for this negative selection is your IR gene. Okay. This is your IR gene. And if you become deficient of this IR gene, what will happen? This negative selection will fail. And as a result, these autoimmune cell will enter your bloodstream. And when these cells enter your bloodstream, what you will get is autoimmune polyendocrine syndrome 1. Okay, so it affects your autoimmunity. It will cause some polyendocrine changes. For example, the adrenal insufficiency, the hypoparathyroidism. Okay, the hyperparathyroidism, the adrenal insufficiency, you will have these recurrent candida infections. Okay, so you can remember it with a mnemonic IR with CHAR. Okay, which is chronic mucocutaneous candidiasis. You will get the oral thrush, you will get the hypoparathyroidism, you will get the adrenal insufficiency, and you will get the recurrent candida infections. So whenever you encounter a case having 2 or 3 of the following symptoms, you can immediately think about the IR mutation. Okay. Then you should know about the macrophage and the lymphocyte interaction. Like I told you, macrophage is actually an antigen presenting cell. Whenever they encounter any antigen, they will load it on the MHC2. And then MHC2, they will present this antigen to the CD4 cells. Okay, and when they present it to the CD4 cells will become the Th1 type of cells. And the interferons that released in this process are the interferon gamma and the interleukin 12. Macrophages releases this interleukin 12 to activate the helper T cells to become the Th1 cells, and in response, the Th1 cell secretes the interferon gamma and the interleukin 2. This interleukin 2 help in replicating the Th1 cells, help in replicating the CD8 cells, and help in replicating the macrophages. And this interferon gamma activates the macrophages. They will help the macrophages, to form the granuloma also. And finally, the TNF alpha is also released, which maintains the granuloma. Okay, you will study that later again in the patch section. Okay, and you should note that on the macrophages, there present the receptors for the CD40 ligand. So the CD40 receptors are present on the macrophages, and the CD40 ligands are present on the CD4 cells, and of course the CD8 cells also. Okay. Please remember the ligands on the T cells and receptors on the macrophages. And these same receptors are present on the B cells also, CD40 receptors. Okay. Then comes the cytotoxic T cells. I already told you that they will recognize the MHC1, and which could be a cell that might be affected with the virus, or it might be a tumor cell. They will recognize by the CD8 cell or the cytotoxic C cells. They will release the perforin and the granzymes, which will lead to the apoptosis of the cells. Then comes the regulatory T cells, which are actually formed from the CD4 cells. Those CD4 cells which could not pass through the negative selection will become the regulatory T cells. And if someone asks you what are the receptors present on the regulatory T cell, what are the CD markers for the regulatory T cell, then this must be CD3. Like I told you, every T cell is CD3 positive. And because they are formed from the CD4 cells, they are CD4 positive also. They have very specific markers. These are the CD25 and FOXP3. Please remember these two very specific markers for the regulatory T cells. These are the CD25 and the FOXP3 marker. Okay. And you should know that these T regulatory cells produces the anti-inflammatory cytokines, which are the TGF beta and the interleukin 10. Okay. And then you need to remember if what happened if the deficiency of this FOXP3 occur, and this leads to the IPEX syndrome, which is immune dysregulation polyendocrinopathy and enteropathy of X-linked. So this must be an X-linked disorder, only happens in the male. Okay, you will have something like diabetes mellitus in a very male infants. So you will have the diabetes mellitus. You will have enteropathy that can lead to diarrhea. You will have this endocrinopathy, which is a diabetes again. You will have the dermatitis in this scenario. So, like the name suggests, polyendocrinopathy, which includes a diabetes and any other endocrine disorder, enteropathy that can lead to the diarrhea, and it is X-linked. And of course, you have this immune dysregulation in it. Okay, and due to this immune dysregulation, you will have this dermatologic conditions also. Okay, so this is your IPEX syndrome, and it is due to the FOXP3 mutation. The CHAR is due to the IR mutation. Should I move forward now?
Yeah.
Okay, just wait for a second. I just lost my internet connection in the laptop. Okay. So now you should know, we have already talked about the interaction of macrophages and the lymphocytes, the CD4 lymphocytes and the macrophages. Now we are going to talk about the interaction of the B cells and the T cells. Okay. So as I told you that antigen presenting cells are also your B cells. There's a list of all the antigen presenting cells that you should know: the macrophages, the B lymphocytes, the dendritic cells, and the Langerhans cells. All of them are the antigen presenting cells. So now what happens when a B cell encounters an antigen? It will present that antigen to the CD4 cells, which are inactivated cells for now. Okay. So as you can see, there's an interaction of the MHC1 or the MHC2. If it is an antigen presenting cell, then this must be the MHC2 antigen. Okay. And for the MHC1, it would be a CD8 cell. So for MHC2, it would be a CD4 cell. For MHC1, it would be a CD8 cell. Now it presents the antigen to the T cell, which is a naive T cell, and it has this toll-like receptors, as you can see. Sorry, the T cell receptor, not toll receptor, the T cell receptors. Okay. And you should know that every T cell has also one receptor, which is a CD28 receptor, and it is for the B7. So now, as you see, this MHC interaction and the T cell receptor interaction, this is the first signal for the activation of T cell. And the interaction of this B7 receptor and this CD28 receptor, this is the second activation signal. Okay. And the third activation signal occurs when the cell releases the interleukins. So the three activation signal that you must remember. Okay. The first is your MHC interaction with the T cell receptors. Second is the interaction of these B7 with the CD28, and third is the release of these interleukins and some cytokines. Okay, if you get just this one signal, not this second signal, you can never activate your naive T cells. Okay, and this is a mechanism to develop the self-tolerance. Okay, so that your cells cannot be activated against the self cells. Okay. So the signal 1, which is the interaction between the MHC2 or the MHC1 to the CD4 or the CD8 cells. If it is an exogenous antigen, which means if the antigen is entered into the cell by the endocytosis, specific for the antigen presentation, this must be the MHC2 loaded, okay, and presented to the CD4 cell. If it is an endogenous antigen, which means if it is replicating inside the cytoplasm, it must be presented to the MHC1 to the CD8 cells. And then comes the second signal, which is basically the co-stimulatory signal, interaction between the B7 protein on the antigen presenting cell or the cell which are having these MHCs, and the CD28 on the naive T cell. Now, if it is MHC1, it is a CD28 receptor on the CD8 cell. If it is MHC2, then it is a CD28 receptor on the CD4 cell. Okay. Then comes the activation. After interaction of these two signals, what happens is this dendritic cells or the macrophages or the lymphocytes, B lymphocytes, releases some cytokines which activates the naive T cells finally. Okay, and in response, these naive T cells, depending upon the type of antigen, will releases some interleukins that activate either the cell-mediated response or the humoral response. Okay, and if it is CD8 cell, then what happens is this CD8 cell will releases the perforins and the granizymes to kill the virus-infected cells. Okay. Now, what happens when the CD cell get activated? Okay, the scenario after the activation of the CD8 cells, sorry, CD4 cells. So once the B cell encounter an antigen and it present it to the CD4 cell, like I told you, this 1, 2, 3 signals will occur, and finally the cell become activated. The CD4 cell become activated, and in response, it releases some cytokines. And there is one more interaction that I told you already about in the macrophage section, that the CD4 cells have this CD40 ligand on them, which is a protein, and the receptor for this CD40 ligand is found on the B cells. Okay, and this lead to and finally cytokines will release that determine the type of class switching that's going to happen in the B cells. So depending upon the interleukins, if it is an interleukin 5, then the IgA will released from the B cells. The class switching will happen so that these IgM will become the IgA. If the interleukin 4 is released, then this become the IgE antibodies. If the interleukin 10 is released, this become the IgG antibodies. So depending upon the type of interleukin is released, they become the IgE accordingly. Okay. I hope you guys understand this part. The activation of B cells or the macrophages, and finally the activation of CD cells. Any doubt? Any doubt, guys?
No. No.
Please remember the CD40 ligand and CD40 receptor thing. The co-stimulatory signals, the B7 and the CD28. They can also ask you the number or the CD marker for the B7 protein. Okay, and it is CD80. Okay, sometimes they give you the CD80, not the B7. So you can you should also remember the CD80. I remember this question in my exam, and they have given not the B7 but the CD80 actually. So you should also remember the CD80 and this CD marker for the B7. Okay. And then the class switching, the type of interleukin which causes the class switching, and what type of class switching gonna happen. You should remember everything. Okay. Then let's talk about the antibodies and their structures. Okay. You already know the antibodies has two type of chains. One is the light chain, which is this chain, and second is the heavy chain, which is this chain. Okay. So one light chain and the two light chains and two heavy chains. Okay. And all of these chains are made from the VDJ recombination, like I told you already. Okay. Some chain carry the D part, some chain carry the J part, and some chain carry the V part. And it is a combination of these VDJ which leads to the formation of this light chain and the heavy chain. Okay. And all of these things are going to happen in the bone marrow only. So during the formation of these T cell receptors or the antibodies, what's happening in your bone marrow is the recombination of the V, D, and the J chains to make the heavy chain and the light chain. The heavy chain is made up of the V, D, and J, and the light chain is made up of only the V chain and the J chain. Okay. Remember, you know, guys, understanding it?
Can you say that again?
Yeah.
Can you go over that again, please?
Okay, so in the bone marrow, during the formation of the T cell receptors and these antibodies, what's going to happen is there are some genes for the V, D, and J proteins. Okay, And what's gonna happen now? These the combination of these genes gonna happen. There is up to 100 or thousands of V gene available. Similarly, the 100 or thousands of D genes are available. Similarly, the hundreds and thousands of these J genes are available. Okay.
Okay.
And what's gonna happen? Yeah, yeah.
Go on. Go
Okay, so
on.
what's gonna happen now? Your one of the V gene is chosen, one of the D gene is chosen, and one of the J gene is chosen, and your antibody will combine them to form a heavy chain. Okay, and similarly, one of the V gene is chosen, one of the J chain is chosen. Your cell will combine it to form a light chain. Okay, these are the combination of VJ and the VDJ actually, which forms these light chain and the heavy chain. These light chain and heavy chain are made up of these only. As you can see, the J is written here, the D and J is written here, the V is written here. Okay. So these chains are made up of these proteins only, the V, D, and J. You understand it?
Yes, please.
Whether
Okay,
D
so
and
now,
J will be combined whether D and J will be in combination or it can be combined with B also. Can
sorry,
you
I didn't
understand what
understand.
I'm saying?
No, please
See,
repeat
in
it
the
again.
figure they have mentioned D and J is combined.
Yeah,
I'm asking whether B and D get combined or not.
whether V and D are combined.
Is there any chance to get a combination of B and D?
I'm not understanding what you're saying. Sorry.
Actually, V, D, and J, three genes are there,
Yeah,
no?
yeah,
In the given immunoglobulin, they have combined D and J.
yeah.
Is there any possibility to get a combination of B and D in a single chain and J
Yeah,
in
of
another
course.
chain?
Yeah, of course, of course, of course.
Oh.
This heavy
That's
chain
why I
consists of
asked.
all of the three genes. This heavy chain consists
Oh,
of all of the three genes. Okay. So you have V,
oh,
you have D as well as J in the single chain. Okay. And you
okay,
have J and V in this light chain. Okay.
okay, okay. Thank
Okay.
you.
Now, so this antibody is actually made up of, like I told you, the light chain, the heavy chain. The light chain is made up of two genes, which is the J and the L. And the heavy gene is, this heavy chain is made up of three genes, which is the V, the J, and the D. Okay. Now, this antibody has two type of regions. One is the constant region and one is the variable region. The variable region, as you can see, this is a variable region. Okay. I'm circling here. And this remaining region is actually your constant region. As you can see, it is written as CH1, the CH2, and the CH3. And similarly, it is the CL, which is a constant region in the light chain. Okay. Just a second, guys. Actually, my electricity has gone. Okay. So you have this variable region and the constant region. This is a constant region which determine what antibody it is going to be. Okay. Whether it is a IgA antibody, IgG antibody, IgE antibody, IgD antibody. This Fc region or the constant region determines the type of antigen, sorry, the antibody. And remember, in the German center, you have this class switching, right? So during the class switching, this Fc region is gonna change. Okay, during the class switching, this Fc region is gonna change so that it can become the IgG or the IgM antibody again, right? Then you have this FAB region here, which is the fragment antigen binding site, and this is the region where your antigen actually binds to the antibody. Okay, and depending upon how many types of antigen this antibody can bind, this is known as the idiotype, and you should know that one antibody can bind only up to one type of antigen. So every antibody has only one idiotype. Okay, it is not the number of antigen, but number of types of antigen antibody can bind. So idiotype is always one for a uh, for an antibody or a B cell. Okay, then comes the constant region, which has this carboxy terminals. It is has multiple functions also. First thing I told you that it shows what type of antibody it is, right? Whether it is IgM, IgD. Okay, for the class switching, you have to change this Fc region. Second thing, there's this complement binding site present on the antibody, okay, in this constant region. And again, there's a cell binding site for the opsonization is present in the antibody. So the question is, I'm going to give you a figure of this antibody, and they will ask you where the cell, where the NK cells or the macrophages should bind on this antibody, and they will mark this area, okay? And they will ask you where the complement should bind on this antibody, and they will mark this area. Please remember this diagram very carefully. They will give you the diagram. They will ask you where the macrophages should bind, where the complement should bind. Okay, so this is a constant region. This is a variable region. Antigen binds here, and this antibody, if gonna bind to any other cell, it should bind through here, and for the complement, it should bind through here. Okay. Like I told you already, the generation of the antibody diversity, which is gonna happen in your bone marrow during the receptor formation for the B cells and the T cells. You guys should know that these antibodies are actually the receptors on the B cell. You know that fact? These antibodies are the receptors of the B cell. And you should know that on the naive B cell, which is the inactivated B cell, the IgM antibodies and the IgD antibodies are present. Okay. And that's why in the bone marrow, when the receptor formation for the T cell and the B cell is happening, there is this formation of this VDJ and VJ recombination happening at the same time, you know, and that leads to a formation of receptors on the T cell and the B cell. Okay. And every antibody that is on the B cell has this same recombination thing. Okay. So one B cell can recognize only one antigen at a time. Please know this fact. One B cell can recognize only one antigen at a time, because every antibody that is present on this B cell have this same recombination. Okay. And you also should need to know the function of this TDT, which is working on the immature cells during the formation of the cells. Okay, it added some nucleotides at the end of every sequence so that multiple, furthermore diversity of the antibodies could be created. Okay. And you should know, in case of any acute lymphoblastic leukemia, because it is a leukemia for your B cells, it is always TDT positive. This is a marker for your acute lymphocytic leukemia, because in the acute lymphocytic leukemia, you have these blast cells in your blood. And in these blast cells, you have this activated TDT enzyme. Okay. Very important fact to remember. And then the generation of antibody specificity, like I told you, all of these things gonna happen in the germinal centers. First thing is a somatic hypermutation, which is a random mutations occurring in your B cells. And some of the mutations lead to the increased affinity of these antibodies to the antigen. And those mutations are selected, those antibodies are selected, and rest of the antibodies are died within the germinal centers. And this process is known as a somatic hypermutation. This process leads to the affinity maturation. And where does this affinity maturation happen? It in this variable region, because this is the region where your antigens would bind to the antibodies, right? And finally, within the germinal centers, your class switching gonna happen, which happens at this FC region. Okay, because this region determines what type of antibody it is going to be. Okay, and then you can relate it to a concept of your Staphylococcus proteus. Staphylococcus aureus, which has this protein A. And you know what does this protein A does? Instead of binding it to the antigen binding site, this protein A binded to this FC region. And as a result, the opsonization property of this antibody is lost. Okay, because for the opsonization, you need this area to be free. You need this area to be binded to a CD16 receptor to the macrophages or the NK cells, right? So if this protein A binded to this FC region instead of binding to this antigen binding site, you cannot opsonize the Staphylococcus aureus, and that is the region why this Staph aureus can gain access to your blood. You know, otherwise it could be easily destroyed by your antibodies or the cells in your bloodstream, right? This protein A actually protects the Staphylococcus aureus from being damaged in the blood because it binds to this FC region. Any doubt?
No.
I hope you understand that all of these points. They are so much confusing. I know you need to memorize them many times. But yeah, you will memorize them eventually. And you should know about this ADCC that I was talking about. This opsonization thing is known as the ADCC, which is the antibody dependent cell immunity. Okay. And you know, whenever a parasite actually enters your body, it could coated by these IgG antibodies and the IgA antibodies. And these IgG and IgA antibodies binds to the eosinophils through these Fc receptors so that the parasite could be destroyed by the eosinophils. So if the question stem asks you what kind of antibodies are involved in the response against the parasites, it is the IgG and the IgA antibodies, which fixes the cells and takes part in the ADCC. And lately, the IgE antibodies causes the hypersensitivity reactions by binding on the eosinophils. And this is also occurred through this Fc region. The CD16 receptors are present on the eosinophils. Okay. So please remember these facts also. Then we're going to discuss about the functions of the immunoglobulins and the types of immunoglobulins in your body. So there are 5 types of immunoglobulins in your body. These are the IgG, IgA, IgM, IgE, and IgD. You can remember them by the mnemonic GAMED, GAMED. Okay. And you should know the function of these antibodies. The basics, you should know that every antibody performs these 3 functions. It can either opsonize the antigen, it should neutralize the toxin, and it should fix the complements. These are the basic 3 functions of antibodies. Some of the antibodies, these 2 functions, some of the antibodies, does these 2 functions, some of the antibodies does all these 3 functions. Okay. You should know that in the lymph nodes within the gemular center, this class switching is going to happen, like I told you already. Okay, and this class switching is happening by the interaction of the cytokinins and the CD40 ligands. Remember where the CD40 ligand is present? It is present on the CD4 cell, and the receptors for this CD40 ligand is present on the B cell or either the macrophages. And finally, the cytokines are released, which determine what type of antibody class switching is going to happen. Okay. And you should know about the affinity, which refers to about the interaction between the antibody and the antigen, with how much strength the antibody should bind to the antigen. This is the affinity of the antibody. And there is one more term, which is the avidity, which is a number of antigens to which an antibody can bind at a time. Okay, number of antigens to which an antibody can bind at a time is the avidity. Okay. And can you guys tell me about a type of antigen to which antibody can bind? What does it called? The number of type of antigen to which antibody can bind. What does it call?
Idiotype.
Idiotype. And the number of antigen to which antibody can bind, this is the avidity. Okay. And affinity is basically the strength of binding. And you should know that IgG has the maximum affinity because it binds to a maximum strength with the antigen. And the IgM has the maximum avidity. As you can see, the IgM exists in a pentameric form. It has 10 binding sites for the antigen. So it has the maximum avidity. You should know some facts about the IgG. That is the most abundant antibody in your bloodstream. Okay, it does all the 3 functions. It fixes the complements. Okay, it opsonizes the bacteria, and it neutralizes the toxins of the bacteria and the viruses. You should know that because these IgGs are very small size, they can easily crosses the placenta and provides the immunity to the fetus, to the growing fetus, and of course the infants also. And these are the same antibodies which are involved in one of the disease, a bloodstream disease. Can you guys name the disease?
ITP.
Hemolytic
Yeah.
disease of newborn.
Yeah, hemolytic disease of newborn. What does it call?
RH incompatibility.
Yeah, RH. Yeah, erythroblastosis fetalis. Okay.
Fetalis. Yeah.
Because they can easily cross the placenta and can enter the bloodstream of the infant. They can destroy the RBCs. So most abundant in the bloodstream, and they have the maximum affinity because they have this free constant region which can easily bind to the cells so that it can opsonize the bacteria. Okay. Then comes the IgA, which exists in the dimeric form or maybe a single also, solo also, depending upon the locations. You should know that every mucosal tract in your body, whether it is a respiratory tract or your GIT tract, okay, they are rich in this IgA, and it is the most abundant antibody overall in your body. But it is not so much present in your blood. Every secretion in your body, which is a sweat, your saliva, or the milk, they all contain this IgA antibodies. Okay, it does not take part in the complement fixation. Okay, remember the fact, in the circulatory form they exist as a monomer, and whenever they're secreted, okay, they're secreted with this J chain and they exist in the dimeric form. And the B cells are actually present in the pair patches of your GI tract, which is the other side of your enterocytes, right? Other than the lumen side. So in the pair patches, they present these B cells which secrete the IgA antibodies, right? And they crosses the enterocyte, enters the lumen of the GI tract via process known as a transcytosis. Okay, so the crossing of these enterocytes to enter the lumen is known as a transcytosis, and during this transcytosis process they acquire this J chain, and the function of this J chain is to protect the IgA antibodies from the proteolytic action of your proteases. Okay, and in the lumen of the GI tract they protect your mucosal tracts from the viruses or the bacteria. Okay, so every virus which affects your GI tract, for example the rotavirus, they would be neutralized by these IgA antibodies, and every organism which gain access to your bloodstream, they would be neutralized by this IgG antibodies. Okay. So yeah, I think I've covered every fact about this IgA antibody. Yeah. Then comes the IgM antibody, which is actually the primary antibody. And this antibody is actually a receptor of your B cell. Like I told you, the IgM antibody and the IgD antibodies are the two antibodies which are present on your B cell surface. Okay. And you should know, whenever they are present on the B cell, it is exist in the monomeric form. Okay. Whenever they act as a receptor for the B cell, they are in the monomeric form. And whenever they're secreted, they always secreted in the pentameric form, combining with this J chain. As you can see that there is no free region available in the IgM antibody because of this J chain. They do not take part in the opsonization. But you should know that for the complement fixation, you need two antibodies should come very closer to each other in order to fix the complement. As you can see, there's very little gap in between these antibodies. So you know that IgM antibodies is a very good fixator of these complements. Okay, so complement fixation for the IgG and the IgM antibodies, and most of the complements are fixed by the IgM antibody, because as you can see the space is very narrow between every antibody, and it requires the two antibodies to become closer in order to fix the complements. And because they do not have any constant region available, they do not take part in the opsonization. Because they exist in the pentameric form, they have a very big size, so that they cannot easily cross the placenta. Okay, and these are the first antibodies that could be secreted following the acute infection. Whenever you have an acute infection of any virus or any bacteria, the first antibody to be secreted is your IgM antibody. Okay, then comes the IgD antibody now, and but we just know one fact, that it is present on the surface of B cell. Okay, then comes the IgE antibodies, which also can opsonize, and it has this Fc region free, which bind to the eosinophils or the mast cells that takes place in the mast cell degranulation, and of course the hypersensitivity reactions. And at some extent they also contribute to the immunity against the parasites, but the main antibodies which contribute to the immunity against the parasites are your IgA and IgG antibody, depending upon the location. If the parasite is a GI parasite like your amoeba or the Giardia, this means it would be IgA antibodies. And if the parasite is enters your bloodstream, this would be neutralized by the IgG antibody by opsonizing them and attaching it to the eosinophils. Okay. And you should know how these IgE antibody actually takes part in the mast cell degranulation. This is a very important thing. It happens when the antibody actually cross-links the allergen or the antigen. What happens is actually the antigen is so big naturally, right? Let us suppose this is your complete antigen, very large size. So what happens is the antibodies are actually cross-links the antigen. Multiple antibodies bind to the single antigen. This is known as a cross-linking. And when this cross-linking happens, this leads to the degranulation of the mast cells. And as you can see, let us suppose that this is the mast cell, a complete big mast cell, okay? And there is this antigen, okay? Generally, what happens is that if it's a mast cell, there is one antibody here, one antibody here, and one antibody here, and one antibody here, right? And when the antigen came closer to it, what happens is all of these antibodies gonna go to one side only to bind this antigen, right? That, as you can see. So the two things are happening. First is the receptor aggregation, as you can see here. Every antibody which was here came to here. The antibody which was here came to here, right? And this is known as a receptor aggregation. This is the first step. And second is the receptor cross-linking, as you can see here in this case. And these two things will lead to the mast cell degranulation. You will encounter a question in the UWorld or in the emboss also about this receptor aggregation thing. So please remember these two steps. First is the receptor aggregation and second is the receptor cross-linking. And that leads to the degranulation of the mast cells. Any doubt? Any doubt?
No, sir.
Okay, so we are moving forward now. Then comes the complements. Complements are very much required, especially for the capsulated bacteria, because they are very hard to kill, right? So what facts you should know about the complement? That it is synthesized in your liver, actually. Okay. They are a part of your membrane attack complex, which is very much important when it comes to a Neisseria. Okay. Neisseria is the most important bacteria which is killed by this membrane attack complex, and it is formed by the complements. Okay. And you need to remember about this CH50 test, which is a screening test for the classical complement pathway. Okay. We should know that there are three types of pathway exist. The first one is the alternative pathway. The second is the lectin pathway. And third is the classical pathway. Okay, we will discuss these pathways now. Okay, so for the classical pathway, what's going to happen is whenever an antibody encounters an antigen, whether it is a IgM antibody or the IgG antibodies, because these are the two primary antibodies which fixes the complement. So what happens is, let's suppose this is an antibody with an antigen, and this is an antibody 2 with the antigen. They came very closer to each other. Their FC region came very closer to each other for the complement fixation, like that. And this is the complement. Okay, this is your complement. So when the two FC region of the antibodies came very closer to each other, this leads to the fixation of the complement, and this is the classical complement pathway. Okay, antigen antibody complexes. Now, this classical complement pathway actually activates the C1, and this C1, just wait for a second. Okay, so this C1, when activated, it cleaves the C2 into C2A and C2B. And further, this C2B forms a protein enzyme known as a C3 convertase, which actually converts the C3 into C3A and C3B. Okay, and this C3B ultimately activates the C5 convertase, which converts the C5 into C5A and C5B. And finally, this C5B can activate the C6, C7, C8, and C9. And finally, the C5 up to C9 forms the membrane attack complex that leads to the lysis of the cell or the bacteria. You guys understand this classical pathway? It starts with the activation of C1. The C1, when activated, actually cleaves the C2 into C2A and C2B. C2B activates the C3 convertase, which converts the C3 into C3A, C3B. C3b activates the C5 convertase, which converts the C5 into C5a and C5b. And C5 further, after activating the C6, C7, C8, and C9, forms the membrane attack complex. And the membrane attack complex works like that. Let me show you the diagram. This is a normal cell. And when the membrane attack complex forms, it forms like this, a pore in the membrane. This is your membrane attack complex, like a hollow cylinder. So this membrane attack complex forms a pore in the cell so that the water can run off easily in the cell, causes a cell swelling and the cell lysis. This is how this membrane attack complex works. So this is the first thing, the first pathway. Second pathway is the lectin pathway. Now what happens is, when the mannose or the other sugar present on the microbe, on the microbial surface, came into contact with your body, what happens? A C1 like complex get activated. Now remember, the C1 actually cleaves the C2, but the C1 like complex cleaves the C4 complex, okay, into C4a and C4b. The C4 further activates the C3 convertase, and the same pathway then goes on. The activation of C3 into C3a, C3b, C3b further activates the C5. C5 further activates the C3, C6, C7, C8, and C9, and finally the membrane attack complex is formed. Cell lysis occurs. This is the second type of pathway which activates by the mannose on the microbial surface or other sugars on the microbial surface. Now, third is the alternative pathway. What happens is ki spontaneously or randomly, this C3 activates into the C3b, and this C3b via a positive feedback activates the C3 convertase. Okay, this C3 randomly activates into the spontaneously activates into the C3b, and C3b further activates the C3 convertase via positive feedback. The C3 convertase cleaves the C3 into C3a, C3b, and C3b then again can activate the C5 convertase to form the membrane attack complex. So these are the three pathways for the activation of your complements. Then you should remember the function of every complement in not every, but most of the complements. So the function of C3b is to opsonize. What happens is that C3, let me show you the diagram again. Let us suppose this is a bacterial cell and it has this capsule over it. This is a capsule of a bacterial cell. This C3 actually bind to this cell like that. And then your macrophages or your neutrophils or your other cells have the receptors for these complements. Okay, as well as the antibodies has the receptors for these complements. So either the antibodies bind to these complements like that. These are the antibodies binding to the complement, or the complements can bind to the other macrophage cells or other phagocyting cells, and that lead to the killing of the bacteria. So C3b actually takes part in the opsonization. Okay, C4a, C3a, and C5a causes the direct mast cell degranulation other than the IgE. Okay, please remember the fact C3a, C4a, C5a causes the degranulation of the mast cells directly without the IgE antibodies, so that they take part in the anaphylaxis reaction, which is a hypersensitivity reaction. Okay, your C5a is a neutrophil chemotaxis protein. Can you guys tell me what other interleukin take part in the neutrophil chemotaxis?
Leukotriene B4, interleukin 8, B4.
Interleukin 8 and leukotriene B4, right? So please remember C5a, leukotriene B4, and interleukin 8 are responsible for the neutrophil chemotaxis. And like that, the membrane attack complex is formed by the C5b to C9. Okay. And you should know that the IgG antibodies and the C3b are the two opsonins present in your body. They attach to the microbe and they will help the macrophages digesting the microbe very easily. Okay. Then you should know the inhibitors of this complement pathway. The first one is a decay acceleration factor, which is TAF. And second is the C1 esterase inhibitor. Okay, the C1 esterase inhibitor actually inhibits the activation of this C1 complement so that the pathway could be inhibited. And second is a DAF. Can you guys tell me a disease related to this DAF?
Hereditary spherocytosis. Sorry, PNH.
Not PNH.
PNH,
Paroxysmal nocturnal hemoglobin urea. Yes. because what happens in this case, that DAF is not able to function properly because of a loss of this anchor protein. And as a result, the complement factors get activated against your RBCs, and not just the RBCs, but other cells also, like lymphocytes, platelets, and other body cells. As a result, you will have this pancytopenia plus the anemia that leads to the hemoglobin urea also. Okay, so remember this DAF, which is CD55. You should remember this CD marker for the DAF, which is CD55. And there is one more inhibitor of the complement, which is a factor H. And this factor is synthesized by your liver. And sometimes what happens is these capsulated bacteria like Haemophilus influenza, Streptococcus pneumoniae, Pseudomonas, or Neisseria meningitidis, they hack this factor H, and as a result, they inhibit the complement factor so that they cannot opsonize these bacteria, and that is a mechanism by which most of your capsulated bacteria overcome the opsonization by the complement. And that's why you require the IgG antibodies against these bacteria. Okay, what happens is, like I told you already, the complements then bind to the IgG antibodies like that.
My turn.
أول كل iPad نردقي.
Oh, can I actually use this?
Please turn off your microphone.
It's charging, Galina.
Please turn off your microphone.
I'm so sorry.
Okay, thank you so much. Let us suppose this is your bacterial cell, and it has this factor H over the surface. So what happens if the complement bind to this cell? The factor H inhibits it, so that these bacteria can escape the opsonization. But if you have the IgG antibodies for these bacteria, then IgG antibodies can bind to this factor H, and now these complements can bind to the antibodies like that, so that the opsonization of these bacteria can happen. So that's why you require the IgG antibodies very much for the capsulated bacteria in your blood. Okay. So yeah, that was all about the complements. Any doubt?
No.
Now, then we move forward. Okay. Then comes the deficiencies of these complements. And first is the early complement deficiency that can lead to the SLE. Because you should know that early complements are actually required for the clearance of the immune complexes. So if you lost the early complements, that your immune complexes cannot be cleared from the body, and that can lead to the SLE. Okay. Please remember, early complement deficiencies can lead to the SLE because the clearance of your immune complexes are not happening. Then if you have this terminal complement deficiencies, remember I told you something about this membrane attack complex, that it is very much required, especially for the Neisseria bacteria. So in case if you have a terminal complement deficiencies, what's going to happen? You will have a recurrent Neisseria infection. You will have a recurrent episodes of meningitis. So whenever you encounter a teen patient having a recurrent episode, 2, 3, or 5 episodes of meningitis, you will always think about the terminal complement deficiencies. Okay. Then come the deficiencies of complement regulatory proteins, which are the C1 esterase inhibitor. What happens is if you have the deficiency of C1 esterase inhibitor, then you will get a constant activation of the complements, right? So what you will have, because you have a constant activation of the complements, ultimately all of them will be exhausted. So you will get a low level of this C4 complement and other complements also. And because you know that this C1 esterase inhibitor also inhibits the conversion of kallikrein to the bradykinin. So if the deficiency of this inhibitor happens, you will get the increased production of the bradykinin. And if the increased production of bradykinin happen, you will get the swelling in multiple areas of your body, especially your face and lips. So whenever a question stem describe a patient having a swelling, a recurrent swelling of the eyes or recurrent swelling of the face and lips, you will always think about the C1 esterase deficiency. Okay, and this is known as an angioedema, which is a non-pitting type. They will describe you this. They will tell you it is a non-pitting type edema, not a pitting edema. If you have a renal dysfunction, you will get the edema in that case also, of your eyes, of your lips, of your other body. But that edema would be the pitting edema. But in this case, in the case of C1 esterase inhibitor deficiency, what you will get is a non-pitting type edema. It is episodic type. You will get the multiple episodes of the edema. In case of renal failure, you will get the constant progressive type edema, right? Please remember this fact. And yeah, you will get the edema over the face, over the neck, over the eyes, over the lips, over the tongue. And if you get the edema of your larynx, you will get the respiratory compromise. You cannot breathe properly then, okay? So it is also very important. And you should also know that ACE inhibitors are contraindicated in this deficiency, because ACE inhibitor actually increases the bradykinin level, because ACE is a enzyme which inhibits the conversion of this bradykinin. So if you give the patient ACE inhibitors, you will get a high level of bradykinin, and that's why these inhibitors are contraindicated in this deficiency syndrome, okay? Then the paroxysmal nocturnal hemoglobinuria, like I told you, it is a deficiency of the anchoring protein, which is a GPI that anchors the DAF or the MERL, which is a CD55, or the membrane inhibitor of the reactive lysis, which is MERL CD59. So if you lost this anchoring proteins, this GPI, which is coded by the pica gene. So if you get a mutation in the pica gene, you will get a deficiency of this GPI anchors. If you get a deficiency of this GPI anchors, your DAF and MERL will no longer be able to function properly, and as a result, you will get the complement activation against your body own cells, your lymphocytes, your macrophages, you know, your RBCs, your platelets. So what you will get is a pancytopenia and, of course, the hemoglobinuria. So you will get a very dark or the red urine whenever you wake up in the morning. You will get the recurrent episodes of infections because of loss of your lymphocytes, right? And you will something known as a Budd Chiari syndrome. If you guys remember, you will get the venous thrombosis in this case also, and that leads to the Budd Chiari syndrome. Okay, you can get the hepatosplenomegaly if you get a venous occlusion of your splenic veins. Okay, so any doubt in these two diseases? Any doubt?
No, sir.
And can you guys tell me, if you get the hemoglobin urea, if you have a extravascular hemolysis? Where does the extravascular hemolysis takes place?
In the
Spleen.
spleen.
In the spleen, in
And
the
there will
liver,
be
right?
no hemoglobin urea because the
Yeah.
macrophage will consume the hemoglobin.
Hemoglobin. Yeah, exactly. Please remember this fact. Only in the intravascular hemolysis, which is happening in this case, you will get the hemoglobin urea, you will get the red urine. Okay. And of course, in order to clear the hemoglobin from your blood, you require this haptoglobin, right? And the haptoglobin is almost used in transferring the hemoglobin to the liver or the spleen. So you will get a very low haptoglobin levels. Okay. And you should also know that you knows that this angioedema could also happen in case of mast cell activation. Remember, that releases the histamine that can cause the pruritus and the edema in your body. So what is the difference between this angioedema due to the excessive bradykinin and the angioedema due to the mast cell activation? Well, the difference is a pruritus. You won't get the pruritus, you won't get the urticaria if you have angioedema due to the excessive bradykinin, but you get the pruritus as well as the urticaria in case of this mast cell activation. Okay, so that's how you can
Sir,
differentiate. Yeah.
will we get bronchoconstriction in this one, or
Yeah.
only in the mast cell activated?
In the mast cell only, not in the angio, because you are having just the edema in case of the
Okay.
deficiency, you know, no
Okay.
contraction.
Okay, thank you.
And then if there's a deficiency of this C3 complement happen, like I told you that C3 is involved in the opsonization of the bacteria. So if you get a deficiency of the C3 complement, you will have a recurrent meningococcal meningitis as well as the pneumococcal meningitis as well as the pneumonia, not the meningitis wala meningococci, because meningococci meningitis can only happen in the MAC deficiency, which is the C5 to C9 deficiency. In case of C3 deficiency, you will have this pneumococcal meningitis. Please remember this fact. Pneumococcal meningitis and pneumococcal pneumonia in case of C3 deficiency. and meningococcus meningitis in case of MAC deficiency. And if you get a deficiency of IgA, you won't see the blood infection, you won't again see the meningitis, but you can have the pneumonia. Because remember, the IgA protects your mucosal tracts. And in order to get the meningitis, your bacteria should be enter your bloodstream first, and from there it will go to your brain. Remember? So if you get a complement C3 deficiency, it would be meningitis and pneumonia, both caused due to the Streptococcus pneumoniae. In case of a terminal complement deficiency, you will get the Neisseria meningitis, and in case of IgA deficiency, you will get just a pneumonia, but not the meningitis. Any doubt? No?
No, sir.
Then you should know the function of important cytokines. And in FA, it is written in order of cells that secretes them. So first, cytokines which are secreted by the macrophages. You should know whenever acute infection happens, it always gonna be the interleukin 1, interleukin 6, and TNF alpha that's secreted first. Okay, whenever an acute infection happens, these are the interleukins or the cytokines that are first secreted, and then the interleukin 8 and interleukin 12 secreted from other cells. Okay, remember this fact. So the cytokines which are secreted by the macrophages, these are the interleukin 1, interleukin 6, TNF alpha, interleukin 8, and interleukin 12. Like I told you that interleukin 8 is a neutrophil chemotactic factor. When the macrophages encounter a pathogen, they will ask the neutrophil to come here and to destroy them, and for that they require the interleukin 8. Okay, and likewise I told you already that interleukin 12 actually activates your CD4 cells, remember, and convert them into the Th1 cells, so that the cell mediated immune response can be happens. And I also told you that this interleukin 12 activates your NK cells, and in response the NK cells releases the interferon gamma to activate some macrophages. Remember that cycle I told you when I was talking about the NK cells, that the macrophages releases the interleukin 12 to activate the NK cells. And you should know that the interleukin 1 actually who causes all of the acute inflammation. It is a cause of your fever, it is a cause of your acute inflammations. You know, it activates the adhesive markers on your endothelium, so that the transcytosis process can occur. Transcytosis process can easily occur. And you should know that the osteoclasts are also activated by the interleukin 1. Whenever your interleukin 1 is present in your body, secreted in the bone, it will activate the osteoclast for the bone resorption. Okay. Then comes the interleukin 6, which does the same thing. It causes the fever, it causes the acute inflammation, but most importantly, it causes the production of acute phase reactants or the acute phase proteins, which are the proteins which increase drastically in number whenever you encounter any infection. For example, the C-reactive protein. Remember? So the production of C-reactive protein is dependent upon this interleukin 6. Then comes the tumor necrosis factor alpha, which does the same thing. It causes the fever, it causes the inflammation. But apart from that this tumor necrosis factor alpha actually maintains your granuloma. Very important thing, it maintains the granuloma. So the granuloma is formed by the interferon gamma, which is released by the CD4 cells or the NK cells. And this interferon gamma activates your macrophages to form the granuloma. And later on, these macrophages releases the tumor necrosis factor alpha to maintain the granuloma. So whenever you give a patient any TNF alpha inhibitor drug, you always want to make sure that the patient is not having any tuberculosis. Otherwise, it will lead to a disruption of the granuloma. So and finally, your TB can spread all over your body. Okay. So remember the three things: interleukin 1, 6, and alpha can mediate the fever and the sepsis. Then the interleukins which are secreted by the T cells, and these are the interleukin 2 and interleukin 3. Interleukin 2, like I told you, will causes the replication of all the CD4 cells, CD8 cells, the NK cells, and the macrophages, and the B cells also. Okay, so it simulates the growth of helper cells, the cytotoxic cells, the regulatory T cells, and the NK cells. Then comes the interleukin 3, which actually functions in your bone marrow. It functions like the GM-CSF. which is a granulocyte monocyte colony stimulating factor. It actually causes the replication of these lymphocytes and other cells in your bone marrow. For the new cell formation, it requires the interleukin 3. Okay, and you should know that the interleukin 7 is required for the lymphoid stem cells, and interleukin 3 is required for the myeloid stem cells. So whenever the myeloid stem cell encounters interleukin 3, they start replicating and differentiating into the other cells. And whenever the lymphoid cells encounters interleukin 7, they start replicating, okay, and forms more lymphocytes and the NK cells. Then comes the interferon gamma, which is secreted by the CD4 cells and as well as the NK cells. You should know that the macrophages releases the interleukin 12, which activates these NK cells and the T cells, and in response, the NK cells and the T cells releases this interferon gamma to activate the macrophages. Finally, after activating the macrophages can form the granuloma. So you know that interferon gamma actually stimulates the granuloma formation. Then the interleukins, which are released by the TH2 cells, and when CD4 cell can be changed to the TH2 cell when the antigens are presented by the B lymphocytes mainly. Okay. And the B lymphocytes then releases, after encountering the pathogen by the B lymphocytes, this CD4 cell releases the interleukin 4, which converts the CD4 cell into the TH2 cells actually. So it is an interleukin 4 which converts the CD4 cell into the TH2 cell. It is also responsible for the secretion of these IgE antibodies and the IgG antibodies. Okay. So three functions for the interleukin 4 is to change the TH cell into the TH2 cells, class switching of the antibodies into the IgG and IgE. Okay, then comes the interleukin 5, which actually forms your IgA antibodies and it stimulates the formation of your eosinophils. So 2 functions for the interleukin 5. And all of these interleukins are released by the TH2 cells. Then comes interleukin 10, which is an anti-inflammatory interleukin. It inhibits the immune response. It is also released by the T regulatory cells, and T regulatory cells along with interleukin 10 also releases the TGF beta. And you should know the difference between the TGF beta and interleukin 10 is that both TGF beta and interleukin 10 are involved in the suppression of the immune response, but only this TGF beta actually causes the fibrosis and the wound healing. Okay. Fibrosis is caused by the TGF beta and immune suppression is caused by both of these cytokinins. Okay. So whenever you want to know the activity of your T cells, you always check the activity of interleukin 2. And whenever you want to check the activity of B cell or the B cell count, you always look for the Ig antibodies, IgM mainly. Okay. Again, the important thing. Any doubt?
No.
Then comes the respiratory burst phenomena, not a phenomena, but actually the process. And it takes place mainly in your neutrophils. Okay, you should know that 2 type of damage or the 2 type of lysis of the bacterial cell can be happen. One is the respiratory burst and second is the lysosomes. You know, the lysosomes contains these hydrolytic proteins or the enzymes which degrade any bacterial cell or any antigen, foreign antigen. Okay, so 2 things can be happen. One is the respiratory burst and second is the lysosomal destruction. And you should know that the respiratory burst is the primary response of the neutrophils and lysosomal destruction is the primary response in your macrophages. You can note down this fact that the respiratory burst is the primary response of your neutrophils and lysosomal destruction is the primary response of your macrophages. Okay, so you know, whenever you encounter a pathogen, whenever a pathogen enters neutrophils, what happens is there is an enzyme known as the NADPH oxidase, which uses the oxygen to convert it into the oxygen superradical, which is a O2 minus with our extra set of electrons, as you can see here. Okay, it is a superoxide of the oxygen. And during this process, it requires this NADPH. And that's why I told you earlier in the biochemistry section that this NADPH is required for the respiratory burst phenomenon in the process. Okay. So The enzyme is NADPH oxidase, and it is a deficiency of this enzyme that can lead to the chronic granulomatous disease. The deficiency of NADPH oxidase can lead to the chronic granulomatous disease. Okay. Then comes the superoxide dismutase enzyme, which converts this superoxide into the hydrogen peroxide. So the enzyme name is superoxide dismutase. Then comes the enzyme known as a myeloperoxidase, which converts this hydrogen peroxide into the hypochloride, okay, HOCl. And this HOCl can damage the bacterial cell. Actually, this hydrogen peroxide, this superoxide, and this HOCl, all of them can damage the bacterial cell, okay? You should know. And one more thing that is going, which is not mentioned in the first aid here, which is the formation of this nitric oxide. And this nitric oxide is formed by the conversion of this arginine into the citrulline, like I told you into the biochem section, that this arginine is converted into the citrulline and it releases the nitrogen oxide, which also takes part in this respiratory burst to kill the cells, okay? Nitrogen oxide is very toxic, actually, that kills the bacterial cell. And you should know that it is this enzyme, the myeloperoxidase, which carries a green color. You know, it is green in the color, so that whenever you have a sputum, it is always of green color because of this myeloperoxidase enzyme. So they will ask you a question, they will give you a patient, and they will tell you that the sputum of the patient is green, and they will ask you what pigment is responsible for the green color of this sputum. So you will tell them about this myeloperoxidase. Please do not confuse between the pseudomonas pigments, the pyocyanin, pyoverdin, which gives the sputum green color. Okay. Do not confuse between the myeloperoxidase and the pigments of the pseudomonas. If you get a pneumonia, it could either caused by the pseudomonas or some other kind of bacteria. If they want to give you a special case of pseudomonas, they will tell you that this must be a hospitalized patient or this must be an immunosuppressed patient. And if they ask you what gives the green color, then you can tell them it is a pseudomonas. But if they give you a general case of pneumonia, like a community pneumonia, and if they ask you what gives it the green color of the sputum, you will answer the myeloperoxidase. Okay. So what happens if you become deficient of this NADPH oxidase? Then your respiratory burst would be stopped. You cannot form this hydrogen peroxide, right? And you cannot destroy the bacterial cell. But actually what happens is there are some bacteria which are catalase negative. And like you remember from the biochemistry section that in the peroxisomes, you have this catalase enzyme that converts the H2O2 into H2O, remember? So what happens if the bacterial cell is catalase negative, then the waste product of the bacteria is actually the hydrogen peroxide. Please remember the fact that waste product of the bacteria is the hydrogen peroxide. Now, if the bacteria is catalase negative, then your cell still have this enzyme myeloperoxidase, which can convert the H2O2 into the HOCl, and it can still destroy the bacterial cells. But if the bacteria has this catalase enzyme, then they convert their waste H2O2 into the H2O very easily, right? And as a result, the neutrophils cannot destroy these catalase positive cells, which are your Staphylococcus aureus or the this Aspergillus and other bacteria. You will study about them later, about the catalase positive bacteria. But just know if you become deficient of this NADPH oxidase, then you can still fight against the catalase negative infections, but you cannot fight against the catalase positive infections. And as a result, what you will see, multiple granuloma, recurrent granuloma formation. That's why the disease name chronic granulomatous disease. Okay. Then you should know about this potassium influx thing. Whenever the oxidative burst happens, it also leads to the potassium influx inside the cell, which releases the lysosomal enzyme also. So along with the respiratory burst, you always get the lysosomal killing too. Okay, then there comes a lactoferrin, which is a protein that is found in your secretory fluid that sequester your iron, so that the bacterial cell cannot feed on the iron. Okay. So remember about this potassium influx and the lactoferrin thing. Lactoferrin is basically a protein which chelates your iron, sequesters your iron, so that the bacterial cell can never feed on the iron. Any doubt on this respiratory burst?
No.
No, okay, good. And you can also see the pathway of your glutathione reactions. You know, this glucose 6-phosphate dehydrogenase deficiency, how this glutathione acts to convert this H2O2 into the H2O to protect you from this reactive oxygen species. You can see here. And if they ask you what two type of enzymes or the proteins are responsible for protecting you from this this oxygen reactive species, so you name them the glutathione reductase, which is the first thing, and second is your superoxide dismutase. Please remember these two enzyme names. The glutathione, because superoxide dismutase converting your superoxide into the H2O2, as you can see here. Okay, so it is protecting you from these oxygen free radicals, reactive oxygen species. Okay, so it has a protective role actually in your body. Superoxide dismutase and this glutathione reductase. If the question is time ask you what enzyme or what proteins protect you from these oxygen free radicals, you will answer the superoxide dismutase and the glutathione reductase. Please do not confuse between any other enzyme. Just these two enzymes are responsible for the protection against the reactive oxygen species. Okay. Okay, guys.
Yes, sir.
Okay.
Okay, then we study about these interferons after a short break, I guess. Okay.
Thank you, sir.
Yes.
Is it 10? Is it 5 or 10 minutes?
Respiratory burst, and we're going to start with this interferons. So you should know that there are two type of interferons are available. First are the type 1 interferon, which includes the interferon alpha and interferon beta. Second are the type 2 interferons, which are interferon gamma. Okay, you already know the function of this interferon gamma. It is required for the activation of macrophages. It is required for the induction of this granuloma. Okay, now you should know the function of this interferon alpha and the interferon gamma. So whenever a virus infected a cell, these virally infected cells releases these interferon alpha and the interferon beta to to signal the non-infected cells that the virus is coming. And what happens is they will start forming some proteins inside the cell, some proteins against the viruses that can kill the viruses. Okay. Secondly, they inhibit the formation of protein synthesis inside the affected cell that is affected with the virus. Okay, so there's the two things. They signal the cell that the virus is coming, and they will start forming some proteins against the viruses inside the cells, against the inside the non-infected cells. Okay, and then they inhibit the protein synthesis machinery inside the virus infected cells so that the virus cannot replicate itself inside the cells. Okay, two things. Now, so let's study a part of the innate host defense.
Can you please
Interferons.
repeat again, Dr. Bhanu? Can you please repeat
Yeah.
again? Thank you.
Okay, so we have the two type of interferons, like I told you, the type 1 interferons and the type 1-2 interferon. Type 1 interferon have this interferon alpha and interferon beta, and type 2 interferon is interferon gamma. So you already know the function of this type 2 interferon, the interferon gamma, which activates the macrophages, okay, and induces the formation of granulomas, right? Secondly, you have this type 1 interferon, which is interferon alpha and interferon beta. What does the interferon does? They're actually secreted from the virally infected cells, the cells which are infected by the viruses. These cells secreted these interferons, and the interferons finally signals the non-infected cells that the virus is incoming, and they start forming proteins inside the non-infected cells against the viruses that can kill the viruses, right? And plus, apart from this function, they also inhibit the synthesis of the proteins inside the virally infected cells. So in the non-infected cells, they form the proteins against the viruses. Inside the infected cells, they stop the protein synthesis machinery so that the viruses cannot use the machinery for their own synthesis of the proteins. Okay. Okay. Do you want me to repeat it again?
No, it's okay. I got it. Thank you.
Okay, and you should know these interferons are the glycoproteins again. Okay, they will down-regulate the protein synthesis in the affected cells to resist the viral replications. Okay, and of course they also upregulate the MHC. Yeah, this is a very important question. Examiner gonna ask you what does the interferon do with the MHC? Either they increase the MHC expression or they decrease the MHC expression, and what type of MHC they will increase the expression of, either the MHC1 or the MHC2. So you should know that the interferon gamma can increase both the MHC1 as well as the MHC2 expression, while the interferon alpha and interferon beta can increase the expression of MHC1 only. Okay. And you can see the type 1 interferons increases the MHC1 expression, while type 2 interferon can increase both the MHC1 and MHC2, while MHC2 mainly. Okay. Please remember these 2-3 facts about the interferons and their clinical uses. They used in the hepatitis B viruses to activate the immune response. They used in the Kaposi sarcoma treatment. They used in the hairy cell leukemia treatment, condyloma acuminata, renal cell carcinoma, malignant melanoma, and other things. And once you give these interferons to the body, to the human, what's going to happen is immune response going to take place, right? So you will get some flu-like symptoms, sometimes a depression, the neutropenia might be there, myopathy, and the interferon-induced autoimmunity sometimes going to also happen. Okay. So please know the function of these interferons. Any doubt? No? Okay. Then comes the cell surface proteins or the CD markers that was keep on coming. Now we're going to study them. And first thing that you should know, how you're going to recognize the CD markers, what test you uses, what tests are being used to recognize the CD markers. So you already know about this flow cytometry, which is the most common test that we use nowadays for the CD markers. Second thing, you can use the immunohistochemical stainings. Third thing, you can do the Western blots. Please remember these 3 names for the CD markers or the CD proteins, because you know that for the protein detection, you use the Western blots, right? You can also use the immunohistochemical stainings against the CD markers, and you can use the flow cytometry also. Then the surface markers for the T cells, you know that all T cells have this CD3 on their surface, which is associated with the T cell receptor. So every T cell has the T cell receptor and the associated CD3 protein. Plus every T cell also had the CD28. Remember that binds to the B7 on the antigen presenting cell, and that is a second signal. If you guys remember, the first signal is the binding of MHC with the TCR, and second is the CD28 binding with the B7. So every T cell is positive in these 3 receptors. Now the helper T cells are positive in the CD4, okay, and the CD40 ligand, like and then the receptors CXCR4 and CCR5, which are the co-receptors for the HIV. Okay, CXCR4, CCR5 are the co-receptors for the HIV found on the T helper cells or the CD4 cells. So ligand, CD40 and CD4. Okay. Then the cytotoxic C cells are positive for the CD8 cells. Are the CD8 positive. Okay. Then comes the regulatory T cell. Like I told you already, it is they are all positive in the, apart from these 3, TCR, CD3, CD28, they are also positive for the CD4 and CD25. Okay, and they're also positive for one more thing, one more protein, guys. Remember the name?
Fox
The deficiency?
FOXP3.
FOXP3. And what syndrome?
Apex.
IPEX syndrome. Okay, please remember. Yeah, exactly. Then comes the B cell. And you know the receptors of the B cell are the antibodies. Remember? So they are all positive for the antibodies. They are positive for the 19, 20, and the 21. And you should know that the CD21 is a receptor for the Epstein-Barr virus. And that's how the Epstein-Barr virus affects your B cells. Okay, and like the CD40 ligand is present on the helper T cell, the CD40 receptor is present on the B cell. And because B cells are the antigen presenting cell, they are rich in, they are also positive for the MHC2, right? And they're also positive for the B7, which is the receptor for the CD28. Okay. Then comes the macrophages. Macrophages is also positive for the CD40, just like your B cells. and they are also positive for the CD14. Like I told you that the toll-like receptors are actually your CD14, which recognizes your PAMP. What are the PAMPs?
Pathogen associated.
Molecular patterns. And what are these? The lipopolysaccharides, the flagella on the bacterial cell, the capsule of the bacteria, right? And of course, they are positive for the CCR5. So you can see the CCR5 is present on both the T helper cells and the macrophages. Okay. And HIV2 actually affects your CCR5 and HIV1 for the CXCR4. If I'm not confusing between HIV1 and HIV2, then yeah. CCR5 for HIV2 and CCR4 for HIV1. Okay. And of course, because they are antigen presenting cell, they're positive for MHC2 and B7. And because they they do the opsonization, so they are positive for the CD16, which is a receptor for the FC portion of the antibodies. And of course, they have the receptor for the complement binding also. And that's how the the opsonization is done. Okay, for the CD16 and C3b. Then the NK cell only two, CD16 and CD56. CD16, you remember the receptor for the FC portion of the IG, and CD56 is actually a very specific marker for the NK cells. And every hematopoietic stem cell, which is a stem cell in your bone marrow, is positive for this CD34. Very important. Okay. And then there is a drug, the rituximab, which is used in the treatment of multiple myeloma. You direct it against a CD20 because in the multiple myeloma, it is a B cell tumor. So you use a drug rituximab against the CD20 receptors. Okay. And so you also know that CD40 is non-specific, not specific for macrophages or the B cell, but a non-specific. CD14, CCR5 receptor is very specific, and CD14 receptors are very specific for the macrophages and the monocytes. Okay, 19, 20, 21 is specific for the B cell. CD4 is non-specific because it is present on both the helper cells as well as on the regulatory cells. But CD25 and FOXP3 is very specific for the regulatory T cells. Okay. And CD40 ligand is again very specific for the helper T cells. So they will ask you the non-specific receptors and the specific receptors that you can get from this table. Okay. Any doubt?
No. Can you repeat the specific markers?
Okay, so as you can see that CD40 receptor is present on both B cells as well as the macrophages. So it is not specific for any type of cell, right? But the CD19, CD20 and CD21 receptors found only on the B cell. So they are the specific markers for the B cell, and it is a non-specific marker for the B cell. Similarly, MHC2, B7 present on both the macrophages as well as the B cell. That's why it is again a non-specific marker, right? Similarly, the CD14 receptor is present only on the monocytes and the macrophages, which are the same cells. So CD14 is very specific for the macrophages. Okay. Similarly, the CD56 is very specific for the NK cell. 16 is non-specific for both macrophages and NK cells. CD34 is very specific for the hematopoietic stem cells. Similarly, this CD40 ligand is very specific for the helper T cells. CD25 is specific for the regulatory T cells. Okay. Remember these facts. What are the specific and what are the non-specific markers? Then comes the energy, which is basically a self-tolerance. Like I told you that two signals are necessary for the activation of your immune cells. First is the binding of this MHC with the T cell receptors, and second is the binding of this B7 or the CD80 with the CD28, right? If one of the two signal is lost, then your cell can never be activated, right? And this is a mechanism of cell tolerance. Okay. Because your every cell has this MHC1. Every time, all the cells in your body are expressing the MHC1, and this MHC1 is loaded with the self antigen. But in case if this MHC1 is loaded with the foreign antigen, then only your CD8 cell can be activated because of these two signals. Okay, so signal 1 is always present, but you need the signal 2 to activate the B or the T cells, and this comes as the energy. That is a self-tolerance. Okay. Then comes the passive and the active immunity. Active immunity, which forms inside your body after exposing any antigen or a vaccine. And passive immunity is when you receive the preformed antibodies in your body. Okay, and because you're already receiving a preformed antibodies, it must be rapid. And in active immunity, because antibodies needs to be formed, it is very slow. Duration is very short. It is a very short-lived. It forms very rapidly and finish very rapidly. But the active immunity forms very slowly and it provides you a very long-lasting protection. Okay, that is a memory. If you remember, the second time when the person enters, it is a very heightened immune response, if you know, right? Then comes the example for the passive immunity, the mother's milk that provides IgE antibody, the placenta that provides IgG antibody, and every antitoxin, for example, the tetanus toxin that you give to the patient, it is all example of passive immunity. The active could be either due to a natural encounter of the bacteria or the pathogen, or it could be due to the vaccines, or it could be due to toxoid vaccines. Okay, and you should know that sometimes you have to give both the active as well as the passive immunity to the patient. For example, in case of rabies or in case of hepatitis B, first you give the patient the passive immunity by giving them the antibodies, preformed antibodies. Then you also need to vaccinate the patient against them. So rabies or the hepatitis B are the example of both the active as well as the passive immunity. Okay, and here given the examples. The tetanus toxin that you give to the patient are the example of passive, because you give the IgG antibodies against the tetanus toxin, the preformed bodies. Similarly, the botulinum toxin, the hepatitis B virus, the varicella, the rabies, the diphtheria. In all these cases, you give the patient preformed antibodies, and all of them are the example of passive immunity. Any doubt?
Sir, can you explain that energy?
Okay, energy is basically a self-tolerance. The immune cells in your body are not active against your self antigens, as you know. Okay, and when this energy is lost, you see what the autoimmune disease is, right? So there is some kind of a some kind of a system is there to stop the cells from acting against the body own cells. Okay, and this is the energy, right? As I told you that you need two signals in order to activate the B and the T cells. One signal is basically your MHC2 when shows the antigen on the T cell receptors, and second is the binding of this B7 protein with the CD28 receptor, right? So if you do not get the second signal, if you get only just the one signal, your cells can never be activated. Okay, and this is a mechanism made inside your body to prevent the cells from active against your body own cells, and this is the energy. When the energy is lost, what you will see are the autoimmune diseases. Okay, it's nothing but just a self-tolerance, a mechanism of self-tolerance. Okay.
Okay. Okay, thank you, sir.
Okay, then you should know what's going to happen with your immune system as you go in the aging. Okay, and this is termed as the immunosenescence, changes that are going to happen inside your body as you age. Okay, so the number of naive B cells, which are the immature B cells, gonna go decrease. Okay, but the quantity or the quality of the antibody will remains the same. So the number of naive B cells or the immature B cells which never encountered any pathogen gonna go decrease, but the quality of the antibody production will remain the normal. Similarly, the production of naive T cells will be decreased, and the memory cells, because as throughout your life you're gonna keep on encountering the pathogens. There is always some level of inflammation going inside your body, right? Every time some kind of a pathogen is being entering in your body, right? So every time all of these T cells or the B cells are keep on converting into the memory cells. So the number of memory cells with the aging is going to go increase, but the production of the immature cells will be decreased. The macrophages, the function of macrophages will be decreased. Their phagocytic ability will be decreased. Their cytokine response will be decreased. Similarly, the neutrophils, their chemotaxis ability will be decreased. Phagocytosis will be decreased. Free radical formation will be decreased. Dendritic cells, their antigen processing power will be decreased. Their cytokine response will be decreased. And the NK cells, again, their function will be decreased. So the only thing that remains constant is your antibody quality. Okay, and everything is going to go decrease, and the memory cells will be increased with the aging. So remember this flowchart, they're gonna ask you, and this is the reason why you get the vaccine failure, because you are decreasing your naive B cell production, you are decreasing your T cell production. So no new antigens could be processed very rapidly, and that's why you get the vaccine failure in the aging. So they will give you a scenario where there is an old patient, and you have given him the vaccine, and but he again, gets an infection. So they will ask you the reason why the vaccine failure is occurring in the patient. So they will give you some some options like loss of naive cell production and increase in the memory cell production, change in the antibody quality and something like that. So we will choose a respective the right option from this flowchart. Okay, so yeah, this is it about the immunosenescence, and the vaccine failure is due to it because of the age-related decline in the immune response. Okay, then comes the type of vaccines that you should remember. Okay, and so there are 4 type of vaccines are available. The live attenuated vaccines, in which you take a live virus, you kind of takes it a power of causing the damage, and you give and you make the vaccine out of it. So this is a live attenuated vaccine where the microorganism loses its pathogenicity, but it's it still retains its capacity to induce a formation of immunity. Okay, then comes the killed or the inactivated vaccines, where you kill the complete virus or the pathogen and you uses its antigen to get an immune response. Third one are the subunit or the conjugate vaccines. It is especially for those type of proteins which are lipids. Like I told you, your MHC can recognize only the proteins, not the lipids. So in order to get both the B cell and the T cell immunity, you require some kind of a protein, right? So he uses a conjugate vaccine, in which a conjugate is a protein to which your cells can activate and heightens your immune response. So subunit or the conjugate vaccine is especially used for the lipid antigens. Then comes the toxoid vaccines against the toxins of the bacteria. So we'll discuss every one of them one by one. So first come the live attenuated vaccines. Like I told you, the organism will lose its pathogenicity, but retains the capacity for the transient growth within the inoculated host. Okay, so it will causes the immune response, and you should know that both the humoral as well as the cell mediated immune response going to happen after this vaccination, and it provides you with a long lasting immunity. Okay, but you should know that you cannot give the live attenuated vaccines in any immunocompromised host, because if you give them in the immunocompromised host, then the bacteria or the virus or any pathogen you give will become reactivated. Okay, but there are some 2 vaccines, the MMR vaccine and the varicella vaccine, that can still be given to the HIV patient without any evidence of the immunity. Okay, and yeah, the pros, of course, because it induces a very strong immunity, it provides you with a lifelong immunity. Cons, that often it is contraindicated into the in the pregnancy, and secondarily in the immunodeficiency, because you can get a reactivation of the virus or the bacteria. You cannot give these vaccines to the immunocompromised host. Okay, and if you give a patient any BCG vaccine, you should know that after giving the patient BCG vaccine, it will become the tuberculin positive. So if you do a PPT skin test to a patient who has taken the BCG vaccine, it will show PPT positive, even though it do not have any a TB infection. You can remember this fact. And how you should learn the name of these all these vaccines, I will tell you later. Just know them for now. All of the adenovirus, especially this adenovirus vaccine is actually developed by the military, and in this adenovirus vaccine you give a live virus, not the live attenuated, but the live virus is introduced into the GI tract of the humans, and as a result what they will get is a diarrhea, nausea, vomiting, but you're actually protecting their respiratory tract from this virus. Once you give the virus to the GI tract, they will get a diarrhea, but they will they will develop the immunity against this virus completely. Okay, So remember the case of this adenovirus. It is a non-attenuated live virus that is given to the military recruits by the military to protect them against the pneumonia caused by the adenovirus. Okay, then the typhoid vaccine, the polio, the varicella, smallpox, BCG, yellow fever, MMR, rotavirus, all of them are the live attenuated vaccine. I will tell you how to learn the names. Then comes the killed or the inactivated vaccines. Okay, and they mainly induces the humoral response, not the cell mediated, but the humoral response, because you are killing the pathogen, you are just using its antigen to get the immune response. Okay, and this, of course, the response is often very weaker than the live attenuated, of course, and it is for a shorter duration of the time, so you require the booster doses, of course. Okay, but it is safer than the live attenuated because you never get the reactivation of the virus. You can even give them the immunodeficient patient. Okay, and these are the hepatitis A, the typhoid, the rabies, the polio, and the influenza vaccine. And how you can remember the name of these vaccine? It is by the mnemonic a trip that could kill you. A, the hepatitis A. T, the typhoid, which is the intramuscular vaccine. VI polysaccharide vaccine. Okay, the rabies vaccine, the influenza vaccine, and the polio vaccine. A trip that could kill you. Okay, please remember the mnemonic and the names. A trip. And most of time they're going to ask you about this rabies vaccine. There would be a patient who got bitten by the dog or by the cat and he developed the rabies, and they will ask you what kind of vaccine could have prevented this from happening. So this would be a rabies vaccine, which is a killed or the inactivated vaccine. You can remember this by the mnemonic trip, a trip. Okay, and please note down one more fact, that all of the live attenuated vaccine you give is by the real root of the bacteria, of the pathogen itself. For example, if there's a pathogen who affects your respiratory tract, you give them by the intranasal route. If there's a pathogen who affects your GI tract, you give them by some other route. If the pathogen affects your bloodstream, you give them by the IV route. Okay. For example, the typhoid, which is salmonella, which affects your GIT, you give them by the oral route. Okay. And similarly, the adenovirus affects your GIT, you give them by the oral route. Okay. And similarly, the influenza affects your respiratory tract, you give them by the intranasal route. But all of these vaccines, the killed or the inactivated vaccine, you always give them the intramuscular or the IV route only. Intramuscular or the IV route only. Then comes a subunit or the conjugate vaccine. It is for those bacteria or the pathogens that has this lipid or maybe the capsule. So it is the vaccines for all the capsule. Yeah, someone say something? No. Okay, so this conjugate vaccine is only for those capsulated bacteria, which are your Neisseria meningitidis, Streptococcus pneumoniae, Haemophilus influenza. Okay, and other than this, you should remember this acellular pertussis, which is a part of your DTaP vaccine, is actually a subunit or the conjugate vaccine, pertussis. Okay, then the hepatitis B virus and the human papilloma virus are also the conjugate vaccine. Now, what you will do in the conjugate vaccine, you actually uses one of the conjugate, which is a protein that could be binded with these antigens. Okay, and this conjugate protein could be a toxoid of your the tetanus toxoid or the diphtheria protein. So what happens is this protein actually causes both the humoral as well as the antibody response. But please note that this humoral or the antibody response is not against the conjugate protein, but against the antigen that you are using with the conjugate. Okay, so you are using an antigen and the conjugate, you are attaching them, introducing them in the body, and finally both the humoral as well as the cell mediated response can be formed against the antigen that you are giving against these pathogens. But immunity do not develops against the conjugate protein that you are using. And the most commonly conjugate protein you use are the Neisseria proteins. The proteins on the Neisseria, the OMP. You will say that later into the microbiology. OMP of Neisseria is used for the conjugate vaccine. Then some tetanus toxin proteins and some diphtheria proteins also could be used as a conjugate. Okay, remember the names, all of the capsulated organism, the Neisseria, the Streptococcus pneumoniae, the Haemophilus influenza, and apart from these, the two viruses, which are human papilloma virus and hepatitis B virus. Then the toxoid vaccine, which are formed against the toxins of these Clostridium tetani and the diphtheria. Only two, the tetani and the diphtheria. And how can you remember the live attenuated vaccines after every of these vaccine, after the ATREP, after these two, and after these vaccines, the remaining vaccines are the live attenuated vaccines. There is no easy way to learn them other than this. You should remember these three names, the three category names, and the rest are the live attenuated vaccine. Any doubt?
No, sir.
Am I audible? Any doubt?
Yes. No, sir.
No, okay.
Okay, and another important thing that you should know, if you give a vaccine by the oral route, it stimulates mainly the IgA response. Okay. And if you give a vaccine by the intramuscular route, it mainly stimulates the IgG response, because you know in the intramuscular or the IV route, the pathogen is entering in your blood, and in your blood, the main antibody is your IgG, and in your respiratory tract or the mucosal tract, the main antibody is your IgA. So by the oral or the intranasal route, even it is your IgA response mainly, and in your intramuscular vaccine, it is your IgG response. Okay. So they will ask you if you give a patient a vaccine through the the oral route, in what type of antibody does this route differ in? So you will so they are asking you what kind of antibody would be there in in the highest amount. So this would be your IgA antibody. Okay, remember this fact. Then we will talk about the hypersensitivity reactions. There are these four type of hypersensitivity reaction that you should remember: the type 1, the type 2, the type 3, and then type 4 hypersensitivity reaction. Okay, so let's talk about them one by one. So what happens in the type 1 hypersensitivity reaction? It is mediated by the IgE antibodies, okay, the mast cells and the eosinophils. Okay, IgE antibodies, mast cells, and the eosinophil cells. Okay, so what happens whenever an allergen enters your body? They in the very first time, the process that I told you earlier, they will recognize by the macrophages. They will take you to the the CD4 cells. CD4 cells become the TS2 cells. They will release this interleukin 4, which will release the IgE, and now the IgE is made up. Okay, and again the interleukin 5 is released, which makes up the eosinophils against this allergen. Okay, so this is a first encounter. So whenever you encounter the first time any antigen, no response gonna happen, no symptom you will feel. It's just a formation of IgE antibodies and the eosinophils will happen. Okay, now what happens is these IgE antibodies will attach to the mast cell surfaces and prime the mast cells against these allergens. So next time what happens when you encounter the allergen, these mast cells, what you say, the receptor cross linking will happen, and the aggregation of these IgE antibodies will happen, and that leads to the mast cell degranulation. Remember the two steps: the aggregation of the receptors and the receptor cross-linking will happen. That will lead to the degranulation of the mast cell. And after the degranulation, the mast cell will release the histamine, which is a vasoactive amine, and the tryptase. Remember the two names: histamine and the tryptase. And you should know that tryptase is an activity marker of the mast cells. You will check the tryptase level in your blood, and if it is raised, you will see that the mast cells are activated. Okay, so once the histamine is released and the tryptase is released, what you will see is the urticaria, the pruritus, the bronchospasms that you will see is due to this histamine. So this is the immediate reaction in the anaphylaxis or any type of hypersensitivity. This is the immediate reaction. Now, what happens after 2 to 10 hours later? Because you have this interleukin 5 and interleukin 4 is secreting, they will attract the eosinophils. And once the eosinophil is reached, they will release their major basic proteins, which are very toxic to the tissues, and that will lead to the cell damage. So first damage is caused by the histamine, which is very, acute, very immediate. And hours later, the eosinophils will start damaging the cells and causing the inflammations and the tissue damage, as you can see here. Okay, so two phases: the immediate phase and the late phase. Please remember the cell names, and it's not just the eosinophils, but every cell in your body is involved in that. Okay, that includes your macrophages, the monocytes, the neutrophils. Every cell is involved in the late phase of this type 1 hypersensitivity reaction. Okay, the interleukin 1, interleukin 6, TNF alpha is responsible for this late phase reactions. The leukotrienes like leukotriene B4, C4, D4 is responsible for the damaging your respiratory tract and recruiting the neutrophils. The prostaglandins, the interleukin 3, okay, interleukin 5 and interleukin 8 is also responsible. So now the examples of this type of hypersensitivity reaction, any food allergies, any drug allergies, any bee sting, anaphylaxis, which is very important because now the allergen is entered in your bloodstream. And as a result, you will get the vasodilation, the leaking of, increase in the vasopermeability. So what you will see is the shock, anaphylactic shock, as you remember. You will get the bronchospasms, respiratory distress would be there, hypotension would be there, tachycardia would be there, and ultimately it can even lead to the death. The allergic asthma that you will is a type 1 hypersensitivity reaction. So the first time when you encounter the pathogen, the mast cell degranulation will occur. You will get the bronchospasms, and in the delayed phase, you will get this inflammation thing. To control this delayed phase reaction, you uses the steroids that the cortisol and other drugs. And to control the immediate phase, to relieve the bronchospasm caused by this histamine, you uses the beta drugs. Okay. And what are the symptoms again? The wheal and the flare reaction. Remember the urticarial rash, which has this central pallor and this peripheral erythema. In the center, it is a very pale region. And in the periphery, you will get this reddish rash multiple areas of your body, and plus the pruritus, the hypotension, the respiratory distress after some kind of a bee stung, or maybe after ingesting a food, or it might be a drug. Okay. So this is a type 1 hypersensitivity reaction. In doubt? Just remember the cell names that are involved, not just the eosinophils, but every cell is involved. Remember the type of interleukins, the type of interleukin that secretes these IgE antibodies, the type of interleukins which secrete these eosinophils. Okay, the role of histamine in the type 1 hypersensitivity at the intermediate phase, the role of mast cells, the degranulation thing, how this happened, the examples that anaphylaxis can cause it, certain drugs which cause a type 1 hypersensitivity reaction like the penicillins. Okay, the bee stung, the food allergy, and the asthma. Of course, they will give you a case of, they will give you a symptoms of all of these type 1 hypersensitivity reaction. They will ask you what kind of cells are involved or what kind of a reaction is this. So you should know the symptoms and the reaction name. Okay, any doubt? Any doubt, or you
Sir,
want me to repeat it?
No, sir.
So one thing, sir,
Yeah.
urticaria is a type 1 hypersensitivity.
Yeah.
Okay, thanks.
Pruritus and radix rash on your body. Will study that later in the section of your skin, the derma section.
Okay,
You will study about the urticaria, the edema, the radix rash, and the circular area. This is an example of a type 1 hypersensitivity. Okay. Then comes a type 2 hypersensitivity reaction, and in this type of hypersensitivity reaction, your IgG antibodies and IgM antibodies are involved. And as you know that both of these antibodies can actually fix the complements and also take part in the opsonization. So in this type of hypersensitivity reaction, what you will get are the complement involvement also. Okay, this kind of reaction is mediated by the autoantibodies and as well as the complements. Okay. So what happens is when your every autoimmune reaction that is an example of type 2 hypersensitivity reaction. When the antibodies are formed against the body own cells, against the body own tissues, so they start damaging the tissues, and this is a type 2 hypersensitivity reaction. The damage can be caused by the cellular destruction after the opsonizations. What they will take the cell to the macrophages, and macrophages will destroy the cells. Okay. And for example, the autoimmune hemolytic anemia that the antibodies are formed against the these ABO group. So what's going to happen? The IgM or the IgG antibodies, mainly the IgG antibodies will take the RBCs to the macrophages into the spleen, and the spleen will destroy these RBCs, causing the autoimmune hemolytic anemia, right? The immune thrombocytopenia that you will study later is an example of this type 2 hypersensitivity reaction. and it is occurred due to the damage of your thrombocytes by the antibodies. Then the transfusion reactions that you know are also the example of this cellular destruction in the type 2 hypersensitivity reaction. The aplastic crisis that occurs due to the thymoma, remember? The aplastic crisis in the thymoma is also an example of type 2 hypersensitivity reactions, because the autoantibodies are formed against the erythroblast cells, which forms our RBCs. The hemolytic disease of newborn, which is erythroblastosis fetalis, is an example of type 2 hypersensitivity reaction in which the cell damage occurs. Then comes the inflammation part. As I told you, all of these antibodies fixes the complements, and when the complement fixation happened, that leads to the inflammation. For example, the Good-Pasha syndrome, which you will study in the renal section, is an example of type 2 hypersensitivity reaction that is due to the inflammation. The rheumatic fever that you will study in the cardiology section and also in the microbiology section in some parts is occurs due to type 2 hypersensitivity reaction when the when the antibodies cross react with this rheumatic factor in your heart. Okay, and this is the M protein in your staphylococcus, the streptococcus pyogenes. They have this M protein which cross react with the some proteins in your cardiac muscles that causes the rheumatic fever. So the auto antibodies form against the cardiac cells. And then the hyperacute transplant rejection, when happens, it is happened due to the preformed antibodies in your body. Okay, so hyperacute transplant rejection is an example of type 2 hypersensitivity reaction. Okay, then comes the cellular destruction. Again, when the antibodies bind to the cell surface and it causes the cellular dysfunction. When the antibodies bind to certain receptors and it will block the neurotransmitters or other hormones from accessing the receptor, and this is done in the myasthenia gravis when the autoantibodies form against the the receptors on your skeletal muscle cells. Okay, and then the Graves' disease is an example of this type of hypersensitivity, and then the pemphigus vulgaris also, in which the antibodies are formed against our skin. You will have this blistering of the skins, pemphigus vulgaris. And also the bullous pemphigoid is an example of this type 2 hypersensitivity reaction. Okay, so myasthenia gravis, Graves' disease, and the pemphigus vulgaris, and also the bullous pemphigoid. So what are the symptoms going to happen in this type 2 hypersensitivity reaction? So mostly the cells that are involved in the type 2 hypersensitivity reaction, because of these cells, they fixes the they take part in the ADCC also, the opsonization. So that the receptors are found in the NK cells, the macrophages, the neutrophils, the eosinophils. So all of these cells are involved in the type 2 hypersensitivity reaction. And as soon as remember, as soon as you do a blood transfusion and it is a non-match type, what you're gonna feel is the fever, chills, the chest pain, the back pain, okay, and the hemoglobinuria because of this autoimmune hemolysis. What you will see is the hemoglobinuria, the red urine. So it could be a classical case of a patient who comes to emergency department following the loss of blood, and you started the infusions of some non-matched blood. So after some minutes or some hours later, what these patient will see: the fever, the chills, the chest pain, and the back pain, and the red or the dark urine. Their urine color will change into red or dark, and that's how this must be a case of your type 2 hypersensitivity reaction, because whenever you have an inflammation, you have this fever. Okay, you have this chills because of the lysis of the RBCs. You have this chest pain, back pain, and hemoglobinuria. Versus in the type 1 hypersensitivity reaction, what you will get is the rash, the itching, the hypotension, and no hemoglobinuria is seen in the type 1 hypersensitivity reaction. This is the way that you can find a difference between the type 1 and the type 2 hypersensitivity reaction in terms of symptoms. If they give you a case of hypotension, bronchospasms, respiratory distress, itching, rash, then they're most probably giving you a case of type 1 hypersensitivity reaction. If they give you fever, chills, chest pain, back pain, reddish or a darker urine, they're giving you a case of type 2 hypersensitivity reaction. And please note down the examples, they are very important. What they will tell you, that they will give you a scenario of, let's suppose, the myasthenia gravis, and then they will ask you what other reactions or what other diseases have the same pathology. So you should know the example. They will give you some options, and one of the options have one of these examples. You will choose the option with these examples. So all of these diseases have the same pathology. They can ask you this. Then comes the type 3 hypersensitivity reaction, which happens when you fail to clear the immune complexes. What are the immune complexes? It is an antigen that is bounded to your antibody or the complement with an antigen. Okay, these are the immune complexes. And what happens after these immune complexes form? They settle on the tissues. And these immune complexes must be removed from your body. But in case if you fail to remove the immune responses, these immune complexes, what's going to happen? These immune complexes will attract the neutrophils mostly. And once the neutrophils reach to the site where the complements or where these immune complexes are deposits, they will cause the inflammation there. Okay. And this is the cause of your type 3 hypersensitivity reaction. It takes generally 1 to 2 weeks to develop. Okay. Well, once you get any disease, for example, remember this post streptococcal glomerulonephritis (PSGN). Once you get the infection from the streptococci, after 1 to 2 weeks, you will see the renal damage, and because of this deposition of the complexes in the tissues. So it will always take 1 to 2 weeks to develop after the first encounter with this antigen or the pathogen occurs. Okay. And yeah, wherever they settle, they will lead to the inflammation. If they settle in the blood vessels, you will see the vasculitis. If they settle in the renal, you will get the kidney failure. Okay. So polyarteritis nodosa, which is a type of vasculitis, is an example of this disease. SLE, in which you fail to clear the immune complexes because of the deficiency of early complements, you will see the SLE. It's a type 3 hypersensitivity reaction. The post-streptococcal glomerulonephritis, which you will study in the renal section, is an example of type 3 hypersensitivity reaction. And the two reference kind of reactions that you will see in is the serum sickness and the Arthur's reaction. So it is a prototype immune complex disease. What happens when the autoantibodies to the foreign proteins are formed? 1 to 2 weeks later, these antibodies will form the immune complexes. Using that that antigen, they form the immune complexes. Finally, that immune complexes will activate the complements, will attract the neutrophils and causes the tissue damage. Okay. Similarly, the Arthur's reaction that happens after a vaccine booster. So one time when you give a patient vaccine, you're giving them the antigen. So first time when you give them the antigen, what happens? You're forming the antibodies against that antigen, right? And next time when you give them the patient the vaccine booster, now these antibodies will form the immune complexes with those antigens, and they will settle in your skin. Okay, and they're gonna cause the Arthur's reaction. Okay, which is basically ulceration or the necrosis of your skin, the edema, the ulcers, and the blistering formations, and even the necrosis of your skin will happen after giving the vaccine booster. And this is due to this Arthur's reaction, because in first time when you give the antigen, you're forming the antibodies, and then next time when you give the antigen, you're forming the immune complexes. Okay, so what symptoms? And not just these 3 diseases, but also the hepatitis B. Sometimes you will see a type 3 hypersensitivity reaction in the hepatitis B because of this formation of the immune complexes. In the penicillin, you can get the type 3 hypersensitivity reaction. Please remember these 2 things. The penicillin and hepatitis B are also the example of type 3 hypersensitivity reaction. So what are the symptoms that you will see? You will see the fever, the joint pain, the proteinuria, which is a protein in your urine, multiple lymphadenopathies in your body, urticarial type rash. Okay, so whenever you got a patient having a fever, joint pain, flank pain, proteinuria, is some kind of a rash, and lymphadenopathy, you will always think about the type 3 hypersensitivity reaction. And most of the time when a patient get a hepatitis B infection, they will present you with these symptoms only. Okay, so whenever you encounter a patient with these symptoms and one of the options mentions hepatitis B, you will choose the hepatitis B as the answer. Okay, fever, rash, arthritis, lymphadenopathy, and this proteinuria. Okay, and in penicillin drug, if you give the patient penicillin and 1 to 3 weeks later he's presenting you with these symptoms, so this must be a case of type 3 hypersensitivity. Okay. So any doubt in the type 3 hypersensitivity reaction?
Doctor, can you please scroll your paper? I want to just see what you add the point regarding complement consumptions down.
Where?
You can just scroll the
Yeah.
paper up. I need to see the down. Yeah, this point. The complement activation, and that may lead to the consumption of complements in the type 3 hypersensitivity. I just want to see your addition points as well. Yeah, this one. Complement consumption occurs 7 to 14 days after trigger.
Okay. Yeah. Okay.
Once the
So once
complement
the immune
activation
complex,
has happened.
once you
Yeah,
get the
please.
antibody antigen complex, they will settle on the tissues, right? And they will attract the neutrophils. They will fix the complements, right? And after 7 to 14 days, because you keep on fixing your complements, what you will get is the ultimate deficiency of the complements, right? So you can expect a complement deficiency in the type 3 hypersensitivity reaction because of that. Okay.
Okay. All right.
Then comes the type 4 hypersensitivity reaction, which is a cell-mediated hypersensitivity reaction. It do not involve any kind of antibody. It do not involve any kind of complement, just the cells. And what cells are involved in the type 4 hypersensitivity reaction are your CD4 cells, CD8 cells, and the macrophages. Okay. CD4, CD8, and the macrophages. Only these cells are involved in the type 4 hypersensitivity reactions. And yeah, it could be a direct cell cytotoxicity, which is done by the CD8 cell whenever these cells become activated against the body own cells, or might be the antigen that is having a MHC1. They will directly kill the cells which are displaying the MHC1, right? And second is the inflammatory reactions. Okay, once once your body encounter any antigen by the macrophages, they will show that antigen to the CD4 cells. They will recognize the antigen and mount an inflammatory response against that antigen, like the process I told you earlier. Okay, so two type of damages, either the direct cell toxicity or the inflammatory reactions. And you must know the examples of these type 4 hypersensitivity reaction, very important. The first one is the contact dermatitis that you will study in the dermatology section, is an example of type 4 hypersensitivity reactions. Okay. Second is the graft versus host disease, which involve only the CD4 cells and the CD8 cells. When the graft CD4 or CD8 cells become active against the host antigens, so they will start killing the host antigens, and this is an example of type 4 hypersensitivity reactions. The PPD skin test that you will do for the TB infections, what you will do in that case, you will you will inject an antigen of the TB in your skin, and the macrophages and the CD4 cells in your skin will become activate against that antigen, forming an inflammatory response. And after 24 to 48 hours later, you will see a bump on your skin. Okay, and this is a positive TB test, the PPD skin test, and it is an example of type 4 hypersensitivity reaction. Similar to that PPD skin test, the Candida skin test is also an example of type 4 hypersensitivity reaction. Okay, the patch test for the contact dermatitis, because contact dermatitis itself a type 4 hypersensitivity reaction. A test you do for the contact dermatitis in which you inject some kind of antigens over your skin, and you will check what antigens are causing the skin reactions. So this is a contact dermatitis, and it is a type 4 hypersensitivity reaction. Okay. And of course, very important thing, the primary biliary cholangitis is also an example of type 4 hypersensitivity reaction. Okay, and all of these examples you are seeing here, in all of these examples, you will see the granuloma formations. Okay, so granuloma formation itself a type 4 hypersensitivity reaction. Okay. So how can you gonna recognize what type of hypersensitivity they're talking about? Whenever they give you some kind of an exposure, and just soon after giving the exposure, the patient started developing the symptoms like fever, rash, and hypotension, this must be a case of your type 1 hypersensitivity reaction. Okay. If you're talking about any kind of autoimmune disorder, they're most probably talking about the type 2 hypersensitivity reaction. if they give you a scenario where the exposure is happened and after 1 to 2 weeks later you are developing the symptoms, might be the skin symptoms or the joint symptom or the lymphadenopathies or the fever or anything, 1 to 2 weeks later, they're talking about the type 3 hypersensitivity reactions. And if they give you exposure of some kind and shortly, within the 72 hours after the exposure, the patient is having the symptoms, they're talking about the type 4 hypersensitivity reaction. So please look upon for the time gap, between the exposure and the symptoms. It will tell you what kind of hypersensitivity they are talking about. Okay.
Yes, sir.
Very important. And this is the easy way to encounter the questions, to solve the questions on these hypersensitivity reactions. So once you recognize what type of hypersensitivity it is, you can further, address the question on what they are asking about that hypersensitivity reaction. Okay. Any doubt?
No.
Okay, then we're going to move forward and talk about different type of blood transfusion reactions. Like in the order of hypersensitivity, we're going to talk about the blood transfusion reactions. So first, the type 1 hypersensitivity, which is the anaphylactic or the allergic response. So what happens in some kind of a patient, they have this deficiency of IgA antibodies. In some patients, they are the deficiency of IgA antibodies. So for these patients, the IgA antibodies are actually a foreign product, right? So what happens if you transfuse a blood to the IgA the deficient individuals? What happens is they're going to have this hypersensitivity reaction type 1. Okay. And that reaction happens as soon as you transfuse the blood. What's going to happen? You will get the wheezing, you will get the hypotension, you will get the respiratory arrest, you will get the shock, you will get the pleuritis. So if they mentioned as some kind of a scenario where the patient is receiving a blood transfusion, and as soon as they receive the blood transfusion, they develop this pleuritis, skin rash, hypotension, shock, and other things. So they will ask you what could be the thing here. So they will you will give them the answer that the patient who is receiving the blood must be the IgA deficient, because the IgA for these individuals would be a foreign product. Okay. So it is happened soon, 2 to 3 minutes or maybe the 2 to 3 hours later. And it is due to the release of the inflammatory mediators, the mast cell degranulations. Okay. Second type is a type 2 hypersensitivity reaction, which is a acute hemolytic transfusion reactions, and it is due to the ABO blood group incompatibility. What's going to happen? You're already having these preformed antibodies inside your bloodstream against the ABO blood group. So as soon as you transfuse the blood, a mismatched blood, what's going to happen? These antibodies start destroying these RBCs, by the opsonization, by the complement fixation, or by the direct damage also. So what you will get is a fever, hypotension, tachycardia, chest pain, back pain, flank pain, and most importantly, the hemoglobin urea, which is a change in the color of urine. They will tell you. As soon as you transfuse the blood, you will see a fever, chills, chest pain, back pain, and change in the change in the urine color. If you get these type of symptoms, they are going to referring you about this acute hemolytic transfusion reactions. Okay. And why this happened? Because of preformed antibodies against these ABO blood groups. And when you do a direct Coombs test, it would be positive. Okay. Then comes the febrile non-hemolytic transfusion reactions, which is occurs when you store a blood product. So what's going to happen is sometimes these cytokines were created by the donor WBCs in the accumulated blood products. So in the blood products that you are storing, they have this some kind of cytokines in them, which are formed by the WBCs of the donor. Okay, and as soon as you transfuse that blood in the host, so these cytokines gonna cause the reactions, and what you will get is the fever, headache, flushings, chills. But when you do a Coombs test, it would be negative. Okay, so a negative Coombs test, because there is no hemolysis is occurring, and all of these reactions are due to the cytokines which are preformed in the product blood. Okay, so how you can prevent these type of reactions? By the leukoreduction, you will reduce the WBCs and their cytokines from the blood products. You will give them the patient the packed cell bloods. Okay, packed cell RBCs. So that's how you can actually prevent such type of reactions. So if a question stem give you some kind of a reaction where a patient is having fever, chills, flushing, headaches, shortly after giving the blood, and they will give you a Coombs negative test, so they are most probably referring you to the febrile non-hemolytic transfusion reactions, and they will ask you what kind of what kind of process could prevent this type of reaction. So this is the leukoreduction. Okay, so please know how to differentiate between different type of reactions. Then comes the transfusion related acute lung injury. What happens sometimes is your neutrophils become activated against some kind of antigens, and your neutrophils go to the lungs and will settle there. Okay, so neutrophils is basically sequestered in the pulmonary vasculature, and they're primed against some kind of antigen, which are the anti-neutrophil antigens. Okay, so what happens when you transfuse the blood, and this transfused blood had these anti-neutrophil antibodies or anti-neutrophil antigens? What's going to happen? Your neutrophil will start acting against these antigens, and what you will see is the pneumonia. Okay, what you will see is the pneumonia-like symptoms. You will get a pulmonary edema. You will get a non-cardiogenic pulmonary edema, I must say, because no heart is involved in this case. You will get the respiratory distress. You will get a tachypnea. You will get the increased breathing. You will get the high CO2 levels in the blood. You will get this pulmonary edema. Okay, so whenever a blood transfusion reaction happens and it is solely focusing on the lungs only, no other symptom, just the lungs, what you will see is the transfusion related acute lung injury. And this is due to the donor anti-leukocytic antibodies, and the host cells are primed against these antibodies. So as soon as they meet up, the host neutrophil will start acting against them. They will destroy the antibodies. They will destroy the tissues in the lungs. What you will get is a pulmonary edema. Okay, you will get the orthopnea, dyspnea, high breathing rate, and there's crackles. They will tell you in the lungs. So just after the blood transfusion, if you're getting the lung symptoms, they're most probably the transfusion-related lung injuries. They will ask you why it is happening, because of this anti-leukocyte antibodies, and because of the neutrophils are in your lungs, settled in your lungs. Then comes the delayed hemolytic transfusion reactions, because they're not just the ABO blood group, but other minor antigens are also present in your blood, right? So what's gonna happen is sometimes the antibodies are also formed against these minor blood groups, and as a result, the destruction of the RBC is gonna happen, but it's not acute. It's gonna happen over the weeks. So once you transfuse the bloods, the reaction gonna happen up to the weeks. It is very slow because these antigens are very minor. So it is an amnestic response to a foreign antigen or on the donor RBCs, some RH antigen or other minor antigens. Okay, and this leads to the extravascular hemolysis because it is a opsonization process. The antibodies will take the RBCs to the liver or the spleen, where the macrophages opsonize it and destroy them. So it usually occur within 1 to 2 weeks. Okay, you will get a positive Coombs test. Okay, and it is always a self-limiting. You will get mild fever or mild jaundice, mild hyperbilirubinemia, but not very much severe like the ABO transfusion mismatching. Okay, like this one. So any doubt? And yeah, one more thing, how you want to differentiate between the febrile non-hemolytic transfusion reactions and the acute hemolytic or the delayed hemolytic transfusion reactions. So they will have to mention you that the blood product they have been transfused, it was a packed RBCs. And what does that mean by the packed RBCs? Is the leukoreduction. You have just the RBCs in the blood, not the plasma, just the RBCs. So if they mentioned the packed RBCs, they are most probably referring to the delayed hemolytic reactions or the acute hemolytic reactions, not the febrile hemolytic reaction. If they fail to mention about these packed RBCs, then they're most probably referring to the febrile non-hemolytic transfusion reactions, and they will tell you that it is an Coombs negative test, which means there is no hemolysis occurring. Okay, any doubt?
No,
Any
sir.
doubt? No?
No, sir. we
No.
can have it.
Okay, then you should need to know about what different disorders have what autoantibodies. This is a complete table. Every disorder you're going to encounter later in the chapters. Some of the disorders you have already encountered, like for myasthenia gravis, you have this ACS receptors, you already know. For the Lambert-Eater syndrome, you have this voltage-gated voltage-gated calcium channel antibodies. For the antiphospholipid antibody syndrome, you have this anti-beta-2 glycoprotein antibody. You will study them later, every disorder. But for the, for a short time, you can review it. So please learn this table. It is very important. Okay. We're not going to discuss it. It is all dependent upon the learning. Okay. No need to understand, just the learning facts. Then we will take a short break of 5 minutes. We will meet again at 9:20 and then we will discuss these immunodeficiency CD19, CD20. If you get the CD19, CD20, CD21 negative in your blood, that means all of the B cells are absent. And because there are no B cells are present in your blood, that means no antibodies. So what you will see is the decreased antibodies of all classes, loss of B cells. I remember I told you where the B cells are stored in the lymph nodes. These are the cortex, right? And because you do not have the B cells now, you will lost your the cortex part, and you will get what? The atrophy of the lymph nodes. Absent or the scanty lymph nodes are seen in these patients, in the tonsils also. You won't have the primary follicles, you won't have the germinal centers, and you should know that the live vaccines are contraindicated in these scenarios. Okay. And yeah. And what are the bacterias? Sorry, you will get the recurrent bacterial infections, because I told you that your antibodies are very much necessary to fight the bacterial infections. Remember, whenever you get the bacterial infection, you will get the hypertrophy of the cortical regions of the lymph nodes to cause the lymphadenopathy. So if you lose the B cells, you will get the recurrent bacterial infections, and especially the enteroviral infection, and that is the cause of death in these patients. Because of the enterovirus, you can get the meningitis. The baby can get the meningitis, and once he get the recurrent meningitis, it can lead to the death of the baby. Okay, and all of the infections will be start after the 6 months, because up to the 6 months, as you know, the placenta transfers the maternal antibodies to the fetus. So up to the 6 months, everything will be normal, and after 6 months, they will give you a history of a patient, who has a recurrent history of pneumonia, recurrent history of otitis media, recurrent history of meningitis, all of them after the 6 months, and they will tell you that the CD19, 20, 21 was absent from the patient's blood. So you instantly know that this must be a case of X-linked gamma globulinemia. Okay. Please remember the fact about it. Only the B cells would be absent, and they will ask you, what part of the lymph node would be absent in these patients. You will answer the follicles or the cortex. Okay. Because there is IgG antibodies and IgA antibodies. Especially the IgG antibodies are very much required to fight the infections from your blood, to opsonize the capsulated organisms, right? So if you have loss of the B cells, you will get the recurrent infections from the capsulated organisms like Streptococcus pneumoniae, the meningitis, the Haemophilus influenza. And many times whenever you encounter the patient, you will see the bacteremia in these patients. So whenever you get the bacteremia in the patient, you instantly know that there must be a deficiency of IgG antibodies. And out of these disorder, only this X-linked A gamma globulinemia has this deficiency of IgG in the blood. Okay. So the only way by which the organisms can invade your bloodstream is by the deficiency of IgG. So that's why you require the IgG. Then comes the selective IgA deficiencies, in which you get this hypersensitive reaction that we talked about earlier in the blood transfusion reactions. It is a most common immunodeficiencies, and its cause is, of course, unknown. What you will get, because you do not have the IgA antibodies, you cannot protect your mucosal tracts. You cannot protect your respiratory tract, you cannot protect your GI tract. So what you will get are the recurrent pneumonia, first thing. Second thing, you will get the recurrent episodes of diarrhea, and especially you will get the giardiasis. Okay. Please remember the similar symptoms you will get in the X-linked acamoglobulinemia, the similar symptoms you will get in the selective IgA deficiencies. But one thing that you could be able to differentiate between the two is that the fact that in X-linked acamoglobulinemia, you will get the bloodstream infections. But because IgA is not involved in the bloodstream, you won't get the bloodstream infections in the selective IgA deficiency. So whenever a question stem mentions bacteremia thing or the sepsis, you will instantly think about this disorder, not the IgA deficiency. Okay. So what are symptoms? You will get the pneumonia, you will get the giardiasis infection mainly. Okay, you will get the autoimmune disease, and this autoimmune disease could be a celiac spur, could be a tropical spur. Okay, it could be an inflammatory bowel disease or any kind of autoimmune disease like rheumatoid arthritis. So whenever you get a patient having the pneumonia, having the diarrhea, having the rheumatoid arthritis, or might be a celiac spur, you know that this must be a case of your selective IgA deficiency. And plus, you will get the anaphylaxis after giving them the blood products, like we talked about already. Okay. And yeah, you will have the low level of IgA in the body, but normal level of IgG and IgM. You will have the increased susceptibility to the giardiasis because you need the IgA to protect against the parasites, against the mucosal parasites. And an important thing that you should mention, you should write in your notepad or in the word file that I asked you to create, and is that in the selective IgA deficiency, you will get a false positive beta HCG test. Very important. You will get a false positive beta HCG pregnancy test. Okay. And SLE and rheumatoid arthritis are very common in these patients. Then comes the common variable immunodeficiency, and a case of this type of disease would be a patient who is like 20 to 45-year-olds. Okay, most important, because this disease always present in the after the puberty. So before the puberty, X-linked acamoglobulinemia, and after the puberty it is CVID. And you should know that differentiation of the B cells actually does not taking place. Formation of the B cells is happening, but you should know that in order to secrete the antibodies, you need to convert the B cell into the plasma cells, right? And so that the plasma cells can secrete the antibodies. But in this case, the B cells cannot be converted into the plasma cells. So you have a normal B cell count, but you have a low antibodies of all classes. Okay, very much important. Normal B cell count, normal markers, CD20 is normal, 19, 21 is normal. But what you will get is a low antibodies of all classes. And that's in the CVID. It will always present after the puberty. So it would be a patient who after reaching the age of 18 or 20 start having this, pneumonia or this bloodstream infections or this diarrhea, giardiasis, and multiple other type of infections. That's how you know there is a CVID, not a X-linked acamoglobulinemia. Please remember this fact. The markers are very important. Okay. And the bloodstream infections are very important, which you won't see in the selective IgA deficiency. Any doubt? Any doubt, guys?
It's okay.
Okay, someone is saying that FA 2021 has mentioned that it is a false, what does it say? That it is a false celiac disease test instead of beta HCG. Okay.
Saying can cause false negative celiac disease.
Well, during my preparation, from the BNB, from the MBOS, and in the FA also, I've heard about this false negative beta HCG test. So I really no idea. But you do encounter the celiac spur in these patients. Whenever they want to give you a case of selective IgA deficiencies, even in the U and in the MBOS, they have mentioned the patient has this celiac spur, and that's why he got the diarrhea. Okay, so I really don't know about why the FA has changed it. But yeah, if FA 2021 has mentioned about the celiac spur test, so you guys can remember about the celiac spur test. But that's what I studied during my preparation. So yeah, that's it.
A quick question on
Yeah.
X-linked Bruton. Do they get like Giardia also?
Yeah, of course, because you are losing IgA. Whenever you lose the IgA, you will get the respiratory and the mucosal tract infections, your GI infection, the respiratory infections. Okay. And whenever you lose your IgG, you will get the bloodstream infections. Very important concept you should remember. Loss of IgA leads to the mucosal tract infections, and loss of IgG leads to the bloodstream infections.
Okay, so the
Okay. Yeah.
okay, that's fine. Thank you.
Now then the T cell disorders, the disorder in which you get the selective T lymphocyte deficiencies, and first is the thymic aplasia, which is due to the 21q11 microdeletion. How you will detect the microdeletion in this case? The test. Remember guys, the test for the microdeletion.
Immunofluorescence, fish.
Fish.
Fish test.
Yeah.
Fish test.
Fish test. Yes. So in this scenario, you will have this microdeletion of 22q11, and as a result, you will fail to develop the third and the fourth pharyngeal pouch. You should know that the the third pharyngeal pouch is involved in the formation of your thymus, and fourth pharyngeal pouch is and third and fourth are involved in the formation of your parathyroid gland. So what you will see is a deficiency of your thymus and as well as the deficiency of your parathyroid hormone. Okay, so two type of disorders are there. First is the DiGeorge syndrome, and second is the velocardiofacial syndrome. In the DiGeorge syndrome, what you will get are the cardiac defects, the thymic defect, and the parathyroid defects. Okay, so what you will get in the cardiac defects is a tetralogy of fallout. You will study that later in the cardiology section about this tetralogy of fallout and the truncus arteriosus. So whenever you got a patient who is having some kind of a murmur, okay, who is having recurrent viral infections, who is having hypocalcemia, and due to the hypocalcemia he is having these spasms, the kidney, you will always think about the DiGeorge syndrome. Okay, and they will mention you that the thymic shadow was absent in the X-ray, and yeah, he has this hypocalcemia. You should remember the symptoms of the hypocalcemia, which is kidney spasms, recurrent contractions. Okay, and because remember I told you that T cells are mainly involved in the immunity against the viruses. So what you will get is the recurrent viral and the fungal infections, not the bacterial infections. Bacterial infections you will get only in the B cell disorder, not the T cell disorders. Okay. So what you will get are fungal infections, the viral infections, abnormal faces like cleft lip and palate defects could be there. Hypotelorism could be there, which is when you're either the hyper or the hypotelorism could be there when your eyebrows came too much closer, or goes too much apart from each other. Okay, and yeah, that's about the thymic aplasia. Please remember the thymic shadow would be absent, T cell would be absent, and the hypocalcemia, hypoparathyroidism you will see the murmur in the heart, you will see the cleft lip palate, hypotelorism or the hypertelorism. Okay, and you will get the viral and the fungal infections, not the bacterial infections. Very important. Okay, remember the microdeletion, remember the pouch defect, not the cleft, not the arch, but the pouch defect. Okay, remember the organs that will be removed, thymus and the parathyroids. Okay, any doubt? And if they ask you what a part of the lymph nodes would be absent, so this would be your paracortex. Okay, and from the spleen, what part would be absent? This would be the para-aortic lymphatic lymph sheets, right? PALS would be underdeveloped in these patients. Okay, know the locations. Then comes the interleukin 12 receptor deficiency. Like I told you that macrophages releases the interleukin 12, and that leads to the activation of Th1 cells. Remember, if you get the deficiency of interleukin 12, what you will see is the decreased Th1 response, and as a result, you won't get to see the granuloma formation. So what you will get is the disseminated mycobacterial and the fungal infections, because you required the granuloma for the mycobacteria and all and as well as the systemic fungi. Remember. Systemic fungi require the granuloma formation, so you will get a systemic, disseminated mycobacterial and the fungal infections. And the infections could also be there after the BCG vaccine, because BCG vaccine is a live attenuated vaccine. So you can also get the reactivation of the viruses and the fungus in the vaccines. And yeah, you will see the low interferon gamma count, because if you're not activating your Th1 cells, so interferon gamma is released from the Th1 cells, right? So if you're not activating the Th1, you won't get the interferon gamma, and you will get the mycobacterial diseases. Okay. Then comes the autoimmune dominant hyper IgE syndrome, also known as a Job syndrome. In this scenario, what happens is you have this JAK-STAT pathway, which is responsible for the response to the interleukins. Whenever interleukin comes, it always activates a JAK-STAT pathway. And in this scenario, what's going to happen? You are having the mutation in the JAK-STAT pathway, so that the Th117 cells, which activates the neutrophils, this response is not going to happen. So what you will get is loss of neutrophils, and you know that neutrophils are, responsible, of course, for fighting the infections. Yes, so you will get the recurrent infections. You will have this low interleukin 17 count. Okay, you will have something known as the cold or the non-inflamed abscess, because abscess are generally formed from the neutrophils. When they destroy the pathogen, they will get the necrosis. This liquefied necrosis is actually your abscess, right? And generally when you when you feel the abscess, it would be warm always because of the inflammation. But in this scenario, because your neutrophils are not there, because your neutrophils are kind of not working, so you will get the cold abscess, and mostly from the Staphylococcus aureus. Okay, you will get the recurrent Staphylococcus aureus infections, and you will get the cold abscess. You will get the baby teeth, which are easily removed. So you'll get the teeth abnormalities. You will get the coarse faces, which are the abnormal faces. You will get the dermatologic problems because of increased IgE. You will get hypersensitivity reactions. You will get the eczema. You will get the pruritus, skin itchy rash. You will get the 2 rows of the teeth because of the baby teeth. You will get the fractures from the minor trauma. So please remember the fractures, the rash, the pruritus, the cold abscess is very important. They will almost every time mention you this cold abscess thing. Okay, and you will get the high eosinophil counts and the high IgE counts in it. Okay, very important thing. Then comes the chronic mucocutaneous candidiasis. Remember the IR mutation, which gives you the chart, the chronic mucocutaneous candidiasis, the autoimmune diseases, the hypothyroidism, the Addison's disease, and finally the recurrent candidiasis. So the IR mutation leads to this scenario. I've discussed this already. You will get the recurrent candida infection. You will get the hypoparathyroidism. You will get the adrenal crisis that can even lead to the death by the hypotension shock thing. Okay, you will get the candida skin infections like intertrigo. You will get the oral thrush, recurrent oral thrushes. Okay. So this is a chronic mucocutaneous candidiasis due to the IR mutation, which is responsible for the positive selections. Then comes the immunodeficiency combined B and the T cells. Okay, both B and T cells are decreased or become deficient in these cases. First is the severe combined immunodeficiency syndrome, SIDS. We know one cause of it, that is the ADA deficiencies, and I've told you why the ADA deficiency lead to the SCID, because your adenosine is very toxic to the lymphocytes. Okay. Second thing is a interleukin-2R receptor deficiency. You know that interleukin-2 is very much important because it leads to the replication of these B cells, T cells, macrophages, right? But if you lose the receptors for the interleukin-2, you never get to multiply your lymphocytes, and what you will get is a deficiency of the lymphocytes. And you should know that interleukin-2 receptor deficiency is the most common type of deficiencies, and it is always this X-linked, very much important. It is almost every time found in the boys only, the males only. Take a second type is the adenosine deaminase deficiency, which is autosomal recessive. And third is the RAG gene mutation. RAG gene is involved in the VDJ recombination, and as you guys know, for the formation of receptors of the T cells and the B cells, what you require is the VDJ chain recombination, right? So if you get a mutation in the reg gene, you won't get to form your receptors of the B cell and T cell, and as a result, your cells will fail to develop. So you will get the SCID. So what you will see, because of the deficiency of B cells, you will get the recurrent bacterial infections. The enteroviruses infections. Rotavirus, enteroviruses, bacteria. You will get the pneumonia. You will get the otitis media. You will get the meningitis recurrent. You will get the bacteremias. You will get the viral infections because of loss of T cells. You will get the recurrent fungal infections, especially the thrush, oral thrush. Of the candida, you will get it. Okay, recurrent protozoal infections you will get, and all of these symptoms will start presenting within the 6 months of the age. Okay, and the test you can do is basically your T cell receptor excision circles test will be decreased because receptors, like I told you, reg mutation lead to the VDJ recombination failure, right? So you won't have the receptors for the T cells. Okay, then you will get the absence thymic shadow, which could also be seen in the DiGeorge syndrome. So please do not confuse between the two. In the SCID, you will get both the bacterial as well as the viral infections, but in DiGeorge syndrome, you will only get the viral infections. Okay. On the biopsy, you will have this absent germinal centers. You will absent paracortical regions. You won't have the follicles in the spleen. You won't have the PALS in the spleen. Okay. On the flow cytometry, you will have loss of the CD20, 19, 21 markers, loss of CD4 markers, loss of CD8 markers. Okay. So this is about the SCID, the recurrent infections. Okay. Then comes the ataxia telangiectasia. Remember the fact that I told you about this ataxia telangiectasia in the biochemistry section? What kind of rejoining happen in this? The DNA repairing. Remember what kind of repair? Homologous or non-homologous? Tell me. Homologous or non-homologous?
I don't remember that.
Non-homologous rejoining. ATM gene is based. Yeah. ATM gene is actually responsible for the non-homologous rejoining of the DNAs. So if you become deficient of this gene, what's going to happen? You will have the DNA damage, and because these DNA segments which destroyed, the double strand breakage that happens in the DNA, most commonly it happens due to the radiation exposures. So what this patient have is extreme sensitivity to the radiations. Okay, because you do not have the DNA double stranded repair, remember? So we'll get an extreme sensitivity to the radiations. As the name suggests, you will have the ataxia, you will have the recurrent falls. Okay, you will have the telangiectasia, which are these blanching lesions. Whenever you press on this region, the region become very pale, and when you remove your finger, you will see the the blood coming, and this region again become the red, and this blanching type, the spider-like region. These are also known as spider angiomatas, the second name of this thing. Okay, so you will get the ataxia, you will get the telangiectasia, and you will get the recurrent infections. Okay, and you will specifically get this IgA deficiencies, IgG deficiency, and IgE deficiencies. You will get the high level of alpha-fetoprotein, which is very easy to remember by the name AA. In the ataxia telangiectasia, will have this high alpha-fetoprotein level. Okay, and you will have the cerebellar atrophy, and that's why you get this ataxia in this scenario. Okay, you will have the risk of lymphoma and the leukemia. Why? Because you are not repairing your DNA, so you have an increased risk of cancers, and of course the extreme sensitivity to the radiation. So whenever the question is describe your case of a patient having the blanching, some kind of a blanching lesions all over their skin, and frequent history of frequent falls, and frequent infections, and yeah, so they might be referring you to the ataxia telangiectasia. They can ask you about this gene, they can ask you about the DNA repair thing, they can ask you about the level of antibodies, they can ask you about this alpha fetoprotein thing, and they can ask you about the risk of these cancers. Okay, then comes the hyper IgM or the Job syndrome. Remember the one thing I told you about the CD40 ligand and CD40 receptor interaction, that they determine what kind of antibody class switching going to happen. So now in this syndrome, what's going to happen is you will have this defective CD40 ligand on the On which cells? On the B cell or on the macrophages? Sorry, on the B cell or on the T cells? Which cell had the CD40 ligands?
T cells.
T cells.
Exactly, T cells. Okay, and the receptors are present on the antigen presenting cell, which could be the macrophages or could be the P lymphocytes. So it is a defect in the TH cells. The CD40 ligand is become defective, and as a result, there won't be any interaction between the CD40 and the CD40 ligand, and as a result, there won't be any class switching happen. So all you get is the IgM antibodies, no IgG, no IgE, no IgA, just the IgM antibodies. Okay, and because now you should know that the two ways by which your B cells can be activated. One is the direct way and one is the indirect way. In the direct way, whenever your B cell encounters a capsulated bacteria, a lipid antigen, they become directly activated and release the IgM antibodies. Okay, and whenever they encounter a protein antigen, they will display it to the CD4 cells, and then the CD4 cells will determine what kind of antibodies they're going to secrete. So in case of indirect activation, what you will see is a widespread antibody release, a specific type of antibody release. But in case of direct activation, which is by the lipid antigen like the capsulated bacteria, what you will see is just the IgM. Okay, this is one fact that you should remember. Okay, so in the hyper IgM as a name, yeah.
Can you repeat that?
Okay, let me check again the activation of T cells. Wait, I think FA has mentioned and I forgot to tell you about it. Yeah, I forgot to tell you about this part. The antigen type and memories. You should know that two type of antigen processing can be happen. One is a thymus dependent and one is a thymus independent. In thymus dependent part, what can happen whenever your B cell or macrophages encounter a protein antigen, they will display it to the CD4 cells, which is a thymic cells, right? And then the CD4 cell will determine what kind of antibody class switching B cells gonna do, right? And as a result, you will get a very heightened or a very great immunity type. Okay. Second thing is a thymus independent. Whenever antigen lacking a peptide component, which is a lipid antigen or a capsule from the bacteria, what's going to happen? They will directly stimulate the B cells. They will directly activate the B cell. And in response to that, the B cell will release just the IgM antibodies, not the IgA, not the IgE, not the IgG, but just the IgM antibodies. And this is a thymic independent antigen processing. Okay. And you should know the example of certain vaccines, which is a PPSV23 vaccine against the Streptococcus pneumoniae. It has just a polysaccharide antigen, which is a lipid antigen. So it will only stimulate the IgM antibodies. And wahi, you have this PCV13 vaccine, okay, against the Streptococcus pneumoniae. It has 13 strains of the Streptococcus pneumoniae, and it is a conjugate vaccine. And now this time, this polysaccharide antigen is conjugated with a protein antigen. And this protein antigen came from the diphtheria toxin like proteins. Okay, and now what you will get, because there is a protein present, you will get a thymus dependent response, remember. So PCV13 vaccine is thymus independent, thymus dependent because it is a conjugate vaccine, and PPSV23 is a polysaccharide vaccine. Okay, remember these two type of processings. Okay, got it now?
Yes, sir.
I forgot to mention earlier. Sorry about that. Okay, now, so because there is no interaction between the CD40 and the CD40 ligand is happening, what you will see is a direct thymic independent activation of the B cell. And as a result, what you will see just the IgM, not the IgA, not the IgG, not the IgE. Okay, so what you will see are the serious opportunistic infections, and you already know oral thrush, the Cryptococcus sporidium pneumonia, right? The Pneumocystis cerevisiae infection, the Candida, the CMV. Okay, so whenever you encounter a case of a patient having this opportunistic infections and a high level of IgM, they will ask you what kind of defect is there. It would be a defect in the TH cell, the CD40 ligands. Then comes the Wiskott-Aldrich syndrome, which is, the name suggests, WAS gene, Wiskott-Aldrich syndrome gene. Okay, it become defective, and as a result, your actin. Remember the actin where we studied it? Anyone?
Industrial
Actin?
muscular dystrophy.
Where?
Microfilaments.
Yeah, exactly. Microfilaments. It is required for the cytoskeleton of your cells. And because WAS gene is lost, you will have this defective actin cytoskeleton. As a result, you cannot have this antigen presentations, because I told you that these cytoskeletons are like a rail track. You require them for the antigen processing, for everything, for moving inside your body. So as a result, in this VAS gene mutation, and it specifically happens in the platelets as well as the leukocytes. Okay, so ultimately your actin cytoskeleton is lost and you will have a defective antigen presentation, and it is an X-linked disorder. You must remember that it is an X-linked disorder. So because it affects your platelets and your leukocytes, what you will get is a thrombocytopenia. You will get the eczema, which is a skin rash, pruritic skin rash. You will get the recurrent pyogenic infections which are directly, without toxins, the direct when bacteria invade your body. This is a pyogenic infections, and this is due to the B cell deficiency, of course, bacterial infections, right? And the fact that you should remember it is that you have a low level of IgG and IgM, but high level of IgA and IgE. Okay, and you have a very dysmorphic type of platelets, very smaller and fewer platelets. Very important. Thrombocytopenia, small platelets, recurrent infections, eczema, VAS gene, X-linked, and actin part. Please remember this. And of course, the fact about these antibodies: low level of IgG, IgM, high level of IgE and IgA. So how can a patient with VAS syndrome, this Viscott-Aldrich syndrome, will present you? They will present you with a history of recurrent infections, with a history of petechial rash, with a history of recurrent bleedings, with a with a history of a skin rash, with very pruritus all over the body. So whenever you encounter this kind of a patient, please take the option for Viscott-Aldrich syndrome. Bleeding, eczema, and petechial rash, and pruritus, recurrent infections. Then comes the neutrophil disorders or the phagocytic disorder. All of the disorder we have studied here, the B cell disorder, the T cell disorder, and the combined B and T cell disorder, they all are the acquired immunity disorder. Okay, because B and T cells are part of your acquired immune system. Okay, and now the disorders that we're going to study are the part of your innate immunity. So these are the innate immunity defect. So first is the leukocyte adhesion deficiency type 1. You need to know, and you will study that later in the patch section, about the process by which your neutrophil will reach to targetoid locations, the target locations. Okay, and let me show you the diagram. Just wait for a second.
Is it like diabetes and stuff?
It will be very easy to understand by that way, you know. Just wait for a second. Let me open the first page. Okay. Okay, so here as you can see, this is the process by which the neutrophils inside your blood reach to the targeted locations. Okay, so first when the neutrophils were moving inside the blood, they will meet with these E-selectin proteins. Very important, the E-selectin proteins that are found in your blood vessels. Okay, and this E-selectin will, just let me zoom. Okay, what just happened? Yeah. These E-selectin proteins will interact with this Lewis X. You will study that later in the patch section. And this is like a speed breaker to the neutrophils. After this, the rolling motion will occur of the neutrophils. This neutrophil will start rolling. And finally, the upgradation of the E-selectin happens and there forms a P-selectin. Okay. And this P-selectin, binds with the Lewis X. So very, very tight bonding would be there. And as a result, the neutrophil will stop there. And finally, there are some molecules, some kind of receptors in your blood vessels exist. And these are the ICAM molecules, which interact with this LFA1. Okay. And after this interaction, the PCAM molecule will appear on the neutrophils, and similar PCAM molecules are also present on your blood vessels. And after the interaction of this PCAM1 molecule, your neutrophils can easily cross the blood vessels and enter the tissue locations where they can cause the inflammation. So the first lectin is the E-selectin. Just after the inflammation, the interleukins will cause the expression of this E-selectin on the blood vessels. After the E-selectin, the rolling motion will occur. Similarly, the interleukins will cause the P-selectin expression. As soon as the cellulose X interact with the P-selectin, it stops there. The neutrophils are stopped now. And finally, the interaction between the ICAM and the LFA1 will occur. And this is a tight binding, very tight binding, okay? And after this, the PCAM1 will appear, and by the interaction of these two PCAM1, this leads to the diapedasis and the transcytosis of the neutrophils, okay? And now in this case, the leukocyte adhesion deficiencies, this LFA1 is gone. So as you can see, if the LFA1 is gone, your neutrophils will no longer be able to bind tightly with the blood vessels, right? With the walls of the blood vessels. And this is a deficiency going to happen. Now, if they cannot bind tightly with the blood vessels, they cannot cross the blood vessels and cannot enter the location of the inflammation. And as a result, you will get is the recurrent infections. Let me share that slide again. Yeah. Please remember the CD marker for the LFA antigen, and this is the CD18. Okay. It is very important for the migration and the chemotaxis of the neutrophils. And you should know that for the separation of the umbilicus of the for the separation of the umbilical cord, you actually require the neutrophils. Neutrophils will reach at the umbilical cord. They will cause the necrosis there, and after the necrosis, your umbilical cord will fall off within 30 days. If the umbilical cord are not falling even after 30 days, this means the patient might be having the leukocyte adhesion deficiency because the neutrophils cannot reach at the umbilicus region. Okay, so most probably when they will give you a patient of LAD deficiency, they will give you this thing. They will give you this hint that the umbilicus cord will was formed after 60 days or 70 days later. Okay, because like I told you earlier that this neutrophil is involved in the pus formation. Remember, in this cold pus time, the cold pus job syndrome, I told you that neutrophils are involved in the formation of this pus. So without neutrophils, there won't be any pus. Infection would be there, skin infection would be there, but there is no pus formation occurs. Okay, so you will get the recurrent skin infections. You will get the recurrent, skin infections mainly. Okay, and the mucosal bacterial infections you will get. You will get the recurrent pneumonia. You will get the recurrent diarrhea. You will get the recurrent infections, and they will tell you that there is no pus formation was there. Staphylococcus aureus was, extracted from the skin infection, but there was no pus. So that's how you know this must be the leukocyte adhesion deficiencies. And because the neutrophils cannot migrate from the blood vessels, now their number will keep on increasing in the blood. So one of the complication of this disorder is the increased neutrophil in the blood, neutrophilia you will see. Okay, and because inflammation is very much required for the wound healing, remember, you will also study that later in the patch section, in the wound healing part, that the inflammation is required for the wound healing. So because there is no inflammation, you won't get the wound healing. So you will get the delayed wound healing in the patient. You will get the neutrophilia. You will get the recurrent skin infections without any pus formations. You will get a delayed separation of the umbilical cord, and that is after 30 days. They can ask you about this neutrophilia thing in the blood. They can ask you about this LFA, and the CD18 marker is very important. And yeah, that's it. Then the Shediac-Higashi disease or the Shediac-Higashi syndrome. Like I told you about the microtubules, that anything that is moving inside your body, inside your cell, it requires the rail tract, the microtubules. Okay, so what happens when the neutrophils endocytose a bacteria or a pathogen? There needs to be the lysosome and phagosome fusion. Remember the phagosome lysosome fusion, so that the lysosomes can destroy the bacteria, right? But now what's going to happen, because there is no microtubule to direct the fusion of this phagosome and lysosome? So ultimately what's going to happen, there won't be any fusion there, right? And as a result, that bacteria can easily replicate or grow inside the phagosome. Okay. And like I told you, the neurotransmitters, in order to move from this cell body to the nerve ends, you need the microtubules. Remember the dynein and the kinesin. So because you lost the microtubules, you will lose the dynein and the kinesin, and what you will get is a progressive neurodegeneration. Okay, there will be a peripheral neuropathy because a loss of neurotransmitters. Okay, you will get the lymphohistiocytosis. Okay, you will get the albinism because the melanin synthesis that occur in the melanocyte, the melanin needs to be reached to the cell surface, skin surface, and that is done by the microtubules. If you do not have the microtubules, your melanin will stays in the melanocytes only, and what you will get is the albinism. And what are the symptoms of albinism? You will get the fair skin, you will get the blue eyes, okay, and the blonde hairs. You will get the recurrent pyogenic infections, which are caused due to the direct invasion of the skin by the Staphylococcus aureus, Streptococcus pneumoniae, or the pneumococci. And because, like I told you, there is no fusion of the lysosome phagosome occur, what you will get are the giant granules. Okay, like as you can see, because after the granules are formed, they need to be dispersed inside the cell, and in order to disperse, they require this microtubule formation, right? And because now there is no microtubule formation occurring, so what you will get are the clusters or the clumps of these granules of the neutrophils, and these granules will appear as these giant granules now. Okay, so you will see the giant granules in the neutrophils, and you will also get the pancytopenia, of course. Okay, then comes the chronic granulomatous disease. I already told you about this NADPH oxidase enzyme, that it leads to the formation of oxygen free radicals or the reactive oxygen species. Without this enzyme, you cannot get the respiratory burst. But you know that the waste product of the bacteria are H2O2. So this hydrogen peroxidase and this myeloperoxidase enzyme can still be functional. It uses the H2O2 to convert into the HOCl, but the bacteria which have this catalase enzyme, that means the catalase positive bacteria, they will destroy their H2O2, and as a result, in the chronic granulomatous disease, what we will get are the recurrent infections from the catalase positive organisms. And you should remember the name. These are the Staphylococcus aureus, the Pseudomonas, the Aspergillus, the Nocardia, the Serratia. Okay. And what test would you use to diagnose the chronic granulomatous disease? This is a dihydrorhodamine test. Okay, dihydrorhodamine test is very important. You won't get the green color. Generally, if you do this test, if your NADPH oxidase is normal, so you will get this green color fluorescence in the direct flow cytometry. Okay, but in case of this chronic granulomatous disease, what you will get is a negative dihydrorhodamine test. You will have this decreased green fluorescence. And second test is the nitroblue tetrazolium test. If you get a blue color, it is a good test, positive test. That means your cell is absolutely normal. If you do not get the blue color, that means your test is negative and you will get the chronic granulomatous disease. Please remember these two test name. Most of us just remember the nitroblue tetrazolium, fail to remember this name. And examiner going to trick you here. They will give you this name, the dihydrorhodamine test, but not the nitroblue tetrazolium test. And sometimes they will replace the name with the flow cytometry. Okay, So please remember about this trihydrotamine test. You will do the flow cytometry, you will get the green color. If you get the green color, the test is positive, everything is normal. But if you do not get the green color, your test is negative. That means you're having the CGD. And similarly, the natoblue tetrazolium test. Please remember the species name, all the catalyst positive organisms. Okay. Any doubt on this page?
No.
I think it's easy and you have to just remember the facts about them. Then come the infections in the immunodeficiency. Like I told you, if you get the B cell deficiencies, what you will get the infections from the bacterias. And if you especially get the IgG deficiencies, what you will get the sepsis. Okay, and most commonly done by the encapsulated bacterias. Because I told you that IgG is very important in order to counter the encapsulated bacteria to opsonize them. Right, and a very good mnemonic to remember them is some killers have pretty nice capsule. Okay, some as the Streptococcus pneumoniae, and this K is the Klebsiella. Okay, H is the Haemophilus influenza, P is the Pseudomonas, N is the Neisseria. Okay, and yeah, that's it. And if you get a complement deficiencies, later complement deficiencies, you will get a recurrent Neisseria infections. Okay, and yeah, if you get a B cells in encapsulated organisms, I think it is easy. You to just remember the names. Okay. The viruses infections are mainly due to the T cell deficiencies, and enterovirus because it infects your respiratory and your GI mucosa. IgA are very important in this case. Okay, and what you will get are the enteroviral infections. And like I told you, in case of glutathione tyrosine kinase X deficiency, which is X-linked agammaglobulinemia, what you will get is the recurrent enteroviral infections, and that could lead to even the death. Okay. If you get the T cell deficiency, you will get the Candida and the Cryptococcus infection. If you get the bacteria deficiency, if you get the B cell deficiency, you will lose the IgE antibodies, so you will get the giardiasis. Okay. So T cell deficiencies produces more fungal and the viral infections, and B cell deficiencies produces both the bacterial infections. Okay. This is a very easy thing to remember now. Okay, now we will study about these transplant rejections. We will end here after studying it. Okay. So first is the hyperacute transplant rejection, which occurs as soon as you connect the organ with the body, and this happens because of the preformed antibodies. Either against the ABO blood group or against the HLA. You need to know that HLA. You already know that HLA is very important in order to recognize the self and the foreign cells, right? So if you have a preformed antibodies against the HLA system or the preformed antibodies against the ABO blood groups, what's gonna happen if the mismatch occurs? This antibody will immediately start acting against your organ, and what you will get is a hyperacute, which occurs within some minutes. As soon as you connect the organ, you will have these reactions. What you will get is a thrombosis, very important thrombosis. Immediately the blood supply to that organ will be lost, and what you will get is a cyanosis of the organ. So whenever questions time mention about some kind of a cyanosis, bluish discoloration of the organ as soon as you connect it, you will get the hyperacute reaction. Okay. Ischemia and necrosis, again because of loss of blood supply, you will get the ischemia and the necrosis. You will get the fibrinoid necrosis also, and now you will get the gross mottling of the organ. You will get the cyanosis of the organ. So the graft must be removed as soon as possible. This is the hyperacute, and it is occurred due to the humoral response antibodies. And what kind of hypersensitivity reaction it is? It is a type 2 hypersensitivity reaction because of antibody involvement. Okay. Then comes the acute, and you should know that acute, the main type of immunity responsible for it is a cell-mediated immunity. Predominantly cell-mediated immunity is responsible for it. When you connect the organ with the body, what's going to happen? The antigens from that organ will be shown to the CD4 cells. CD4 cells will mount an immune response against it, and usually it is less than 6 months. So whenever a question is to mention a transplant case and the patient is presenting you within 6 months with the symptoms, this must be a case of your acute rejection. Like in days, it can present in weeks, it can present in months, but usually within hours to the months. Okay. If it is occurring as soon as you can, you just you attach your organ with the body. If you get the onset of the reaction, this must be the hyperacute. If it is occurring after days or after weeks or after months and within 6 months, this must be your acute rejection. Okay. And it occurred due to the mainly the cell mediated immune response. So what kind of cells are involved in it? The CD4 cells, the CD8 cells, and the macrophages, a type 4 hypersensitivity reaction. Okay. So what you will see is the vasculitis, the inflammation of your blood vessels would be seen in this scenario. Very important. Okay, you will see the lymphocytic infiltration within the organ. Okay, in the histology, you will see the lymphocytic infiltration within the organ. You will see the you will see the vasculitis, which is the inflammation of your blood vessels. Okay, and you should know that this kind of immunity could be suppressed by increasing the dose of your immunosuppressants. Okay, if you increase the dose of immunosuppressants, this type of immunity could be suppressed easily. And what the reactions, what symptoms the patient will get is a fever, non-specific symptoms like fever, chills, joint pains, and very fatigue. You will see, and if the patient present with these symptoms within 6 months, this must be a case of an acute rejection. Okay. And yeah, for the humoral response, because humoral response is kind of very minimal to it. What you will get is a C4D complement deposition. You will get the neutrophils. Okay, you will get the necrotizing vasculitis. Whenever there is a neutrophils, there is necrosis. Okay. So if they ask you about the histology, what you will see is the vasculitis, the inflammation of your blood vessels. You will see the increase in the size of this tunica media, thickening, hypertrophy of the tunica media will be seen. Okay, many cells in the blood vessels would be easily seen. You will see the histology in the U world also. Then comes the chronic rejection, which occurs after 6 months, up to the years. And you should know that predominantly humoral immunity is responsible for the chronic rejection. What gonna happen is there is a hypertrophy of the blood vessels gonna happen, and as a result, slowly the blood supply to that organ would be lost, and what you will get is the atrophy of the organ. In this scenario, in the hyperacute, there is a thrombosis. There is an instant loss of blood supply happening in this scenario, and that's why you're having this ischemia and necrosis. But in case of chronic rejection, because slowly the blood supply is gonna lose, what you will get is the atrophy, and you will get the fibrosis of the organ. So there's a proliferation of the vascular smooth muscles gonna happen, and as a result, the lumen of your blood vessels gonna go narrow, and as a result, you will get the atrophy of the organ. You will get the intestinal fibrosis, and depending upon the type of organ, you will get a different type of reactions. For example, in case of your lung, something known as a bronchiolitis obliterans is seen, in which your small bronchioles will be affected. And what's going to happen in your small bronchioles? You will see the fibrosis in the small bronchioles, and as a result, you will get the difficulty in the breathing. Okay, you will see that progressively your narrowing of your respiratory passage is going to happen. And in case of the kidney transplant, you will get the atrophy of the kidney. You will get the shrunken kidney. The crowding of the glomeruli would be seen. The fibrosis of the kidney would be seen. In the heart, you will get the accelerated atherosclerosis. Okay. And yeah, that's it. That's about the chronic graft rejection. Please remember the fact about this bronchiolitis obliterans, which affects your bronchioles, as the name suggests. Bronchiolitis, inflammation of the bronchioles would be there. The air passages, the small air passages would become very narrow. Okay. And then comes your graft versus host disease, which is a type 4 hypersensitivity reaction only. What happens is when you give, let's suppose you're doing a bone marrow transplant. So before doing a bone marrow transplant, you give a high dose of radiation to the patient, in which a transplant going to happen. And as a result, all of the lymphoid cells, all of the bone marrow cells would be removed from your bone marrow, because you know that the chemotherapy mainly affects all the rapidly dividing cells, and these cells are found in your bone marrow. So by giving the high dose of chemotherapy, you're destroying all of your bone marrow, and once the bone marrow is destroyed, you will remove the cells in the bloodstream of the host, and now you will transfer the new bone marrow to the patient. And because you have removed every single immune cell from the host, if the immune cells are remained in the transplanted bone marrow, what's going to happen? They will start reacting against the host cells, because all of the host cells are very foreign to the uh, to the graft, right? So what you will get is the graft versus host disease. The graft are actually mounting an immune response against the host. Okay, and why? Because host immunity is suppressed completely, because during a bone marrow transplant you need to completely remove the bone marrow of the host by giving him the high dose of radiation therapy, okay, or the chemotherapy. And you should know that there are some benefits of this syndrome also. First thing is because there are some viruses which become latent in your body, and if you remove your immune system completely, then you can expect a reactivation of these viruses, the reactivation syndromes. So if you have the the lymphocytes and the macrophages already formed against the graft organ, so they can protect you from these reactivation syndromes, right? But this is the first thing. And second is a graft versus tumor effect. If the tumor cells are still remaining inside your body, so when you transplant the bone marrow of the patient, what's going to happen is the normal cells in that you know in that bone marrow will attack the tumor cells, because they are foreign to them, right? So they will kill all the tumor cells. This is known as the graft versus tumor effect. So please remember it, the graft versus tumor effect. Okay. So how can you treat the graft versus host disease? You need to completely remove all the lymphocytes, all the macrophages, all the immune cells from the graft tissue. Just you need to keep remaining the bone marrow, but remove every single preformed lymphocytes, and that's how you can prevent this disease. But there are also some negative side effects of this thing also. If you remove the complete lymphocytes, the preformed lymphocytes from the patients, from the graft, then you won't get this graft versus tumor defect. Okay. And second thing, because because you do not have any preformed lymphocytes, then you cannot mount the effective immune response against the latent viruses. So what you can get is the reactivation syndromes. So two things: you will get you won't get a tumor the graft versus tumor effect, and you will get the increased viral infections, because you become the immunosuppressive after removing the bone marrow completely. Okay. And you should know this this is an example of type 4 hypersensitivity reaction, and so that they can ask you what other pathologies have the same pathogenesis as that of this graft versus host disease. So these are the primary biliary cholangitis, these are the candida test that you do, the tuberculosis, and that the contact dermatitis that you have are the same examples. Okay. So what are the symptoms? And not just a bone marrow transplant, if you do a liver transplant also, you will get the same graft versus host disease. So liver transplant mainly, and the bone marrow transplant, you will see the graft versus host disease, because these they are rich in the preformed lymphocytes, which is starting acting against the host cells. Then what are symptoms? The skin symptoms include some maculopapular rash. Then the liver symptoms, if you do a bone marrow transplant, then these preformed lymphocytes will start acting against the host lymphocytes. And what you will get is an increased LFT count. ALT, AST would be increased. And you will see an increased bilirubin. You will get the jaundice. You will get the hepatosplenomegaly. Okay, in the GI section. In the GI area, you will get the diarrhea, the weight loss, the abdominal pain, the nausea, the vomiting. So if you get a patient who recently have some kind of bone marrow transplant or the liver transplant, in case of liver transplant, you won't get to see the liver symptoms. Okay, you just get the skin symptoms and the GI symptoms. So if they give you a patient having the rash, the LFT, RFT very high, the hepatosplenomegaly, the nausea, diarrhea, vomiting, you will know that this must be a case of your graft versus host disease. Okay. Any doubt?
No.
Any doubt, guys? No?
No.
So please remember the timeline is very important. If the immediate reaction is happening, it must be the hyperacute type 2 hypersensitivity reaction. If the reaction happening before the 6 months, it would be the acute, and it is due to the CMI, cell-mediated immunity. If the reaction happening after 6 months, it must be the humoral response, and that's due to the loss of blood supply very slowly, you know. And if it is a type 4 hypersensitivity reaction, it must be the graft versus host disease. Okay. I think we should stop it here now. We will study to next day about